paper session. To chair this session, I would like to call upon neurosurgery in JP Hospital, Noida, with area of interest in minimally invasive spine surgery and endoscopic skull-base surgery. We welcome you, sir. Please note the presentation time is 7 minutes. Calling the first.
Good morning to all the dignitaries present here. So my topic today for the paper presentation is the correlation between the CT findings and neurosurgical intervention in mild traumatic brain injury patients with isolated subdural hematomas. So the traumatic brain injuries vary in severity with each severity category carrying a different risk for neurosurgical intervention. Despite this understanding, the most patients suffering a TBI with intracranial hemorrhage identified on CT scans of the head are treated equally in terms of requisite neurosurgical coverage, regardless of the severity of the injury, leading to inefficiencies in hospital resource utilization and potentially unnecessary inter-hospital transfers. So there are differences in the risk for neurosurgical intervention based on the specific type of ICH in the mild traumatic brain injury patients, that is the GCS between 13 to 15, yet management guidelines treat all the ICH equally. A question repeatedly posted in the TBI literature is whether a neurosurgical consultation or a requirement for a neurosurgical coverage is necessary for all patients with a mild traumatic brain injury with an ICH. So unfortunately, we do not have enough of an understanding of the risk for a neurosurgical intervention to create management guidelines addressing particular ICH types in patients with mild traumatic brain injury. So in order to better understand the risk, we must collect detailed information about each injury and assess the influence of each variable on the risk of neurosurgical intervention through predictive modeling. Because all ICH types in the mild traumatic brain injury population carry different physiological mechanisms and neurosurgical intervention rates, it is necessary to create a predictive model for each ICH type. So isolated subdural hematomas are a prime target for the creation of a predictive models for neurosurgical intervention because they are one of the most common ICH types in the mild traumatic brain injury population, account for 66 to 75% of all the neurosurgical procedures and have one of the highest neurosurgical intervention rates. So these are the Brain Trauma Foundation guidelines for the indications for surgery of an acute subdural hematomas. So they say that any subdural hematoma with a thickness greater than 10 millimeter or a midline shift of more than 5 millimeter should be on a CT scan should be surgically evacuated. And for the patients with GCS score less than 9, they have given a separate guideline. They should undergo ICP monitoring, and if a patient with a DCS less than 9, SDH less than 10, and midline shift less than 5, she or she should go under surgical evacuation of the lesion. If the GCS score decreases between the time of injury and hospital admission by 2 or more points, and if the patient is presented with asymmetric or fixed dilated pupils, or the ICP exceeds 20 millimeters of mercury. So what I want to emphasize is for the patients less than GCS score less than 9, they have given a separate guideline, but the rest of the patients, they have given a common guideline of thickness more than 10 and midline shift more than 5. So in a patient with a mild traumatic brain injury with GCS 13 to 15, if we have a SDH thickness more than 10 millimeter and the patient is having GCS 14 or 15 like, so sometimes we observe the patient and try to manage the patient conservatively. So if we can formulate a guideline for this particular group of patients with GCS 13 to 15, we can prevent the unnecessary inter-hospital transfers, neurosurgical consultations, and the surgical intervention for these group of patients. So the aim of this study was to find the correlation between quantitative CT findings and neurosurgical intervention in mild traumatic brain injury patients with isolated subdural hematomas. And the objective was to measure the length and thickness of the isolated subdural hematoma to analyze how isolated subdural hematomas are associated with the recommendation or necessity of a neurosurgeon to operate. So it was an observational study done at Trauma Center, SMS Medical College. A sample of 50 patients was included, and the study was completed in 1 year with effect from January 2023 to December 2023. The inclusion criteria was patients were included if they present with a mild traumatic brain injury with GCS score 13 to 15 and had a head CT positive for the subdural hematomas. The patient excluded were the patient having a coagulopathy on admission, they who did not have an acute hemorrhage on a CT at the admission, a hemorrhage other than SDH, and no radiological imaging or of hemorrhage at the admission, and only radiological imaging that was obtained after a neurosurgical procedure. So the results that we obtained were, there are 50 patients included in this study. Overall, the majority of the patients were 20 to 40 years old and male. The 90% of the patients had GCS scores, non-GCS.
The death in the conservative patients?
So, those patients, one of the patients got complicated with DVT, and then he had ARDS. And one of the patient, he had fallen GCS sudden, he had a seizure, and then he succumbed to the patient. So somehow not because they didn't, there was a drop in GCS, that the patient was operated, and that was he or she was included in the surgically operated group, intervention group.
So, okay, that's a nice paper. Any questions from the audience? Thank you.
Thank you, sir.
So, invite the next.
Now I request Dr. Kunal Singla to had a paper on the role of CT perfusion in predicting the neuropsychological outcome of the patient with the traumatic brain injury. And I will just request to be on time, because since he was the first speaker, so I hadn't stopped in earlier. Yeah, so just be on time.
I would request you to please stick to your time schedule,
Yes.
because we have a very important session at 8:30. We would want to finish.
Good morning, everyone. My name is Dr. Kunal Singla from Department of Neurosurgery at AIIMS Rishikesh. I'll be presenting for the role of CT perfusion in predicting the neuropsychological outcome in patients with traumatic brain injury. So we know the annual incidence of TBI worldwide has been 369 for 1 lakh people, as documented by the 2016 Global Burden of Disease. Mild to moderate DEI has good physical and neurological outcome, but the cognitive impairment may persist for months. And early detection of cognitive impairment is the key part in rehabilitation. So executive function consists of various schemes, that is planning, working memory, set shifting, inhibitory control, verbal fluency, and processing speed. It can be tested by various tests, but the major key point is to take the test that contains all the 7 key points of cognitive functions. So our aim was to assess the perfusion parameter in patients with mild to moderate head injuries and to compare the CT perfusion results with the neuropsychological outcomes at 3 months of follow-up. So it was a longitudinal observational analytical study from May 2022 to December 2023 with total 45 patients. The patients included were age more than 15 years, mild to moderate head injury, normal NCCT head, or features suggestive of DAI with minimal class 8th education. The exclusion criteria were age less than 15 years, history of psychiatric disease, mental retardation, or any addiction to alcohol or drugs, or patient having hemodynamic instability at admission. So after initial assessment, CT perfusion was done within next 48 hours. It was calculating CBF, MTT, that is the mean transit time, in bilateral, frontal, parietal, temporal, and occipital lobes. All patients were managed as per the standard treatment protocol, and after discharge, the neuropsychological tests were done at 3 months of follow-up, consisting of all these 4 tests, that is the digit span test, TMT-A-B, Stroop test, A-B-C, and the animal fluency test. So the patients were having a mean age of 34 years with a 82% of males, and a mild head injury of 53% and moderate head injury of 46%. The most common mode of injury was RTA followed by fall from height. The CT perfusion pattern, the patients having hypoperfusion, out of the all 45 patients, there were most common hypoperfusion noted in the frontal lobe. That is 25 patients in the right side and 24 patients on the left side. And the least common was in the occipital lobe, that is 16 and 12. Now coming to the results. As we know, the frontal lobe has 20, we compared the cognitive function of the patients with low perfusion with the patients having normal perfusion. after 3 months post-trauma, the patients with low perfusion in frontal lobe had statistically significant difference in cognitive functions of attention, flexibility, inhibitory control, as well as patients with normal perfusion perform better in Stroop A, B, and C test as compared to patients with low perfusion. In parietal lobe, we have seen that patients with normal perfusion has better working memory as compared to patients with low perfusion. Similarly, on the left side, we have seen frontal lobe having 24 patients having hypoperfusion. While comparing patients with low perfusion and normal perfusion parameter on the left side, it was observed that patients with low perfusion on the left frontal lobe had statistically significant deficits in all domains of cognitive function, be it attention, planning, motor performance, cognitive flexibility, verbal fluency, or working memory. Similarly, in parietal lobe, patients with hypoperfusion had statistically significant difference in mostly the attention and the memory. And the temporal lobe, similarly in the left side temporal lobe, had statistically significant difference in the cognitive functions at 3 months of follow-up. But no difference was seen in the occipital lobe perfusion deficits, either on the right side or on the left side. Now, next parameter we compared was the mean transient time. The mean transient time data was divided into 3 categories, that is the decreased mean transient time, normal, and the increased mean transient time. While comparing cognitive function of patients with decreased mean transient time to normal mean transient time on the right side, patients with lower MTT in frontal, temporal, and occipital lobe had better planning and motor function as tested by TMT A and B, and attention as tested by the Stroop test. And these data are statistically significant, or they are near significant with p-value between 0.06 to 0.09. While testing MTT on the right side, it was seen that patients comparing with decreased MTT to normal MTT, similar results were obtained as patients with low MTT performed better in all domains of cognitive function and all the tests that was tested at 3 months as compared to patients with increased MTT. While comparing patients with normal MTT to increased MTT, the patients with increased MTT performed poor. Now, while comparing these tests on the left side, we have seen that patients with low MTT in the parietal, temporal, and occipital lobe had good performance, but no difference was seen in the frontal lobe mean transient time difference. And similarly, comparing the decreased mean transient time with the increased mean transient time, it was seen that patients with decreased mean transient time in frontal, temporal, and occipital lobe had difference in their memory as tested by the digit forward backward test and the attention, Stroop test, and TMT A test and B test. Comparing the normal MTT with the increased MTT on the left side, it had similar results, that is the increased MTT patients performed significantly poor in cognitive test at 3 months of post-trauma. Now, as per discussion, this is the first study in literature that has analyzed the acute cerebral perfusion in relation to neuropsychological outcomes at 3 months follow-up in patients with mild and moderate TBI. It is well known that cognitive deficits can be correlated with size and location of the focal or diffuse lesions that are seen on the conventional CTs or MR imaging. Multiple studies has been done in the past that has concluded that hypoperfusion in the frontal and temporal lobe is most common, and as well as in the basal ganglion thalami, and most of these studies are in the severe TBI and or in patients with abnormalities in conventional CTs. Just 30 seconds. These are few studies that has compared the severe TBI patients and used the CT perfusion in acute phase of TBI, and none of them has compared the psychological outcome. Only thing compared was the functional outcome with Glasgow Coma Scale extended. These studies only single study that had performed CT perfusion in and compared the neuropsychological outcome. They have taken only 18 patients with mild head injury, and they have divided the psychological outcomes into dichotomized, that is the normal and the abnormal. But as we know in the psychological studies, we can't divide just the normal or abnormal. It can be low or it can be relatively low or relatively normal. So my conclusion was the executive function at 3 months during follow-up can be predicted by difference in cerebral perfusion at admission in mild and moderate TBI. Patients with perfusion deficits, especially in left frontal and temporal lobe, had poor performance in neuropsychological assessment, and in MTT study, lesser the MTT, better the neuropsychological outcome. The strength was, it was the first study and it had correlated neuropsychological outcome in patients with normal conventional CT. The only limitation was the small sample size, the single strength center, and the short-term follow-up. Thank you.
I think we will take the questions later. May I request the next speaker, please? Dr. Hem Shah for the decompressive craniectomy versus the cysternostomy in the traumatic brain injury.
Please stick to your time, otherwise we'll have to, cut.
Yeah, sure, sir. Good morning, everyone, respected faculty and delegates. I am presenting a topic on decompression cranectomy versus cysternostomy in traumatic brain injury, conducting a randomized control trial. This is my thesis topic under Professor S.S. Kale at AIIMS Delhi. So as you all know, the traumatic brain injury is a big public health burden in India, with around 40.5% of all RTAs being TBI patients. And this significantly affect the males more than females, and they have a 24.6% of in-hospital mortality rate. And for surgical management of traumatic brain injuries, decompressive cranectomy obviously currently is the standard of choice. So cysternostomy actually is an emerging technique which refers to opening of the basal cisterns in order to release the CSF. It has been hypothesized that it causes reversal of CSF shift edema and also provides better outcomes in terms of ICU stay, hospital stay, and better Glasgow outcome stay, and reduce ventilator dependence in TBI patients when compared to decompressive alone. As of today, there are 2 randomized controlled trials that have been published from India for comparing both decompression and cysternostomy patients. The first one is by Dr. Ramesh Chandra et al., which had a sample size of 50 patients. The second one is by Kumari et al., which had a sample size of 100 patients. Both of them had slight differences in the technique and their criteria. For example, in S. Kumari et al., they actually attempted placing the bone flap back in the same sitting, and they also had a small subsection of patients in which they had done that. Whereas in Ramesh Chandra et al., they did not replace the bone flap back. They just did the cysternostomy and compared it with the decompression group. So both of them actually found out that cysternostomy patients had actually an increased outcome, and they had a better outcome in terms of ventilatory support and ICU stay and hospital stay, and also better ICP outcomes in the cysternostomy patients was found out by these studies. So our study also is a parallel arm RCT, which has been designed and is being conducted at the JPNATC at AIIMS Delhi. The randomization is done at the casualty level when the patients actually reach the casualty, and it is done using a sealed envelope technique. So the target sample size in our study is also 100 patients, 50 in each arm. So our inclusion criteria actually include patients who have a presenting with a GCS of more than 3, and all cases of traumatic SDH, SH, and parenchymal contusions which are causing brain mass edema and mass effect, and which are candidates for surgical intervention. Whereas the exclusion criteria include anyone with any M1 patients with any absent brainstem reflexes, and any non-traumatic causes of SDH or SH. And pure EDH causing mass effect is also not a part of our study. So the primary outcome is ICP values, which are measured both intraoperatively and postoperatively. And the secondary outcomes are actually the duration of ventilator dependence, the ICU stay, the hospital stay, and whether the patient was dependent on the ventilator on post-op day 5 and 10, and the extended Glasgow outcome score at discharge and 3 and 6 month follow-up. There is also a radiological outcome in terms of the AP and the transverse diameter of the basal cisterns as seen on pre-op and post-op CT scans, and 30-day mortality as well. So the participant flow that we use are when the patient comes to the casualty, we take an informed consent from the attendants, and we explain to them about both the procedures. And once the consent is given, we place an ICP monitor pre-operatively, either in the OT before the incision or in the casualty itself. So we get the opening ICP, and then we randomize the patient, and we do either the decompression or the decompression plus basal cysternostomy. Again, there is an intraoperative decision involved whether to replace the bone flap back, and it depends depends upon the operating surgeon's preference. If the surgeon finds that there is a significant reduction in the brain edema and the swelling, and the bone flap can be replaced safely, then the bone flap is replaced in the same setting. In that case, that would be a cystonostomy alone. Whereas in the other cases, it would be a decompression plus cystonostomy. And there is also a provision for a crossover in case the patient has been allotted to the cystonostomy group, but the cystonostomy cannot be carried out in case of extreme swelling or edema of the patients. Then the patient can be crossed over to the decompression group and analyzed as such. So the permissions were obtained in both ethics and the CTRI approval were obtained. So the provisional results, the study is still ongoing. The patients that we recruited, we recruited 7 in the decompression and 6 in the cystonostomy group. There was no significant difference in terms of the mean age, the presenting GCS, or the opening ICP in both the groups. So there was the time from presentation to incision was slightly higher in the decompression group and lower in the cystonostomy group, but again, it was not significant. The one significant finding that we found out was that the surgery duration was much more in the cystonostomy group as compared to the decompressive group. And the blood loss was also on the higher side when in the cystonostomy group. The post-procedural ICP, and this refers to the immediate post-procedural ICP, which means that during the shifting after closure, the ICP values that were measured, that is the post-procedural ICP, and they were slightly higher in the cystonostomy group. But again, at 24 hours post-op, the ICP was reduced in the cystonostomy group as compared to the decompressive group. However, in contrast to the studies that are already published, we found a slightly higher duration of stay in the ICU and the hospital in the cystonostomy group as compared to the decompressive group, and this was in contrast to the findings that were published earlier. So the hospital stay again was on the higher side in the cystonostomy group, and however the GCS and the Glasgow outcome score and the extended Glasgow outcome score were better in the cystonostomy group as compared to the decompressive group. In both the groups, there was a mortality, 2 patients expired in both the groups due to different causes, and on post-op day 5, as you can see, the ventilator dependence was again a higher percentage in the cystonostomy group when you compare to the decompressive group. So in conclusion, if I can conclude the findings, this is still a study under process. This is an interim analysis. It is still ongoing. But cystonostomy represents an emerging technique that has the potential of offering improved outcomes in patients with TBI. However, it is difficult to accept widespread. It is difficult because it requires microsurgical instruments and capabilities of skull-based technique expertise, and it is required in operating at the patients, and which is not always available everywhere at all the times, especially in trauma cases because they mostly appear at night and you do not have the expertise available at all times. So the need of the hour obviously is to increase the number of RCTs that are being done in this regards, as well as multicentric RCTs, so that we can actually gather more plausible evidence to actually include or exclude from the guidelines that are available. Thank you.
It's very good. How many patients do you have in your study? How many patients?
So the sample size is 100. It is still ongoing. It has still been recruited as of now. We started recruiting only 3 months ago, so it is still ongoing.
No, in this study, how many patients have you taken right now?
13.
Results.
13.
13.
Yeah, 1-3.
Okay.
Yeah.
So thank you.
I have one question for you, but we have seen that the ICP reduce was better in the cystostomy.
Yeah.
After 24 hours.
After 24
Immediate it was less.
Yes.
But then once the cause is like we have to take care of the ICP. So why the stay was prolonged in the cystostomy group? Like ultimately the main aim was to reduce the ICP, and if the ICP reduction was better in the cystostomy after 24 hours, so.
Sir, I think the sample size right now is not enough to conclude any about it.
Okay.
So I think the patients had a different profile in each group. They were significantly different from each other. Some patients in the cystostomy group had a significantly lower GCS at presentation. Okay. So the outcome was determined by that. So we have to prolong the stay, sir. Yeah. Thank you.
Now I request the next speaker, Dr. Harnoor M. Kamik, Management of the Traumatic CSF Leak.
Good morning, everyone. I'll be speaking about the management of traumatic cerebrospinal fluid leaks. Our experience at a Singer Tertiary Care Center, Santokh Bad Urology Hospital, with a transcranial repair of these leaks over the last year. So, Traumatic cerebrospinal fluid leaks are a common occurrence following head trauma. Most of the cases that we see, about 96%, have some origin in some sort of trauma. The rest may be spontaneous. Out of these, 80% of the cases are caused by craniofacial trauma, and some may be severe enough to not find a line to repair. So there may be multiple complications like meningitis or recurrent leaks after this. So there are significant challenges that we face in terms of diagnosis and management. And another thing is that at the time of any surgery in the skull base, there is an iatrogenic damage in which we can cause CSF leaks, which again goes to the traumatic group. So, as per the clinical presentation, the most common presentation is an intermittent watery discharge, as of what we have also found. Then we can have a reservoir sign in which there's a collection and then the CSF gets draining. We can have patients presenting with meningismus. Delayed presentation may be due to tissue necrosis or wound contraction. 12 to 39% of cases of head trauma have leakage of CSF, in which 23% have some involvement of the cribriform plate or the fovea ethmoideus, and 30% have some fractures associated with the frontal sinus or the sphenoid sinus, which may run up to the base of the skull. So in our experience, we are reviewing 33 cases, out of which 15 were operated transcranially. Their ages ranged from 1 year to 77 years. That is, 3 patients that we had in this group were under the age of 7 years, but all of these were in the spontaneously healing group. Then we had male and female comparison, in which males were on 27 as compared to 6 in the series of 33, which is a gross difference, which may be attributed to the nature of traffic accidents again, though there are no other changes that have a gender predilection. Most presented acutely after trauma with CSF leak. 6 patients out of these presented with CSF otorrhea, and all of those were self-limiting. The rest presented with CSF rhinorrhea or leak of CSF from the main lumen line. Traumatic leak sites were identified intraoperatively and may include large defects, both bony and dural, as we found in our experience. So in the management, the surgical intervention remains the mainstay in any case of traumatic CSF leak, which may be primary repair of the leak, external drainage, which may buy us time or which may be needed after we repair and there's still a continuing leak. And then we have endoscopic repair. Though both the kind of repairs, open as well as endoscopic, are done at our center, in these we have just included the transcranial ones just to compare whether extradural or intradural repairs are better, or whether a sandwich technique that we most often use these days gives a added advantage over the two. Endoscopic repairs are usually undertaken with us for spontaneous leaks and may be used in any kind of traumatic leak where we do not have a major craniofacial damage already. So leaks in traumatic patients may not heal spontaneously due to depressed fractures, bony spicules, dura stripped or trapped at the edges of a fracture, or herniation of brain. And the most dreaded complication is meningitis. There is avulsion of the olfactory fibrils, which may occur even without a visible cribriform plate fracture. Due to all these cases, all these causes, we prefer a transcranial approach wherever major trauma is involved. In our case, we've used pericranium glue most commonly, along with a dura patch or a pericranium patch, and we've used bone cement in some cases and duragen in some cases. Most cases were acute cases with facial fractures, and the approach most commonly used was either intradural or intradural plus extradural, and the site of leak usually had cribriform plate involved, and there were 2 which had a running the basal skull fracture up to the base of the sphenoid. So the synopsis of these patients, the ages ranged from 18 to 75 years. 4 out of 15 had delayed presentation, and 2 had to be treated for meningitis before surgery. 10 patients were treated with intradural repair or combination of intradural and extradural repair, also known as the sandwich technique. Prophylactic antibiotics were given in all for 5 days and continued if required. No postoperative infections resulted from the use of any prosthetic material in these cases. So various materials used were as here: bone cement, dura patch or G patch as we know it, duragen, pericranium patch along with Surgicel. These are the two things that we prefer for the intradural part, and also for covering the skull base and the cribriform area with a material which actually holds. Then fibrin glue is there. There is we can see an intradural repair. This is the same patient in which there were multiple areas of rents, and we did a sandwich technique. So we have a pericranial patch buttressed with Surgicel. We have a pericranial patch and Surgicel, and dural defect with extradural repair on some parts. So in our experience of 15 cases treated transcranially, their buttressing was done with all of these things. The sinuses were packed with betadine gel foam and exteriorized, and lumbar drain was prophylactically placed in 2 patients. 1 case of postoperative leak was managed conservatively and healed. 2 patients of meningitis were treated, and the intracranial intradural approach allowed a better exposure of the anterior fossa, visualizing both the sphenoid wings, a better view of where the fracture was going, better view of the tears, both cribriform fossae and both the orbital grooves. So the take-home message in our series is that the transcranial approach is a better approach for large anterior cranial fossa defects, both dural and bony, as they allow better visualization and better anatomical repair. All efforts must be made to prevent the olfactory tracts as far as possible and fibrils from further injury in the region, and also maintaining whatever is left for better functional recovery after the surgery. And intradural approach is preferred for repair, as the dural tears are much more common in the extradural approach, and the defect cannot be reliably sealed externally with brain tissue herniating into the wound. Thank you.
So, a nice paper. Can I ask you one question? These operated patients, were they primarily operated for the CSF leaks or the head injury per se?
Sir, initially, if we have a CSF rhinorrhea, we tend to manage initially with conservative methods. But if there is a CSF from the wound, we take up the patient. Usually, there is a depressed fracture, and there is an indication already to operate. Some of the patients, we found the leaks intraoperatively because there were large tears after we removed the contused part of the brain.
So, if there is a depressed fracture and you operated only because there was a CSF leak, or you were primarily
for this fracture, sir, and then because there were spicules, we had to go in for the
repair. Had to go in. So yes, how many patients out of these were those that you would have otherwise treated conservatively, yes, but you had to operate because there was a CSF leak, suppose a CSF rhinorrhea or something?
So the 4 patients that I've mentioned, they had a continued leak, and the others were initially operated because of the trauma involved. So 11 had trauma and depressed fractures, or some we had the spicule insinuating into the dura, and then we had to remove it. Usually in these cases, an extradural repair or a primary repair is enough alone. But in the delayed part or in major facial injuries, we tend to go intradurally.
Okay. So any questions? Jatin, would you like to make a comment? Good.
Thank you, sir. Thank you.
Okay.
I was surprised that you never use a facial autograft. Most of the time it is used, but
yes,
you can use. It's just not very important. Another thing was, if only like CSF leak was there, then did you wait it for like 7-10 days or 15 days, and after you have taken a delayed one, or like immediately you try to intervene?
Sir, in 4 of these we did that. We tried, and most of them actually healed spontaneously, but the ones who did not were included, sir.
Thank you all speakers. Thank you Dr. Dinesh and Dr. Manish for chairing the session. Requesting you all to please escort yourselves to Hall A for the orations, please. We'll resume our session in Hall B at 10 a.m. Thank you. Welcoming you, ma'am. She is Senior Professor of Anesthesia in SMS Medical College and Hospital, Jaipur. Her field of interest is in neuroanesthesia and has over 30 paper publications. Welcoming you, ma'am. Our second chairperson for the session is Dr. Matthew Joseph, Professor of Neurosurgery from Department of Neurological Sciences, CMC Vellore. Also welcoming Dr. Sunita Sharma, Associate Professor in Department of Neuroanesthesia, Mahatma Gandhi Medical College, Jaipur. Welcome, ma'am. Please note the presentation time is strictly 10 minutes.
Good morning, everybody. At the outset, I congratulate Dr. Sinha for organizing an international conference on recent advances in neurotraumatology and giving us the opportunity to chair the session of neurocritical care. We have eminent speakers in this session. First of all, I invite Dr. Sudhir V, ultrasound in critical care of traumatic brain injury, transcranial Doppler, ocular ultrasound and diagnosis of DVT. Dr. Sudhir.
Good morning, all of you. Good morning to the chairpersons, and thanks to the organizers for having us here from NIMHANS. So today, for the next 10 minutes, we are going to see how one machine has changed critical care over the years. So this was ultrasound many years back when I did my cardiac fellowship or neuro fellowship. The ultrasound was somewhere in the corner, used by only the radiologists whenever we required, or a cardiologist whenever there was a cardiac echo. So now we have reached this position. Everything is in our hands. How one machine can change the scenario. So the first use of ultrasound in the critical care is transcranial Doppler when it comes to neurocritical care. So we use this 2 megahertz probe. I use standalone machine, but you can use TCD in your ultrasound machine which is present in the ICU using a 2 megahertz cardiac probe. So there are 4 areas of interest: the transorbital, transtemporal, transcervical, and transforaminal approaches to study the vessels of the base of the brain. Most commonly, we use the transtemporal approach to study the middle cerebral artery, which is of importance for us for all clinical diagnosis and management. So once you put the probe on the transtemporal probe, this is what you are going to see at the mesencephalus level. The brainstem at the mesencephalic level, which appears as a hypoiconic zone, like a Mickey Mouse sign or butterfly sign. Once you recognize this, you put on your color Doppler and all the vessels will start forming around the base of the brain. So this is the circle. Very rare video of where you can get a complete circle of Willis. You can see here I am insinuating from the ipsilateral side. This is your ipsilateral middle cerebral artery, which goes like this, and this is the ipsilateral anterior cerebral artery. This is the contralateral anterocerebral artery. This is the posterior cerebral artery over here. So contralateral MCA will form here. So this is a complete circle which you can visualize actually with the ultrasound using a 2 megahertz probe. Each artery which you can be interrogated. So you can appreciate the entire circle forming here. Very, very rare video where you can appreciate the entire circle. So this is where we interrogated the middle cerebral artery. You will get a middle cerebral artery, the first artery to get from the area of transtemporal insertion at a depth of 40 to 45 millimeters. So once you insonate, you put on the Doppler and the waves start to form. So you freeze this, go to calculations and find whatever calculations you want to see with respect to this particular envelope. So this is the MCA which is commonly interrogated in the critical care unit. Now, what is the most important use of TCD? Two uses of TCD. One is diagnosis of brain death, very early diagnosis before even the clinical parameters set in. And the second use is to differentiate between hyperemia and vasospasm, which if time permits, we'll see later. So this is a video of a patient with severe intracranial hypertension with brain death. As you can see here, MCA is interrogated. So this is the baseline. Whatever goes above is systole, whatever goes down below is diastole. So you can see that a spike in the systole and a spike in the diastole. That means blood is trying to go across the MCA. It is not able to go, it is coming back. The brain is so tight. This is what we call as reverberation phenomenon, or a sign of brain death or cessation of flow distal to the MCA. So this is what we use in the critical care to diagnose early diagnosis of brain death. As you see, there is a phenomenon. The systolic stump changes slowly, and there is, when this is a final picture, there is gradually changes in the systolic flow is seen, and when we reach this is irreversible brain death. So this is again severe rise in intracausal pressure. As you can see here, we can just see a chink of blood forming when there is across the MCA. You can see just spikes. That means the ICP is so severe that blood is not able to force through the MCA. That's the skull is so tightly closed. The second use of ultrasound is to understand the optic nerve sheath diameter, a surrogate marker of rise in intracranial pressure. So your linear probe is used, 4 to 12 megahertz probe, which comes with the standard ultrasound machine. So you insonate the eye from the globe down. So this is the optic disc, and this is the optic nerve. So across the optic nerve, 3 millimeters down from the optic disc will give you the optic nerve sheath diameter. Any diameter up to 4 to 5 mm is normal. Anything above this, that is considered abnormal. If the ICP, if the optic nerve sheath, I'll show you next, if it goes beyond 5, this is how we measure the optic nerve sheath diameter. The optic disc, from there we come down 3 millimeters down and measure across from border to border. That will give you the optic nerve sheath diameter. So border to border will give you the optic nerve sheath diameter. In this case, it was around 0.5, that is 5 millimeters. So this is an example. So optic nerve sheath diameter was 4.2 when the patient was admitted here. On day 3, the diameter rose up to 7.8. The ICP roughly translates to around 25 millimeters of mercury. This is the early indication of rise in ICP. It can be correlated with your traumatic, the invasive ICP if you have. The third use is to diagnose DVT in patients in ICU. Head injury patients stay for a long time, and it's a procoagulant injury, so there is a chance of DVT in the lower limbs. So how do we go about diagnosing this DVT? So this is the normal saphenofemoral junction at the level of inguinal ligament using the 4 to 12 megahertz linear probe. You can see this is the artery, this is the saphenofemoral venous complex. As we compress, the test is compressibility. As we compress, the vein is going to disappear. The artery remains the same. That is a Doppler showing the continuous flow in the vein and a pulsatile flow in the artery. See here, if we apply pressure, the vein can be compressed. That's an indication that the vein is patent enough. There is no thrombus in the vein. So how do we diagnose a thrombus? So this is a video of a thrombus. As we can see, if we compress at the level of inguinal you image and then you try to compress the vein is not compressible. So you can see a thrombus formed here. So the whole thing is formed by thrombus, both the saphenous and the femoral vein. So compressibility test, if it fails, that means there is a thrombus in the femoral vein. So you put on the Doppler. So there is a nice Doppler in the artery. There is no blood flow in the vein at all. The vein is completely occluded. This gives an indication that there is a deep venous thrombus which has set in the vein. So next confirmation, you put on the Doppler. As you put on the Doppler across the artery, you can see a nice flow. As you come towards the vein, as you turn towards the vein, there is absolutely no flow in the vein. This indicates that the vein is cut off from circulation. So there is a thrombus there. So then we come down and see how long the thrombus has extended. We come to the popliteal system. So as we insolate from below the knee, so this is the artery and this is the vein which you can see. So vein is compressible. So there is no thrombus in this particular popliteal system. This is a video of a clot. So you can see here that this is not compressible even on applying compression, the force. So this is the artery, the down below, and this is the vein. So here we don't see any flow at all. There is flow in the artery, there is no flow in the vein. That indicates the popliteal system is also involved. This is an old popliteal clot. So old clot needs to they tend to organize and they become translucent or hypoechoic. So here you can see this is a old organized clot. This is the artery. There is no movement on compression. There is no compressibility, but it looks as if it looks like a normal vein. So this is a old clot. So one last use of TCD, that ultrasound as used by TCD mode. So Lindegard ratio to differentiate between if there is a vasospasm or hyperemia. So we interrogate the middle cerebral artery and get a nice envelope, Doppler across, and whichever is the best envelope, you try to interrogate that and put your calculations and map the velocity. You can see here mean velocity is 229, and then we move ahead and interrogate the ipsilateral extracranial carotid artery. So Doppler again and measure it. So this is the formula, MCA by ICA flow velocities. If it's greater than 6, it is severe vasospasm. Anything below 3 is hyperemia, more than 3 vasospasm, more than 6 is severe vasospasm. So this is the brief introduction of ultrasound, how it has changed over years and how it is integral in neurocritical care these days. Thank you very much.
Thank you, Doctor, for finishing well within time. And we are really thankful to these recent tools which have been provided to us for early diagnosis and then treating the cause of these in prolonged the patients of this traumatic brain injury who remain in the ICUs.
Yeah.
We'll have the discussions afterwards.
Thank you.
Thank you.
Thank you, Doctor.
PhD, after doing MD and DM in neuroanesthesia, he has also done PhD, and he is at present head of the Department of Neuroanesthesia and Neurocritical Care in NIMHANS, Bangalore. Over to you, Dr. Sri Ganesh.
Thank you very much, madam, for the introduction. At the outset, let me thank the organizers for giving me the opportunity to be amongst the neurotrauma and neurosurgical community. I bring greetings from NIMHANS, and in the next 10 minutes, I will be speaking on analgo sedation in the ICU for acute traumatic brain injury. So I'll be covering 3 aspects. One, why analgo sedation is important in patients with traumatic brain injury. And then I will discuss how to assess pain, agitation, and delirium, which are critical components in the ICU. And lastly, what management options we have to treat this. So the need for analgo sedation is because of these 3 reasons. One is the pain. Patients with traumatic brain injury have significant tissue injury, and that is often followed by a surgical trauma. All these can lead to pain in the intensive care unit. Apart from this, there are several aspects of care in the ICU, such as positioning, tracheal suctioning, etc., which amount to significant nociception as well. Then certain procedures such as central venous access, peripheral venous access, endotracheal intubation, all these are again a painful stimuli. Apart from this, patients can be agitated because of the traumatic brain injury associated with hypoxia, hypocarbia, etc. And then certain maneuvers such as physical restraints, inability to communicate, ventilator dysynchrony, these can also lead to agitation in these patients. And together, pain, agitation, and trauma that is associated with traumatic brain injury can lead to delirium. And if this delirium incidence increases in ICU, if patients have pre-existing impairment, comorbidities, metabolic disturbances, and also if there is sudden withdrawal manifesting because of alcohol withdrawal or withdrawal of sedation. Now, common scales that are used to assess the level of sedation in the ICU in patients with TBI include Richmond Agitation Sedation Scale scores and the Riker Sedation Agitation Scale. The Richmond Agitation Sedation Scale ranges from -5 to +4, with -5 being unarousable and +4 being combative, and 0 being a normal patient who is alert and calm. Whereas with the Riker Sedation Agitation Scale, 1 is unarousable and 7 is the maximum score, that is for dangerous agitation, with 4 being a normal, calm, cooperative patient. Sometimes these scales are difficult to implement, so we need objective tools which are mostly EEG based or process EEG based. These not only help in assessing the depth of consciousness but also help in titrating the level of sedation, including maintenance and weaning from sedation. Next is assessment of pain in TBI patients in the ICU. We have two common scoring systems. One is the behavioral pain score, and the second one is critical care pain observation tool. The BPS has 3 components: facial expression, movement of the upper limbs, and compliance with the ventilation in intubated patients and vocalization in non-intubated patients. Here the maximum score is 12, with 3 being the lowest, and any score more than 6 is considered to be a nociceptive stimulus or a painful condition. The CPOT has another component added, that is muscle tension, and here the maximum score is 2, and so the total score is 8, and any score more than 2 is considered as a painful status. Again, we have some objective tools to assess pain in the ICU where CPOT and BPS cannot be or reliably used. Some of them are a pipilometer, wherein you stimulate continuously the cutaneous fibers using tetanic stimulation, and depending on the current required from 10 milliamperes to 60 milliamperes, you get a change in pupillary diameter. A more than 13% increase in pupillary diameter from baseline is suggestive of painful stimulus. Then we have analgesia nociception index. Here, any value more than 50 is considered painful, and similarly surgical pleth index, any value more than 50 is considered painful. This is mostly used in the intraoperative period, but ANI pipilometer can be used in the intensive care unit. Then we have nociception level index, again takes into account 3 parameters. One is the heart rate, the second one is the skin conductance, and it also takes into account the plethysmographic change because of the sympathetic activity. Together it gives a single numerical value ranging from 0 to 100, with more than 50 suggestive of painful condition. And this is a skin conduction altimeter, where you can, whenever there is a painful stimulus or nociception, there is increase in sympathetic activation, which results in perspiration and change in the cutaneous conduction. And this can be captured using this algesimeter. The last one is slightly different because all these parameters are derived from the autonomic nervous system, sympathetic parasympathetic imbalance, whereas Q-Nox is derived from the changes in the EEG. Basically, it also incorporates depth of anesthesia and also the measuring analgesia as well. So together it gives a score. The next is assessment of delirium in TBI. It's important to assess all patients in ICU for delirium. And there are 4 components: acute change or fluctuating course in mental status, inattention, RASS level or level of consciousness, and disorganized thinking. You need to assess the sedation level first and then proceed with performing the CAM ICU test. So coming to management, we all are familiar with these drugs. Propofol is an anesthetic agent used for sedation in the ICU, easy to titrate. The contact sensitive half-life is less than 20 minutes. So even after giving for 24 hours, patient can wake up within 20 minutes after this infusion. Dose is mentioned here, 1 to 5 milligram per kg per hour, titrated to the desired level of consciousness or sedation. Barbiturates is less used currently, but it's good or effective in patients with post-traumatic seizures. And when propofol cannot be used more than 24 hours, barbiturates may be a good option. But remember that both these can produce hemodynamic compromise, which is not seen so much with midazolam infusion, and so midazolam is preferred in most ICUs in the peripheries. Alternative to these are 2 other agents: dexmedetomidine, which is alpha-2 agonist, the dose 0.2 to 1 microgram per kg per hour, with or without bolus dose. The advantage of dexmedetomidine is it also provides some degree of analgesia, and second, it does not suppress respiration. But the disadvantage is it produces bradycardia, which can be difficult because it masks any change in the intracranial pressure. Ketamine is another agent which was out of favor in traumatic brain injury because it was considered to increase the ICP, but recent studies have shown that in fact it is advantageous because it has several neuroprotective properties, and it is used in traumatic brain injury as well. Non-pharmacological methods which can complement pharmacological sedation includes music which is preferred by the family or which the patient is to like, or lighting, noise levels, presence of family members. All these should be complementary to the pharmacological sedation that we use. It also reduces the requirement of sedation in these patients. Coming to analgesia, the most common group that is used is opioids because they are potent analgesics. Most commonly used is either fentanyl or morphine. Ketamine and dexmedetomidine, as I mentioned, apart from analgesia, they also produce sedation. So it can be advantageous in that way. Ketamine maintains the hemodynamic status better than other agents. And dexmedetomidine, as I mentioned, in low doses is used for analgesia and sedation as well. Apart from this, paracetamol should be given for all patients with traumatic brain injury because it is simple, effective, and does not have major side effects. NSAIDs can be used if required in these patients as well. Patients with TBI often have extracranial injuries such as long bone fractures or rib fracture, where loco-regional analgesia is very important and it provides more effective pain relief than systemic analgesia that I mentioned above. This is a slide summarizing various sedative and analgesic drugs, their mechanism of action, and possible risks and benefits in these patients. The intracranial profile of most of these agents is favorable, that it reduces the ICP, it maintains cerebral metabolism, and also decreases cerebral perfusion, cerebral blood flow. Management of delirium is required only when analgesia and sedation are taken care of. Most often, non-pharmacological interventions are sufficient once analgesia and sedation is taken care of. But however, sometimes we do need certain pharmacological agents like antipsychotics such as haloperidol to reverse or treat delirium in the ICU. Neuromuscular blockade is generally not used along with analgesedation, but sometimes it is required in the early phase to facilitate synchrony with the ventilation. And when there is lung injury, that is acute lung injury or ARDS, when hypoxia, hypercarbia is common and you need to sustain a desired level of ventilator parameters, you need to use neuromuscular blocking. Here, short-acting agents are preferable such as atracurium, and you should use it the shortest possible duration required. Advantages of analgesedation: control of ICP, metabolism is better managed, seizure prevention, reduces cerebral edema, facilitates ventilation, and oxygen and carbon dioxide management. Remember that hypercarbia and hypocarbia are both deleterious in injured brain, and sedation helps in managing this better. It also reduces systemic and neuroinflammation, manages sympathetic activation. One common problem, though rare, is problematic is chronic headache or post-traumatic pain. Early analgesedation in the acute phase reduces the occurrence of chronic headache. And lastly, analgesedation helps in facilitating invasive procedures and ICU care. But there are also disadvantages of analgesedation. Most important and worrisome is the difficulty in assessing neurological status in these patients. But there are alternatives such as CT scan, which is portable and available in the ICU, ICP monitoring, and use of non-invasive, which Dr. Sudhir mentioned, optic nerve sheath diameter and TCD can be used to assess neurological function when sedation is used. Hypotension, cardiac instability are side effects requiring vasopressors when used large quantities to sedate the patient. It also results in prolonged awakening, delayed ambulation, longer ventilation and ICU stay, and withdrawal symptoms. So, early implementation of analgesedation, especially with analgesia first approach, where opioids and multimodal opioid sparing adjuvants are used. Sedation use minimal and targeted, and early mobilization, sleep promotion, environmental modulation, family engagement is required to reduce pain, anxiety, agitation, delirium, and immobility. So, analgesedation is an important care element for management of patients with traumatic brain injury in the intensive care unit. The choice of agents, timing, duration can be individualized as per the need of the patient, and multimodal approach is always better. Whenever you use analgesia sedation, it is advisable to use appropriate monitoring tools to titrate analgesics better. Thank you very much for your patient listening.
Thank you so much.
Thank you.
And we will take questions later on.
Sure. Thank you.
Now I invite Dr. Priya from Jaipur to talk on the anti-epileptic treatment in traumatic brain injury. Head of the department in neurology in SDMH Hospital, Jaipur.
Very good morning to all of you. At the outset, I would like to thank V.D. Sinha sir for giving me this opportunity to present my views about the usage of anti-epileptic drugs in traumatic brain injury. Traumatic brain injury is one of the commonest presentations to the emergency department and is associated with seizures beginning soon after the onset of the injury, and they continue to occur till late in the course of the disease. The occurrence of seizures at different points of time reflects the different changes in the brain and the potential targets for anti-epileptic therapy. The use of anti-epileptic drugs to treat patients who have developed a post-traumatic epilepsy is a standard. However, the important question that still remains to be answered is whether to use the anti-epileptic drugs prophylactically after a traumatic brain injury, and does it decrease the incidence of later development of post-traumatic epilepsy. As we all know, seizures and epilepsy are not the same. Seizures are isolated and transient phenomena, whereas epilepsy is a disease that is characterized by an enduring predisposition to generate epileptic seizures. As per the time frame, the occurrence of seizures can be categorized as immediate, occurring in less than 24 hours, early, occurring 1 to 7 days, and late, occurring beyond the first week. Post-traumatic epilepsy refers to epilepsy that develops after traumatic brain injury and is stated as occurring any time after the first 7 days of the injury. This needs to be differentiated from the frequent post-traumatic seizures that occur in the early stage following the injury and occur from the onset to day 7. This cutoff reflects the differences in the causal mechanisms and subsequent seizure risk. Early post-traumatic seizures occur because of the direct effect of brain injury, example, contusions, presence of a hemorrhage, or the release of excitatory neurotransmitters. Whereas post-traumatic epilepsy indicates permanent changes in the brain as gliosis and rewiring. As per ILAE 2014, one of the criteria for the definitions of epilepsy is the presence of one unprovoked seizure and a probability of further recurrence, which is at least 60%. The risk of recurrence after a single late post-traumatic seizure is over 70%. Therefore, its occurrence is sufficient for the diagnosis of post-traumatic epilepsy. Post-traumatic epilepsy accounts for 10 to 20% of symptomatic epilepsies in the general population and 5% of all epilepsies. Early seizures occur in 2 to 17% of all patients with head injury, while 4 to 53% of patients with head injury go on to develop chronic seizures. The type of seizures usually encountered with head injury are focal epilepsies that may progress to bilateral tonic-clonic seizures. Some patients also may have non-convulsive seizures. Temporal lobe is the most common site for the origin of these seizures, and a critical determinant for post-traumatic epilepsy is the severity of the brain injury. Post-traumatic seizures may result in secondary brain injury. They may predispose to brain herniation and death and predict post-traumatic long-term epilepsy. Therefore, anti-seizure medicines are indicated for the prevention of these post-traumatic seizures, that is, in the first week of the injury. This was a landmark trial that was done by Temkin et al. And was published in NEJM in 1990. It studied the effect of phenytoin for the prevention of early post-traumatic seizures. The phenytoin group had a seizure risk rate of 3.6% at the end of day 7 versus 14.2% in the placebo group. So this phenytoin usage was associated with a 73% decrease in the risk of seizures in the first week. Current guidelines given by the Brain Trauma Foundation and the American Academy of Neurology recommend the primary prophylactic use of anti-seizure medications in patients with moderate to severe traumatic brain injury during the first 7 days. This was a meta-analysis which has been published recently, and it has studied all the available recent literature, and it also suggests the use of anti-seizure medications in the first 7 days, as a lower risk for early seizures were seen in the patients given prophylactic medications. All patients who actually develop a seizure are treated in the usual way, that is with IV anti-epileptic drugs. Diazepam, lorazepam, Fosolin, levetiracetam could be used. The choice of anti-seizure medications is optional, and there is no RCT to prove the superiority of one over the other. Phenytoin has been widely used. However, levetiracetam is more tolerated and is non-inferior to phenytoin. As far as prophylaxis of post-traumatic epilepsy is concerned, there is no beneficial effect on mortality or neurological disability. This was again the same trial by Temkin, which shows that phenytoin usage, even if it is used as compared to placebo, there is no beneficial effect of phenytoin in the prevention of post-traumatic epilepsy, starting from day 8 up to the end of 2 years. The current guideline does not recommend any use of prophylactic anti-seizure medications for the prevention of post-traumatic epilepsies. As far as treatment of these post-traumatic epilepsies is concerned, it is done in the usual way with anti-epileptic drugs. Since the recurrence is high after the first late post-traumatic seizure, chronic use of anti-seizure medicines is recommended even after a single late seizure. They are to be continued for 2 years. The presence of focal neurological deficits, a CT evidence of structural brain disease, and persistent EEG abnormalities increase the risk of recurrence after tapering these medicines, and therefore the drugs should be tapered carefully in the presence of these conditions. If seizures remain intractable, surgical therapies also may be considered. The patients with post-traumatic epilepsies should not be advised to drive, swim, or go to heights alone. The future prophylaxis for post-traumatic epilepsy, this requires further analysis, especially addressing the possible sources of heterogeneity and the use of newer anti-seizure medicines with newer modes of action. Therefore, larger studies with higher methodological rigor are needed before making any recommendations, and future research efforts should investigate associations through the use of minority subgroups. Thank you so much.
Now, house is open for the questions. Yeah, sure.
Dr. Priya, would you mind staying up? We can finish your questions first,
yes,
and then we'll ask Sri Ganesh and Sudhir to come. Yes, David. No, speaker, the mic.
I enjoyed your talk. Thank you very much. Nice overview. I think we talk about early prophylaxis, and then we talk about the development of post-traumatic epilepsy. But where would be instances where you might continue anti-seizure medication past 7 days? Do you feel that you need to have a seizure, or is there certain populations where you would provide medication beyond the 7 days?
So, though we do not have any evidence that the early use of anti-seizure medications would actually decrease the chance of post-traumatic epilepsy, but I think the option that we all follow is we do keep our patients on anti-epileptic drugs. Those are the patients who have moderate to severe traumatic brain injury. So we do continue them on anti-epileptic drugs, though we do not have evidence. That is why larger studies in future are required to actually prove this.
Hi, sir. I would like to add to your point. I live in Sikkim, which is a place where it's got a lot of heights, and traveling just to your own vehicle from your house to the road, that is also a height. You have to climb maybe 15-20 steps. So I agree with your point that we need to continue anti-seizure medication for long. So over there, I have individually developed a kind of practice where even if it is mild to moderate head injury, I give them anti-seizure medication, wait for almost 2 to 6 months, and before stopping it, do an EEG. If it's clear, then slowly taper. Maybe first you put the dose half, then give it alternate day, and then stop. I don't know how good that is, but I feel safer that way with my patients.
Yeah, I mean, I would challenge it because I would say that there are certain, I don't know if you can blanket say all patients with TBI should have an extension because we're worried about seizures. Because if somebody has a DAI, for example, that's different than someone who has several contusions.
Right.
And so if I saw someone with mild or even moderate severe with contusions, I would tend to treat them longer just to be confirmed that they don't have post-traumatic epilepsy versus DAI 7 days because you're avoiding the acute events.
I totally agree with you, sir. Though the evidence at present is lacking, but it is quite, I must say, it is quite natural for all of us to use anti-seizure medications in those patients who have a traumatic brain injury. So that is why the future should actually we should have more studies in the future that should highlight, and then because now we have several new anti-seizure medications also that may have some helpful neuroprotective role as well.
I'm here. Professor Priya Agarwal, many thanks. I like to lecture. I'm Partho Rai, from neurologist from Kolkata, because you took on the challenge of going into an area where there's not much in way of evidence, and each one of us does it differently, as we were just hearing. Now the point is, my doubts exist around EEG seizures or clinical seizures. That's one. Because we believe that in head injury there's a significant amount of inflammation in the brain. So the role of steroids acutely, and again subclassifying it. Then of course, as you said, there is no evidence to show that either lacosamide or levetiracetam or phenytoin or valproate is better. And it's basically a toss of the coin, and we decide which one to give. Yeah. So I won't be asking you these questions because there's no real evidence that one can, but everyone does their own things. Would it be nice to set up a trial or RCT, because we have a large number of TBIs and head injuries, and form some sort of societal guidelines from Indian Society of Neurotrauma, driven by neurologists, because we are the ones who are often asked to give it. Previously, my surgical colleagues always gave the phenytoin, and they didn't know, or well, they knew, but they would ask us when to stop it, and it was a risk that we took as to stop the drug and have a seizure, and then it's we who stopped the drug. So it wasn't right. And again, phenytoin had apparently neuroprotective capacities as well. So it's all quite a muddy area. So would you mind sort of, advising on how we take this further to get some clarity?
That would be very nice, because we all feel that future studies are definitely required in these fields as to whether the use of early usage of anti-seizure medications, if it actually helps in the prevention of post-traumatic epilepsy, number one, and secondly, if one drug is more favorable as compared to the other drug.
It was the IV route that most of us chose as the optimum one. That's why in the others which didn't have IV formulations fell out of the choice. So yeah, well, thank you very much for raising a very important area. Thank you.
So
just
Dr. Priya,
short, please.
I'm Dr. Krishnari Sharma. I'm a neurosurgeon working for last 25 years and worked in medical college for 15 years. There are a lot of load of head injury patients we used to see, and the practical aspect is that those patients who had an impact of injury
more, patient may have some transient unconsciousness or not. There may be some contusion. Beside those patients who are having significant findings in their CT scan and clinically also they are having a GCS little poor, beside that, we used to give anti-epileptic drugs to all patients, even if we small contusion, or sometimes we don't have any contusion, for at least 3 to 6 months and taper it. And I don't think for every patient we can ask for an EEG or that, because in my tenure I have seen 2 patients who were not given any anti-epileptic. There was no contusion seen in the CT scan, but they were brought dead to the hospital in 48 hours because of recurrent seizures and leading to status epilepticus. So there are legal aspects also if we don't start any anti-epileptic drug for such patients. So definitely more research is required for set any protocol for all these things.
Sir, we do need to give anti-seizure medications at least in the first 7 days. We have evidence for that, but we do not have evidence for the future development of the epilepsy. So definitely further studies are required for that.
Madam, for future, if once patient throw a seizure
Yes.
and has a history of trauma, then we have to continue as per guidelines.
Yeah.
Rather,
but then-
as a neurologist, you come to patients who had one doubtful seizure. You always say, better see if other seizure comes, then we will start anti-epileptic.
Once the patient is started on anti-seizure medications after he has a seizure,
Yeah.
the anti-epileptic drugs need to be continued for at
is
least
a separate,
2 years.
That is a separate
for
thing.
at least 2 years.
Yeah.
That is
That is
different.
Yeah, thank you. Thank you.
Please refrain, ask questions, all right? We don't want comments.
Morning, ma'am. I'm a resident in SMS Jaipur, neurosurgery, ma'am. Ma'am, I have a question, ma'am. We just operated a patient of temporal contisectomy, and post 15 days, the patient was well. Suddenly, in today's morning round, the patient had a focal seizure in right upper limb extending to the right upper limb. Ma'am, the patient was already on levetiracetam and sodium valproate. Ma'am, what would you recommend in such a patient, that whether the anti-epileptic the same anti-epileptic should be continued, or is there a need for addition of a newer anti-epileptic to this patient now?
The approach differs from doctor to doctor, but what I would actually suggest in this clinical scenario is not to withdraw a drug, not to change the drug in this situation, but to add the third one. And after the patient is seizure free, we can try to withdraw one of the previously used drugs.
What would you recommend, ma'am?
Clobazam is a good choice. Carbamazepine and oxcarbazepine are good choices. Carbamazepine and oxcarbazepine, as proved in the SANET studies, had a good role in focal epilepsies.
Thank you, ma'am.
Okay, as chairperson, we will reserve the right to ask the last question. A couple of years ago, I work in Vellore, and the trip to the airport takes about 3 hours. A couple of years ago, I got into the cab, and the taxi driver greeted me in great delight, saying, "Sir, you operated on me 5 years ago." Okay, and he had this big craniotomy scar. It was the tensest 3 hours I've spent in my life, wondering when he's going to have a seizure and crash the car. All right? The man had contusions. He never had seizures. It's 5 years post-trauma. Can we ask him to drive a taxi?
Sir, that is a very controversial issue. That is a very controversial issue. As such, in India, we do not have still driving rights given to patients who had epilepsy, at least in the past. I understand he never had epilepsy. I understand, but this is a very controversial issue.
I have never been as tense as that
Yes.
3 hours, waiting for the man to have a seizure and crash the car. Yeah. So I wondered what the influence be on other people as well.
My brother-in-law was operated for CABG. Post-operatively, he developed seizures maybe because of hypoxic brain damage. Now he's after 13 years, still he is on anti-epileptic drugs. Once we try to reduce it, then he developed again
He
seizures.
develops the recurrence of seizures.
Now earlier he was taking only sodium valproate, but now we have added levetiracetam also.
Okay.
But earlier he used to drive the car, and now he has stopped driving.
Actually, driving should not be permitted to at least those patients who are having seizures, at least in the recent 6 months.
Okay.
Thank you for a
Thank you,
wonderful
Dr.
discussion.
Priya.
Thank you so much.
Okay. Any questions for Dr. Sudhir? No, I mean, we have stopped here because we have 10 minutes total for discussion for 3 speakers. Yeah. Dr. Sudhir, any questions? He spoke on ultrasound, TCD. Okay, I have one question, Sudhir. How about TCD for measuring ICP. You didn't cover that.
Yes, sir. That's because of lack of time. Yeah, TCD to measure ICP is something which we have to explore more. Right now, we do not have clear evidence, but as I mentioned, the morphology of the curve, the systolic curve, is going to roughly tell us what is going to happen to the ICP, what is happening to the ICP. So, what I do is, whenever there is a patient with subarachnoid hemorrhage or head injury, twice a day TCD is done. So we see what is happening to the velocities. Is there hyperemia or vasospasm? One. Second, what is happening to the morphology of the waveform serially. So as it changes, we can have a rough indication of whether there is a change in the ICP, and immediately we do a clinical examination. I mean, clinical examination is done, then the imaging, CT scan or something to get a idea of ICP.
You don't believe any of the formulas out there?
I would not still stick to formulas, sir. I would still go with the morphology of the waveform. So that will give us a real indication of what's happening in the brain.
David?
Sorry to add. I agree with you. I think TCD is a very potential important tool. What do you do for the variability between technicians and variability in those that are administering the TCD, that you get such results? Because that's where we found challenge day to day. Could we trust the numbers?
That's one limitation of TCD. So we cannot ascertain the same angle of insunation every time we do it. Either I do it or my resident do it. What I do is in the critical care ICU, there is one resident posted for one whole month. He is responsible to do the TCD. He marks the point where he has done the TCD, and we hope that it's the same angle of insunation. So when we are conducting studies or RCTs, what we do is we do 3 serial TCDs and take average of that to be sure that the angle of insunation at least in some way is negated.
Thank you, Dr. Sudhir. Any other questions? Dr. Sri Ganesh? And I'll go sedation in trauma.
Yes. Yeah, Professor Sri Ganesh. I have found a variation in the depth of anesthesia my neurointensivists keep my patients on when they're on intensive care. Do you have any guidelines as to what level of anesthesia you need to keep them? Because analgesia, sedation, and anesthesia are 3 different parameters, and you've shown us several different angles of assessment. And I've seen colleagues keeping very deep anesthesia and some keeping light anesthesia. What's your practice?
This requires 2 approaches. One, why is sedation required? Just for sedation or analgesia is required. One, whether the ICP is very high, you need to control the ICP. In that case, you need to go higher depths, means deeper plane of anesthesia. Okay, suppose the patient is awaiting surgery or a decision regarding surgery has not yet been taken and ICP is expected to be high. To manage the ICP, you need higher depths of anesthesia with propofol or thiopentone, whatever agents you use, sedative agents. But if it is mainly for preventing secondary injury because of sympathetic activation, because of agitation, because of tube tolerance, because of any procedures in the ICU, you don't require that high depth of anesthesia. So you need a moderate depth of anesthesia. It could be as simple with BPS, behavioral pain score, that we do routinely.
So is there a score that we're using instead?
Yes, which I showed, BPS.
Thank you very much. Yeah. That was all.
Anybody else? Okay, you gave us choices. You tell us what to use. Okay, I'll tell you, I have a scenario. Patient, post-TBI, little contusions here and there, a fairly swollen brain. ICP is tending to go up. It's 16, 17, but what would you use as sedation?
Yeah, I go with the analgesia first approach.
You know, which ones? I mean, specifically which drugs?
Opioids, the morphine.
Specific. I mean, tell somebody here wants to go and treat tomorrow, what drug should they use?
Yeah, whatever is available. So that is the first thing. I would go with, if morphine and fentanyl is available, fentanyl infusion, 1 to 2 mics to start with, see how the patient is on a behavioral pain score, and then proceed with addition of any other analgesic or hiking up the drug. Suppose the ICP is on upward trend, if it's touching say 20, 25, then definitely this patient will require a propofol to be added to the opioid that I am using. So that would be the approach I use.
Propofol?
Yes.
Huh?
Yes, sir.
Even if if I think that this is going to go on for 2-3 days, you would still start with propofol?
Yeah, propofol is generally used for 24 hours.
Yeah.
But I would give propofol as the first choice because it significantly reduces metabolism. We have better titratability as compared to thiopentone.
Tomorrow?
We can definitely switch over to alternative or add on other one. To either.
I'm trying to make you say
Yeah.
drug names for these people.
Okay, the drug names which I mentioned were ketamine and dexmedetomidine as an alternative to propofol.
Which would you prefer, dexmedetomidine or ketamine?
Depends on hemodynamics again. So it is not one size fits all. So depending on the clinical situation, if the blood pressure is say 90, I would definitely not go with dexmedetomidine. I would go with ketamine with propofol combination.
So you're saying it would be fentanyl first and then either dexmed or ketamine? Or
Propofol, fentanyl, propofol, then dexmed or ketamine.
Suppose I need more than 24 hours.
Yeah,
I estimate that
but I would still start with propofol.
And then switch to something
Yes,
else.
especially when the ICP is on the rise. If the ICP is normal, propofol would not be required.
ICP is tending to go up. It's
Yeah.
staying below 20, but or 22, whatever you want to use.
Yeah.
But you would not use midazolam.
No, sir. Midazolam is not a very good drug to be used both in the anesthesia practice and in the ICU. These are all earlier studies. We have better drugs with better pharmacokinetic and pharmacodynamic profile, such as propofol. Again, it depends on availability and familiarity with the drug, how confident you are. So I can understand even the peripheral setup where anesthesiologist is not involved in the care, midazolam is safer because it is cardiostable compared to propofol or other drugs. But you have asked my opinion, my choice, I would go with this.
So I have a question. We get a lot of head injuries with of patients who are drug addicts.
Who are?
Drug addicts.
Yeah.
Okay, when they come, they might be, the urine is positive on cocaine, positive on amphetamines, THC, a lot of things. So we have a very difficult time trying to sedate them. Midas, Fenta doesn't work. Lorazepam, we take the psychiatrist's advice sometimes, that doesn't work. Dexmed, it works only for a shorter time. So what do we do? How do we sedate them? They will have multiple small contusions. You can imagine the ICP is high, we are giving anti-edema. And even to do a small CT scan, we put a Dexmed, do the CT scan, and then again it's difficult. We actually restrain them. Let's be very practical.
Yeah.
So what else can we do?
So of course, it is a difficult subgroup of patients that we see. Opioids generally they require large quantities, so that is not a good choice. But of course, we cannot remove the opioids completely. We need to supplement with either fentanyl or morphine and add on, like you said, dexmedetomidine, which is a good choice because these patients' agitation is more as compared to because of the withdrawal effects. So dexmedetomidine is a good choice because it's centrally acting alpha-2 agonist. So that also, if it is not helping, then one is physical restraint, and we can completely anesthetize the patient with propofol or thiopentone.
Like if we start a Dexmed infusion, can we give it for 12 hours, reassess, and again start it off?
Yeah, Dexmed that way is very beautiful.
About anything else?
No, Dexmed only problem is hypotension and bradycardia. Other than that, it is excellent drug. It can be continued beyond 24 hours period.
That brady actually overlaps with high ICP.
Yeah, that is what I mentioned. That is a confounding. It can mask any change in neurological status. Right. So you need to use alternative methods of assessing the ICP in those patients.
Thank you, sir.
Sigresh, are you doing this assessment test regularly? Or whether daily or 8 hourly or
every shift. Every shift analgesic pain score is assessed, and BPS is generally assessed, not other modes which I mentioned.
So what difficulty you guys come across in these traumatic brain injury patients? They are stupros or delirious or unconscious patients?
All spectrum, madam. Very unconscious to delirious. We see all kinds of spectrum patient. Generally, post-surgery, if the first 24 hours, we start them on sedation and then only plan for weaning. So generally, they will be on propofol or dexmedetomidine depending on the hemodynamics. So generally, we don't see that. Once we start tapering the sedation, we see this agitation manifesting. So you need to add, like I said, non-pharmacological methods also.
What type of non-pharmacological?
Most common and easiest cost-effective is a family member. Especially in a pediatric traumatic brain injury, presence of a family member itself reduces agitation, reduces all other manifestations of sympathetic activation.
Thank you. Okay.
Thank you.
Okay. Very good presentations and very good discussions. I must congratulate all the 3 speakers. Thank you.
Thank you to all the speakers, and thank you all the chairpersons. Thank you. We'll break for a small tea break now. Please join the sessions in Hall A, and the next session here in Hall B will resume at 12 noon. Thank you. Asi Besta, pardon my pronunciation, sir. Dr. Jitin Bajaj, Associate Professor, Neurosurgery of NSCB Medical College, Jabalpur, and Dr. Kamal Goel, he'll be joining us soon. He's a Senior Consultant Neurosurgeon and Clinical Director, IBS Hospital, Jaipur. All the talks are strictly for 10 minutes.
I think that we are a little bit late because we were waiting for the plenary session in Orlahey to finish. And I think some more people will attend this section that is the surgical aspect of neurotrauma. It's my pleasure to be here with you. And it is my pleasure to ask to Dr. Bihari to talk about traumatic pseudoaneurysm. I'm sorry that the organization give all the speakers only 10 minutes. So we try to be fair, but sometimes we will be very tough.
Yeah. So, good afternoon. I'd like to talk to you about some cases of traumatic aneurysms, the neurosurgical implications and management nuances. It's rare, less than 1% of cases, and but they have a significant mortality and morbidity rate. So they have the classification is those which are proximal to the circle of Willis, and those are which are distal to circle of Willis, and they can be infraclinoid or supraclinoid carotid artery, vertebrobasilar, subcortical, or cortical. And so the first case is a 24-year-old male patient who, following neck trauma, developed progressive neck swelling with recurrent transient ischemic attacks. And the CT and MRI were normal. And the angiogram showed this huge aneurysm on the region of the neck. And it was partially filling there. And so my endovascular colleagues, they did segmental embolization. First, they did partial embolization just to make sure that there is no ischemic defects. And then they did a complete embolization. And luckily, the cross flow shows that both the, from the contralateral sides, both the carotid arteries were filling. And so this was a good point. So there was a good cross flow, tolerated internal carotid artery occlusion, and there was no transient ischemic attacks after vascular occlusion. So basically, this patient presented with embolism. There was redistribution of blood flow, and bypass may still be required to prevent a long-term ischemic episode. And there's no need for a stage vessel occlusion in most of the cases, but it's much better to kind of do it either in a staged manner or do a prophylactic bypass here. Case 2 is a 16-year-old patient who sustained neck trauma when he was 8 years old. There was progressive neck swelling and developed a pulsatile neck swelling. And this is the patient with this, and somebody actually went and operated trying to take a biopsy because they thought it was a tubercular abscess, and then they closed it up. Luckily, the patient still made it after that. And so this is another huge aneurysm that you see in the neck. And so there was no cross flow in this particular case. And so in this case, the only possibility was to stent that vessel to maintain the patency of the lumen, which was done. And so it is very important that before we operate, a balloon test occlusion and a cross flow is essential to be determined. You have to maintain vessel patency, and bypass is required if the patient does not tolerate occlusion. So this is the second case. The third case is a 16-year-old child with recurrent epistaxis and dysphagia. And so this is the huge aneurysm, which is actually corresponding with the pharynx, and actually part of it was bleeding intermittently into the pharynx. And then there was a pseudothrombus formation, which was preventing complete bleeding and complete exsanguination of this patient. And this was the MR angiogram, which shows this huge pseudoaneurysm with multiple layers of clot present. And there was again no cross flow present from the internal carotid artery. There was no cross flow present. And of course, a part of it was filling. So here, there was mass effect was due to the intraluminal thrombus, and there was a very small filling portion that you can see here. So the interesting thing was that the internal carotid artery was, this patient was still living because the internal carotid artery was being supported by the, middle cerebral artery was being supported by the PCOM and the PCA and the middle cerebral artery. So you see the vertebral artery, and then through the PCOM artery, the circulation was being supported. And of course, here we had to do the proximal occlusion, and then there was this, the patient did well after this. So sometimes they will present with epistaxis and dysphagia, vertebral artery supported by circulation despite no flow from the opposite contralateral circulation. There was a large luminal thrombus, and pseudomembrane which prevented exsanguinating epistaxis. And there was a little ICA flow with dissection which prevented its intraluminal reconstruction using a stent. So we just had to do a proximal vessel occlusion. But because there was a cross flow from the posterior circulation, the patient did reasonably well. This 22-year-old male, the next patient, had profuse epistaxis and was unconscious. And urgent hemodynamic resuscitation was required in this particular patient. And the past history was that of road traffic accident in June 2001. He was hospitalized after loss of consciousness, sustained multiple injuries, and though other incidental history. After 25 days of road traffic accident, he developed a moderate to severe headache, non-remitting in nature, associated with vomiting, with occasional epistaxis and blood in sputum. And the interesting thing was that there was a rapid loss of vision within 2 months after 45 days of the road traffic accident. And all this was not discovered because everybody thought that, oh, it's because of post-traumatic syndrome and this and that. And till the loss of vision was there, nobody actually realized that there was something going on in the brain. And he had undergone a neuroimaging, including a DSA, which revealed a pseudoaneurysm arising from cavernous and paraclinoid segment of the left ICA. He underwent intervention by the neuroradiology department, where coiling and obliteration of the left ICA was done, and had immediate symptomatic improvement with the remission of headache and vomiting, but vision loss persisted, and then was subsequently asymptomatic for the next 6 years. Led a very productive life. And then this was the previous one, which you see almost like a pituitary tumor, but you cannot make the mistake of actually going inside and trying to do a transfemoral surgery in this case. That will lead to a disaster. And so this was the MRI which was done in 2001. You see this small amount of pseudoaneurysm with in the suprasellar region. And this time when the patient came completely conscious, there was PL negative in the left eye, right eye was 6/6. There was proptosis, and this was increasing continuously. Left eye had primary optic atrophy, and there was no other deficit in this patient. And when we did the interesting thing was that the aneurysm had actually caused bony changes. So this was like a expansile lytic lesion because of the aneurysm being present in the suprasellar region this time. And you see this interesting thing that the aneurysm had caused a perfect circle of the sphenoid sinus, and the clinoid was eroded, and this was almost like this. And this angiogram showed that this was the angiogram, and again there was a problem about the cross flow being an issue here. And so another interesting thing is the external carotid showed that through a supply, it was supplying this carotico-ophthalmic pseudoaneurysm which had formed here. And this is an external carotid was giving a large amount of supply here. And of course, the ascending pharyngeal was also giving supply to this aneurysm. And so this was the actual image of the left ascending pharyngeal, which showed the aneurysm there, and this was giving the supply. And again, this patient had a good supply from the vertebrobasilar system. So from the PCOM, this supratentorial area was being supplied, and that was responsible for the patient remaining well. So some of these patients sustain themselves simply because of cross circulation from other areas. And so this is the actual aneurysm of the carotid angiogram. And so here, during surgery, we did an intradural clinoidectomy, and this was a huge aneurysm which had actually caused primary optic atrophy of the optic nerve here. This is the aneurysm which was seen. So we drilled the clinoid process and removed this, and then trapped the aneurysm in the neck and in the supraclinoid segment just proximal to the PCOM artery, and then this cannot be seen here. And of course, this is the post-operative angiogram, which shows that there a little bit of cross flow is coming from the middle cerebral artery, and of course a lot of it is being supported by the vertebral system. And of course this can also, a prophylactic bypass can be done, but if there is already a circulation being there, most of this prophylactic STMCA bypass will not work so well. I mean, in these cases, this is the thing. So there was the point here is there was a delayed deterioration, recurrence despite successful treatment. Manifestations may change. Epistaxis leading to proptosis, loss of vision, and ophthalmoparesis. And this is a cavernous sinus aneurysm. So multiple small arterioles supply even when the main vessels are occluded including the external carotid artery, the ascending pharyngeal, and all of them. Now this was another very interesting case, a 25-year-old boy who had a bleeding neck mass and remote trauma which was forgotten. And you see this giant aneurysm which was seen here, but a very good cross flow, and this was present in the neck. And so you see this, this was this had eroded the skin, and you can actually see that the entire thing was there. So this was a bleeding neck mass, and the thrombus prevented exsanguination, and the cross flow prevented ischemia. So we actually operated on this patient and removed the thrombus, and then the patient did well. Sometimes we also have this iatrogenic injury. For example, a vertebral artery injury following a retrometastaroid suboccipital craniectomy. Just make sure that either you have made complete, or in the third part of the vertebral artery, you might get this flow, and you can see that there was a pseudoaneurysm here during CV junction surgery, and therefore immediately take the patient to the ward and actually embolize it. So aneurysms could be true aneurysms, which will, adventitia will be intact, and a false aneurysm where the adventitia will actually go. And there can be a mixed aneurysm where some part adventitia can be intact and in some part it will not be given. So to conclude, I will say that if there is a slight irregularity in one of the intracranial arteries, please make sure that it's not a pseudoaneurysm. And if there, after trauma, or if there's a disproportionate amount of subarachnoid blood following trauma, that's another big indicator. And the third very important thing is, if there's a large hematoma adjacent to a major intracranial vessel, although you don't see an aneurysm, you still have to be very careful about a pseudoaneurysm being there. Thank you very much for your kind attention.
Thank you very much, sir. So just a question, sir. Sir, regarding the clipping of these aneurysms, how friable are these vessels, and how different the clipping is from normal vessels?
Yeah, so I mean, the point is you cannot clip them because they form a wall of the aneurysm, so a wall of the main vessel. So, and most of the outer covering is also the thrombus, multiple layers of thrombus, so it will just avulse. So the important thing is either to trap it or to stent it or to bypass it. So that those are the only things which work. And if you are working at the carotid ophthalmic region, then the very important thing is that you must make sure that it is proximal to the PCOM artery, so that some of the perforators of the PCOM don't get compromised by the thing. So that is why, and the other important thing is in the neck you can do it, but then another thing is if you can just get some proximal aspect after drilling of the clinoid, then in the extradural segment of the internal carotid artery, the C4 segment, you can clip. So that traps it without actually compromising anything. But then the cross flow has to be really determined. And in most of them, when there is a pseudoaneurysm that the patient has still lived, so there is a cross flow already available with you. So it's not like, the patient will collapse if you just trap the main vessel. In most of them, there is always either through a posterior circulation or through the cross from the opposite side, there will be some available, or even from the external carotid artery.
Sorry, just if cross flow, because in the patent vessel, there is some flow is already there. If you trap it, then possibility of the infarct would be there. It will be less than usual.
Actually, the difference between a carotid ophthalmic aneurysm, I have done many of them, and the difference will be in a carotid ophthalmic aneurysm, that vessel will usually be supporting the circulation. But in a pseudoaneurysm, usually what happens is either because of dissection or because of the weight of the thrombus within the aneurysm, or because the vessel is already obliterated or is very, very narrow, usually cross flow is already established. So the amount of bypass which is required may not be as much as is required. But if you're doing a balloon test occlusion and after 20 minutes the patient is developing some ischemic symptoms and all that, then of course a bypass is required. The problem with STMCA bypass is that in most of these cases the circulation is not enough to support the entire brain. So either you're doing a high flow bypass, or just wait and watch.
Or
and
stenting at this.
or stenting. The stenting will only work if the proximal and distal segment is patent. If it is not, then it's not. It's very difficult to do it. Yeah, that's it.
Any questions from the house? Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you.
We now invite Professor Salvatore Shibaro.
Sorry. Ladies and gentlemen, dear colleague, good afternoon. And firstly, I would like to thank Professor Signa and all the organized committee for the kind invitation. For me, it's a great honor to be here today to share the experience of our research group. So just before to start, I would like to ask to the audience, just lift up your hand, who is using the monopolar and bipolar to manage temporal muscle during cranioplasty, or during craniectomy, sorry. Monopolar, bipolar? Okay, just monopolar, okay. So, actually, the compensated connector is now an established procedure, but sometimes represent the first step of along the venture patient. Sometimes cranioplasty is aggravated by a lot of complication. So we actually we pay attention to the temporal muscle. Actually, we don't use at all the monopolar during the craniectomy, and also we try, and that is not enough, and try to pay attention to possible adherence that are maybe occur after the cranioplasty. The old scar tissue is a problem when you go afterwards to make the cranioplasty, and sometimes you cannot easily find the temporal muscle plane, just the dissecting plane, go down and until the dura plane. So we decided to try to interpose a patch. Maybe many people are already doing that, but anyway, the literature is not very rich about that. We found a lot of people are paying attention during the pterygium approach, but not many groups are working about the temporal muscle during craniectomy, the compensated craniectomy. So we put a double patch just to avoid or to reduce this problem. So everything is like everybody I think does, and this is the same. But now it actually starts the change. So we put a small patch just underneath the temporal muscle, and afterward we stitch up on the temporal muscle another small patch just to avoid eventually the adherence. And this is a typical case. You can see the first one is underneath the dura. The second one is stitched up to the temporal muscle. That one is just underneath, just lying over the dura where the temporal muscle is gonna be. Now, this is a surgical case of cranioplasty. You can see, this is one, this is another one. You can see how it's very easy to lift up the temporal muscle just with 2 forceps. And afterwards, you should take off the patch just to give the temporal muscle its functional integrity and function, and afterwards you can perform very easily your cranioplasty. So what actually we did, we included a cohort of patients during 3 years, and we about all patients undergoing for various reasons the compensated craniectomy, and we excluded people that could have a skin healing problem, and we evaluated the temporal muscle thickness and the operative time, the blood loss, and also the wound healing, the infection, and possible new occurrence of epilepsy. And this is actually our cohort, is 59 patients, and all mostly underwent to the compensated craniectomy for head injury. And you can see as the temporal muscle thickness assessed by CT scan was almost the same before and after. So almost zero adherence were found during surgery, and the surgical time was, the mean was 66 minutes. It's not very quick, but I think it's not too much, and the surgical, the blood loss was very, very small, and also the hospital stay. But what is important is that we didn't have wound dehiscence, surgical site infection, CSF leak, so zero CSF leak, and also no new postoperative epilepsy. So finally, we can say that this is nothing special, but it's just to take care about the temporal muscle. I'm sure that everybody here does it, but sometimes people say, yes, I do it, but when I go around and sometimes I just see some president just, grilling the muscle, is a barbecue, and we just go. This is not really something that would take care of the outcome of the patient. A temporal muscle is really important, and we can have very nice results about wound healing, about cosmetic. And finally, we believe that you should take care of about temporal muscle. And this, although it's not related to my talk, I would invite all of you to contribute to the special issue about traumatic brain injury and chronic traumatic encephalopathy that is edited by myself and Professor Ganao. And any questions? Anyway, I invite all of you to come and to visit Siena and this crazy horse race. Thank you.
Thank you for your presentation. I would like to make a comment. I think that your presentation is very important, but the first question that you asked is the most important issue. Less monopolar use, better results.
Absolutely.
Not only for the cranioplasty, but for any kind of surgery that you are doing in the, let's say, frontotemporal region. I think that is very important. And the, let's say, tricks that you are using is very interesting. Thank you.
Any questions from the house?
May I invite the next speaker, Dr. Giovanni Broghe from Italy.
Okay, good morning. And again, thanks for the organizer to invite me to get this opportunity to share with you my experience, and mainly to have the opportunity again to come to this wonderful country that is India. Okay, I am reporting the experience on the surgical treatment of post-traumatic epilepsy. That is something that happens very, as we will see, very often in the injuries. So all the data are coming from the Bernstein Institute and the Claudio Munari Epilepsy Center in Milano, that we are working together on this particular, and not only this for the epilepsy surgery. What is the problem of the basis of post-traumatic epilepsy? You have immediately contusion, hematoma, and edema. But what's more important, you have two events. The radical, free radical generation, the alteration of the calcium channel, the angiogenesis, and the mainly a glial response that is responsible for what is the most important things, is that the recurrent excitatory synapses that is at the basis of the surgery, of the epilepsy, I'm sorry. So epidemiology, as you say, is quite in different series from 16 to 50% traumatic brain injury, is 80% in penetrating brain injury. So this is a little bit different. Anyhow, the most important message is that sometimes there is the interval in between the trauma and the epilepsy is long, months. Sometimes we show you years, and that is something that has to be taught in terms of following the patient in chronic way. The most important things, the other things is that, of course, you can give drugs to protect toward the epilepsy in the first part of the after the traumatic injury, but it is very important that sometimes the patient are treating themselves without any intervention. This is a series reported, as you see here in the 2019, of the surgery for different type of authors, and you see that success is quite good in every series. But the most important things is that you have to divide in between the temporal series and the extratemporal. You see here that the findings. The most important message is this one: 63% of angle 1, that means no seizure, no drugs, and 36% of, let's say, failure of the patient and require again treatment, medical treatment. These results are not far different. What is the epilepsy surgery in MRI negative? That means where there is no alteration of the brain. And the other things is that the better results, of course, are coming out with the temporal surgery. Extratemporal surgery, again, you see here all the characteristics of the series, and that is the most important message. 36% of angle 1. So it's quite different the response and the success of surgical treatment. But it's not so far away of what, again, is the surgery for epilepsy in MRI negative. That is 36%, 38 versus 36%. And so let's go to some cases just to discuss. This is quite important because he has a car accident at the age of 22, and 10 years after he had the surgery for ocular prosthesis implantation and to take out the bone that is inside. And at the age of 30, he was free till the age of 43. That means 20 years after he started having surgery, having a seizure. And you see here that the EEG was positive on that, and there was some psychological problems. This is the case. This is the pre-op. You see here the frontal lobe injury. We, of course, as in all cases of surgery for epilepsy, a PET scan is mandatory to see if the lesion is correlating with other metabolic deficit or not. And you see here that was coherent. And we did surgery, and with, of course, conticectomy of left frontal, sparing the let's say Broca gyrus, and this at the 18 months follow-up, he has no more leukorrhea and no seizure, and that is the control at 3 years follow-up. Second case. Before second case, we have to understand why there is a difference from the first one. So you have functional changes that is far away from the site of the lesion, and sometimes EEG is not helping you because of the previous craniotomy it's difficult to have a different, exactly localization of the nidus of the seizure. So we have to do stereotaxic EEG. This is the one case, again, a trauma at the age of 17, and it starts 5 years later to have a seizure with aphasia, automatism. So it's a kind of localization. It was quite clear. EEG in this case was helping us, and there was no neurophysiological deficit. So this, as you see, is not so far different of the previous one. Nevertheless, we did the ACEG to be sure of what we have to do surgery. And you see here all the electrode implanted. The ACEG told us that there was an epileptogenic zone, multifocal, at the left frontal lobe, and including a singular cortex. So we proposed surgery, left frontal lobectomy sparing, again F3 to avoid things. So that's, you see that the lesionectomy was larger than before, and 10 years follow-up, we have angle 1 and no medical treatment. Second case, at the age of 17 again, he has the trauma. At the 6 year after, 7 year after, he got seizure, complex partial seizure. The EEG was not so coherent with the symptomatology. So we did, that is the lesion you see here, frontotemporal. And that is very important. We did the ECG on the frontal lobe and in temporal lobe. And what it came out, that the temporal lobe was not involved. And we try to, due to this kind of seizure that he has, to do thermocoagulation using the same electrode that for the EEG, and with the proposal that if there was a failure after this kind of lesioning, we can plan resective surgery. And exactly what we did, that is the implantation after the radiofrequency, but the response was not completely, and he underwent to resective surgery. So to make some conclusion on this kind of experience, the high density EEG is a good. I'm sorry. Is a good tool to be used, but is not exactly as the magnetoencephalography. But that is something that is not easy to be used in any center. And so let's go to conclusion. The post-traumatic epilepsy surgery is a very good outcome, mainly in temporal lobe surgery, but also extratemporal surgery, the results are good. And you see here that the temporal lobe, as I say before, 63% of success, extratemporal 33, but still is something that you have to propose to those patients. You have to remember that sometimes is the epileptogenic zone is very difficult to identify, is not coherent with the MRI lesioning, and the need to have a investigation with SEEG is quite important. So thank you for this. This is the team that collected all this data, and I thank you very much for your attention.
Thank you very much, sir. It was a very nice paper. I have two questions, sir. What are the results of surgery for post-traumatic epilepsy compared to the focal cortical dysplasias? And second question is, do you use intraoperative electrocardiography for these?
Well, let's say the second one. Usually we are not using electroencephalography. As you say before, all the clinical situation and the EEG are convincing us to just do the surgery, otherwise we do SEEG. That is much better of cortical, because with the cortical you have only the image of surfaces, not the image of the. For instance, for this, if we did the cortical examination in the case I've shown you the last one, probably we will take have surgery also in the temporal lobe. Why ECG showed that there was no reason to do it. That's the first question.
Results vis-a-vis FCDs. Focal cortical dysplasia. Results versus of these versus focal cortical dysplasias. Focal cortical dysplasias.
Oh, for the cortical dysplasia is not post-traumatic.
No, I'm saying results of these versus surgery for focal cortical dysplasia.
Oh, for the cortical, you have angle, well, doing all this, the situation. In this is a case in which MRI is positive, and if EEG is positive, if mainly clinical symptomatology is coherent with this lesion, you can do surgery without any stereo EEG, and the success is very high, it's more than 90% in all centers that are doing that.
Did you find any cognitive improvement after surgery following the stoppage of anti-epileptic medication?
No.
You didn't find any?
If you have deficit, the deficit stay there.
Cognitive impairment?
Yeah, cognitive impairment, I have to say no. No improvement. Well, you know, we are always, as surgeon, we are always optimistic, but I don't think that is the answer.
Like we see in the mesial temporal sclerosis, because
Yeah,
patients have been taking so many medicines.
Oh yeah,
If we stop them, they improve their
that,
cognitive behavior.
but I think that there is two reasons for the temporal medial sclerosis. First of all, you take out something that is, in spite of the drugs, is making seizure under clinical, and second thing, you take out of the drugs. Yeah. Because when you have no control, you increase the dosage, and that is a side effect of the drugs.
And your indication only when it is intractable epilepsy following traumatic trauma?
Yes. Although with let's say, not pediatric, but adolescent type of epilepsy, we try to be a little bit enlarged. And we have the opportunity to have the MEG, and the MEG is not so invasive, but is giving you a lot of information. So if the MEG is positive, the symptomatology is very important in spite of the fact that there is, let's say, control of seizure. We propose surgery for this patient.
Thank you. Any questions from the house, sir?
Thank you.
Thank you very much, sir. Next, we invite Professor Amit Chakrabarty to give his talk.
Good morning to respected chairpersons, professors, my colleagues, and to all the delegates who have taken out time to attend this conference and make this conference a grand success. I shall take this opportunity to share my experience in transcranial repair of anterior skull base in cases of post-traumatic CSF rhinorrhea. So the probable sites of leak are the sphenoid sinus, the ethmoid sinus, either the anterior or the posterior ones, the cribriform plate, the frontal sinus, and sometimes the site of leak can be multiple. The incidence of leak are mostly in the sphenoid sinus, accounting for almost 50%, followed by the cribriform plate, ethmoids, air cells, account for around 17 to 16% each. The frontal sinus around 4%, and multiple sites was around 11%. The skull-based CSF leaks can be caused by several mechanisms, and 80% of them are because of craniofacial trauma and skull base fractures. The another 16% is iatrogenic because of endoscopic skull base surgery, and the rest is because of a congenital defect of the skull base. Talking about the surgical approaches, there are many ways to skin the cat. So starting from transfacial extracranial approach, we have the transcranial intradural or the extradural approach, transseptal, endonasal, or sometimes maybe a combination of all. As we all know that transnasal approaches have earned the flavor of times because of its less invasiveness. And at the same time, we all agree that endonasal closure has revolutionized the management of CSF rhinorrhea due to its less morbidity and better closure rate. It is usually best suited for small defects in the cribriform plates, sphenoid sinus, and the ethmoid sinus. However, the transcranial approach also has some of the advantages, especially in case of high pressure leaks, large defects, and laterally rotated defects. The transcranial procedure should be the procedure of choice in case of frontal sinus fracture post-traumatic, multiple sites of leak in lateral position, complex skull base fractures, and in certain cases of nerve injury. Of course, a satisfactory surgical outcome will depend a lot on the exact diagnosis and the operative approach and the surgeon's skill. The surgical transcranial route has been used for more than 80 years now, and the strategy allows us to manage any other facial fractures simultaneously, and it was Dandy who advocated this, and it is still being followed with some modifications. To quote unquote Professor Drake and Peerless, which they had written in one of their books, much of the merit of an approach is a matter of surgical experience. We always attempted to make these operations simpler, faster, and to preserve the normal anatomy by avoiding resection of cranial base, brain, and sacrifice of veins. Approaches are many for the transcranial route, but the commonly used ones are the standard pterional approach, the bifrontal approach. At our institute, we have been using the lateral supraorbital approach for the past 10 years. This is a relatively simple approach and gives a better and fairly well access to most of the anterior skull base and has been used extensively for various vascular and skull base pathologies as well. Even if the CSF leakage has stopped, there is a chance of developing a meningitis because of delayed recurrent rhinorrhea occurs when the dural defect is not clearly and properly sealed. So the objective of the surgery should be a very tight dural repair, and it reduces the chances of a subsequent meningitis by almost 85 to 90%. So microsurgical approaches should be simple and fast, less invasive and tailored, and if you follow these, then the efficacy of surgery and the safety of surgery increases. These are some of the key instruments, equipments which we need for a CSF rhinorrhea transcranial approach, which we are using. Of course, a high-speed drill, ultrasonic aspirator, and a navigation system. So mention about the lateral supraorbital craniotomy. It is a less invasive modification of the pterional approach where the temporal extent of the craniotomy is omitted or minimized. The craniotomy size is around 3 to 4 centimeters, and it is usually in the frontal side. The surgery is done under very high magnification, and this approach can be used in other pathologies of the anterior skull base also. So this is just a picture showing the various craniotomies for anterior skull base approach from the bifrontal, pterional, and then the lateral supraorbital. In certain cases, the orbital rims are also removed. The advantages of the lateral supraorbital craniotomy are the frontal lobes are less exposed, no retraction is needed because the surgical trajectory is such. The superior sagittal sinus is not sacrificed, as is the case for most bifrontal approaches. There is no possibility of breaching the frontal sinus, and no extensive skull base work is needed. These are the structures which we can access through the lateral supraorbital craniotomy. So this is how the craniotomy looks like. And if in a 3D CT scan, if we make a cut, then this is our approach, the opening in the skull. This is the intraoperative view through an LSO, that is lateral supraorbital craniotomy. This is a skull, anterior skull base. The frontal lobe is dynamically retracted, the anterior clinoids, and as we change our retraction, we can approach and access the various parts of the frontal base. This is a schematic diagram demonstrating the physics of operating from a small craniotomy under high magnification, and by constantly moving the microscope trajectory, we can cover a larger area as compared to a standard craniotomy where the craniotomy is bigger but the area of interest is small. This is the viewing angle from the midpoint of the lateral supraorbital craniotomy. Coming to the strategies. So the strategy starts from the positioning to the craniotomy. Slack brain is of course important, brain protection, harvesting a pedicullated periosteal flap, and a split bone of the craniotomy flap. Positioning is quite standard as per principles. The head has to be high above the cardiac level. Fixation, I prefer a fixation in a Mayfield or a Sujita clamp. The rotation depends on the location, but what is more important is, apart from these, a slight extension and head rotation, we do a lateral tilt of the head. So this is the lateral tilt. So this basically elevates the anterior skull base and we can directly go inside. The preparation of the skin is standard, but what is more important is the incision is around 7 to 9 centimeters long, just behind the hairline. And a single layer flap is taken. We do not open the temporalis. We do not take a flap of the temporalis muscle completely. The eyebrow incision gives a very similar access, but the only drawback is harvesting a large pediculated periosteal flap is a challenge. Splitting of the temporalis muscle is usually restricted to the anterior and the superior part, and usually around 3 centimeters is enough. This gives a very good cosmetic results, and we usually like to use a periosteal elevator for dissecting of the temporalis muscle. How big the craniotomy should be? Well, it should be good for the patient, good for the surgeon, and good for the lesion, or maybe in the reverse order. The aims of the surgery should be to reconstruct the anatomy of the cranial base, prevent CSF leak, meningitis, and mucocele formation, optimizing the cosmetic outcomes. So a water seal of the dural repair is the key to reconstruction of the anterior cranial base injuries. This is how we take the periosteal flap. So the pedicle is here somewhere near the temporalis muscle, and it extends till the end of the skin flap. A 3D CT image showing the anterior skull base through the proposed craniotomy, and this helps us in planning. This is just a diagrammatic representation for the residents. So this is the brain, the subarachnoid space, and this is how the arachnoid pouch comes out through the subdural space, dura, epidural space, and then the bone. And this is how we actually plug in the defect. First, we use a dural substitute or a fascia which has been harvested from the thigh for the intradural repair. Then the vascularized flap is put exteriorly, and both these are sealed with glue, and if possible, with the jeweler's set, we put a couple of stay sutures over there. Then we plug the bony defect with fat, and we put a bone or a bone substitute. This helps as a buttress to prevent the CSF pulsations trying to repenetrate through the bony defect. This is how we put the glue between the fascia and the bony defect. So once we have the bone flap and we know the size of the defect, we try to take a split bone graft. How we take this? We usually use the ultrasonic bone knife. This maintains the viability of the bone, and at the same time the cutting is quite accurate. There is injectable hydroxyapatite which is available, but again the cost and availability is a factor in our city. But if that is available, injectable hydroxyapatite is a very good substitute for bony reconstruction of the skull base. So these are the Sonopet knife tip selection which we usually use. This also includes the bone shaver, sometimes to shave and decorticate the surrounding bone of the skull base where we intend to put the graft. The end result is something like this, which we have. So selecting the treatment modality, I think we as neurosurgeons should trust and realize that opening the head is not dangerous. Why I have to say this today is because with change in strategy for vascular pathologies from microsurgical approach to endovascular approach, the next generation of neurosurgeons, their confidence and bias may be towards other modalities but not microsurgery. So it is very important to practice microneurosurgery to its highest level to match the minimal invasiveness of endoscopy, maybe something like a black belt in microsurgery. And for this, I think we have to train and live with the microscope. It's important. Use the mouth switch. Use high magnification but few instruments. Operate skin to skin. This is very important for all the junior colleagues of mine. Operate skin to skin under microscope with the mouth switch if you have. Learn to use the microscope like any other part of your body. And this art must be passed on to the next generation, maybe to those who deserve. So train your best young people and they will become better than you. Thank you.
Thank you for this presentation. Just a very small question. In case of multiple site of CSF leak, how you do you find out the leaking? Are you using some, for instance, fluorescence intradural or contrast medium or what is your suggestion?
So usually what I do is I do CT cystoscopy preoperatively, and routinely I use a navigation. So with the navigation, they can guide us better because the shift is not very important when we are repairing the skull base. So they give us the precise location as per the CSF cystoscopy, CT cystoscopy images.
Okay, thank you.
Thank you. Thank you.
May I invite our next speaker, Dr. Anil Kochewala from Jaipur, about bilateral chronic subdural single-stage surgical peristalsis.
Good afternoon, dear delegates, faculty, and chairpersons. I welcome you all once again on behalf of the Working Committee of ICRAN 2024. And we all know that SDH is one of the most commonest pathology that we encounter in our neurosurgical journey. And even those who are not neurosurgeons, those who are doctors, when they hear the diagnosis of subdural hematoma, they know that it has to be referred to the neurosurgeon. But recently there is some murmurs that whatever work being done by neurosurgeons is not enough. And they have a reason so, because the past 100 years, there are every episode, every journal, every issue have a article on chronic SDH with modification in some technique. And based on that, keeping our theme is stimulating innovations in neurotrauma, I will be presenting my work on bilateral chronic SDH. Unilateral chronic SDH, we have plenty of studies, but the work is scanty on bilateral, and there is no protocol, universal protocol for bilateral SDH, and they often stated as the poorer outcome and more recurrence in compared to the unilateral SDH. So we did some literature review, and in past 10 years, the paper published in JNS and Journal of Clinical Neurosciences, they said the use of drainage, closed drain, improves the outcome. And the few studies from Japan, they say that it is have higher recurrence and poor outcome as predictable, because the disease is on both sides. And when disease is on both sides in compared to the one side, obviously everybody have a high chance of the complications. So we go basic to the pathophysiology. Chronic SDH, apart from acute SDH, it is not just raised intracranial pressure. There is an inflammatory process which is going on. So based on that, the 200 years old philosophy that when the skull is intact, the volume of brain, blood, and CSF is constant. And by any means, if this distribution is disturbed, even the single burr hole helps. So this is the basic, that surgery is the mainstay of chronic SDH, which I will show in my further slides. And second is that chronic SDH, in addition, have a membrane which encapsulates the hematoma, and opening the membrane ensures the flow of CSF all over the convexity. It is a kind of, we can say that in cystinostomy, it's all about CSF flow. In chronic SDH, it is the CSF which cannot circulate over the convexity. That's why the patients presents variably. In our series of last 7 years, we had 33 patients who had bilateral SDH. Mean age was older, the patient ranging from 60 to 96 years, and mostly were males. The cardiac comorbidities are most common, and 50% of patients were planned. The planned patients were the older age group. The younger patients, 60 to 70 years, were taken to the surgery immediately because they had poorer neurological status on arrival. So when we move from left to right in this, these three CT scans, we see that the thickness of SDH is increasing, but the pressure is not that high. So in first scan, there is not a single sulcus which is visible. The patient arrived to casualty in status epilepticus in M2 status. Second patient arrived and in night, but we planned the surgery on the next day because he was little bit stable. And the third patient is a 96-year-old patient. Sulci gyri were visible. I will later on show about what happened with this patient. The second thing, when the patient arrives, diagnosed with bilateral SDH, we look for whether it is symmetrical. Symmetrical means the same procedure on the both sides. And asymmetrical means there will be some difference in the approach on the opposite side, which does not have the thickness of SDH in compared to the other side. And even in this case, you can see that the patient have the minimum SDH on the right side, but once I remove the left side of SDH, it will increase because the pressure is very high in the brain. Based on the density, thickness, and hematoma, 80% patient fall under the normal procedure bilateral burr holes. 3 patients had required just because the strip of hematoma was very thin, 1 burr hole. Mini craniotomy was in the initial cases. In 33 patients, the mini craniotomy was when in the beginning, 2017, 18, 19 years. Now we just do the burr hole. And 1 patient required the craniotomy because of the hematoma and neurological status of the patient. Once the bone work is done, the chronic SDH evacuation leaves such a big dead space that if the hemostasis, extradural hemostasis is not pinpoint, if there is even a slight trickle of blood, it will accumulate and the scan will look dirty. So extradural hemostasis, which includes the part of the MMA embolization, which the radiologists murmuring these days that MMA embolization is a big thing. It is covered in surgical procedure, one of the stages. And after SDH evacuation, the opening of the membrane, which makes the difference because the CSF is flowing over the convexity. And this is one of the case in which the SDH was so thick, patient was M2 status. We took to the surgery immediately. Membrane was stripped in post-op. Next day, patient was ready to go home. And all the patients, we put subgaleal drain because for 24 hours, we have opened the convexity subarachnoid. CSF is coming, and we want the CSF flow should be across. So drain negative effect works in such a way that whatever is unnecessary collection, brain keeps on expanding, and the residual collection comes out through the drain, and both the drains are exit from the skin in such a way that they are connected to one tube, and the patient can lie supine comfortably. This is the first case, end-stage renal disease, 70 years old male, thick SDH. Because we cannot, the nephrologist said that the kidney is damaged to such an extent, we cannot give extra line of antibiotic. That's why I did not perform any crinotomy in this case. Burr just because single antibiotic, burr after 2 days the patient was discharged. Another patient in which uneven thickness, but luckily patient had MRI outside, which showed that the SDS thickness is need to be evacuated. Pseudomembrane was opened, and the patient recovered completely on 2 weeks follow-up, radiologically and neurologically. This is another patient which I showed that the patient is alcoholic, was seeking treatment for alcohol rehabilitation. So the patient arrived for the psychiatrist. It might be related to withdrawal symptoms, but on imaging, first the MRI was done. There was a bilateral SDH hint. If I would have not done the MRI in this case, I would have missed the opposite side of SDH. It was thin SDH, evacuated, and the complete recovery over the period of 2 weeks. This is another case in which the SDH was thin. This case was done in earlier years, 2018. So mini crinotomy was done because the strip is so superior. I was not sure that burr hole will able to evacuate the completely. But in later stages, whatever cases I'm doing, the burr holes is sufficient. This patient primarily admitted under cardiology for aortic stenosis, valve measuring 5 millimeter. So they wanted to do catheter valvular replacement and asked me that make sure that there should not be even a single drop of blood in post-op scans because they are going to give high doses of heparin for the valvular replacement. So in the left side, there is a hint of acute component of SDH. We performed the mini crinotomy. Patient had complete recovery and cardiology procedure was done. This patient, the grandfather of my colleague, doctor, ENT doctor, and the patient came during the COVID days. Patient was COVID positive and dull and drowsy with the degenerative diseases. So on arrival, we reached the consensus that let's wait. The COVID symptoms should subside, and it acted as a blessing in disguise. The hematoma got converted into the chronic, but you can see in the first, where the hematoma is acute, the sulci are visible, but the hematoma is chronic, not a single sulci is visible on the right side. But same procedure, SDH evacuation, opening of membrane, patient did well, and he is living, he has become recently great-grandfather and living fine. The another patient, 96-year-old patient, in single burr hole was done on the opposite side, where the thin SDH, if I remove the right side of SDH, I know that the left side will increase. This patient had fibrous dysplasia of bone and bilateral symmetric SDH, arrived in OPD almost intact. We gave a trial that they were not agree that both side surgery will be done. The relatives were not agree. And when I opened the bone was so bloody leg that you can notice that every burr hole have a different dimension, because I did not proceed further until I made sure 100% hemostasis at the burr hole. I kept on drilling, coagulated each or waxed each bony bloody leg, and the patient recovered fine at 2 weeks. The patient, fine art worker, and the patient was diagnosed, arrived in night, but neurological status was intact, and he was taking antiplatelets. So we waited. The same procedure was repeated and patient had complete recovery. So at 3 months clinical and radiological follow-ups, there was no morbidity, there was no redo surgery, except one patient had wound dehiscence and one patient of end-stage renal diseases in which we didn't give antibiotics, required IV antibiotics later on the dialysis cover. The patients, I work in a corporate hospital, and especially these old age patients, they belong to influential families. If I give them option that this will be done in next step, they already come with 10 opinions. We want to do this. So I give in single stage, I will take it out completely, don't worry. So I don't think that even if it is not symptomatic in opposite side, MMA embolization will be useful. I think just making one burr hole doesn't make much difference. It adds just 20 to 30 minutes. Yeah.
So one more thing, you put subgaleal drains in all of your cases.
Yes.
Why not subdural drains?
Subdural, because for removing subdural drains, I have to be there. Subgaleal drains are safe. You don't have to think. Just put it, keep it negative. Even the drains are not over the burr holes. I create a tunnel. I create a tunnel around the burr holes. So it is safe. Even the resident can remove. Subdural drains, the monitoring issue is higher.
But it is shown. It is shown in literature.
But the subgaleal drain is working fine for me so far. So the second thing is that opening the membrane makes this whole space one. I hope you understand. After closing the suture, the whole space is one. The membrane is open, CSF is flowing over, the whole space is one. It doesn't make any difference. Where is it?
So are you putting negative pressures in your?
Yes.
Okay. And then is there any case of CSF fistula or leak?
No.
You noticed?
No. One patient which had wound dehiscence had severe betadine allergy.
Thank you, sir.
Yeah. Any other question, comments? Okay, thank you.
So, thank you very much. We next invite Dr. JKB Pratibhan from Chennai. He will be talking on literature, myths and facts of basal cystonostomy.
Thank you very much. And I prefer to choose this topic because this is one of the hot topics which is going on for the past 10 to 15 years. So I like to provide some summary of what I have learned over a period of time. How to move this? How to move to next slide? This one. Okay, see, these are the steps. You do your frontotemporal craniotomy, go towards the pterion approach, crawl through the subfrontal approach, reach the optic nerve, and then you can reach the optico-carotid cistern, and then enter between that, you find the liliquist, open the liliquist, give a good wash, you will be in the prepointing cistern, wash it out, and then you put a drain. So this is the basis of the cystonostomy. And what we see is that when we start practicing, you find such a large edematous brain becomes like this, like very quiet, and then you can put back the bone. So this is the basic concept. This is the basic concept of cystonostomy. And there's a few case report like this. You can see the severe edema here, along with the contusion. This is the post-operative picture, the final picture after cystonostomy. Another case you can see here. In this case, you can see the cerebral edema here, severe, and this is the drain, preponderant drain here. And subsequently, it becomes better. In this case, we had done removed the flap here in this case, and this is the final. In 2 months' time, patients get a good recovery. Now, after showing this, I like to now go through the literature for all of us to know. These are the scientific articles. These are the scientific articles which cover some basics, some pathophysiology, and hence the surgical rationale of cystonostomy in traumatic brain injury. This is, I go from the 20 near to the later, but in 2023 and 2022, you find so many papers published. So many papers published on this subject, directly or indirectly, with the glympatics for the neurosurgeon from Randall Sheffi. And if you see the very good papers, if you please have to go through this, then only we can understand the value of cystonostomy. So this is about the glymphatic system, which is being proposed not now, but it is far, far away. But then it is, we are getting more understanding now only. And then there is a very beautiful paper here, and you can say call for a medical education reform by Travis in 2022. And we have to go through this paper so that we can understand the dynamics of the CSF. And once we know the dynamics of the CSF, then the whole management of TBI will change. These are from 2021 to 2022. This is about the CSF shift. What is happening to the CSF shift? Then when there is a head injury, then you have the CSF accumulated. Suddenly the CSF enters into subarachnoid spaces through the Virchow-Robinson space, and then gets dissipated as an extracellular fluid into the brain parenchyma, and then so you have a severe edema. Now, if you can allow this, then you can reduce the edema. So these are the basic scientific papers between 2020 and from 2020 to 2027. There are some papers which are very nicely by Nethergaard. Cerebrospinal influx drives out this acute ischemic tissue swelling. We have to read this. We have to read this in 2020, and there are so many other papers which talk about CSF shift and influx, and then the brain cooling, which are found by Aicherian thinks about a lot, and so he has made a few of the articles in 2027. From 2016 to 2013, we still have a lot of papers which talks about, we go from the glymphatics, then now we come to cerebrospinal fluid mechanisms and its coupling with the cerebrovascular dynamics. And so you can see that so many people are thinking about it, and they are writing articles from up to 2023, and down the line from 2023 to 2026. Between that period, there more papers were about Virchow-Robinson space. So these are the earlier papers. Now, if you see until the aquaporin, which was the first thing which came in 2006. So when you collect these articles and start reading it, you need a lot of time to read on these things. But when we start reading it, then we understand very, very good. Now, I do have to talk to you about scientific articles for surgical procedures. Now, what are the scientific articles from surgical procedures in 2023 to 2022? You can see here, these are the articles which are published by various group of surgeons who have done cystonostomy, and their results have been brought up in a different type of papers, including that one paper from Manish from North India, which was there. I'm not able to include that in this. It's a triple center study. So there are at multiple places the study is being conducted, and the results are pouring in. Now, following this in 2021, this was my work which was published in 2021, and then there were also other work from Switzerland. There are a lot of work on this subject, whether to do it as a to do it as an adjuvant procedure or do it as a primary procedure. So there are much talk is going about the surgical aspects of this technique. From 2019 to 2018, again you can see we do not know what is happening in China, because there is so much of work is going on in China. It is getting published in Chinese literature. So we do not know, because we read only the English literature, which is really it's a minus point for us to understand what is happening in the research, because Wang is doing quite a bit of work on this subject, including the physiology. Now this is Chinese, and then you can see the Switzerland's work. All these things, most of these papers are also on the surgical aspects of cystonostomy. And the best and the first one which came was, as we all know that Aicherian did presented that in 2013 officially, though he started the work in 2007, 8 or something like that. Now we took up in India very fast and then we started doing it. To just talk about my work which we did, I just give a few slides. Now this is what we have done, the severity of the injury. If you see the 72.5%, that is 29 patients were in the severe head injury category, and we divided. We are not comparing this with the decompressive craniectomy. All these patients are cystonostomy patients. One is the BC, that is what we call BC means that we put back the bone. When we say BC plus DC means that we are removing the bone. So that group is very small, this group is large. So of the 40 patients, 27 patients I had done at the BC alone. Overall, the 40 patients, I had a very good success rate overall outcome. If you see the favorable outcome, it is 82.5%. This is a very big result. Now I compared this with the BC, where we put back the bone and where we have not put back the bone. If you look at that, 85% we get a better result when compared to 76.9% to do that when we do with the DC. For this, I will come to it later on what my observation in the last. Now this is, see the severity of injury. Now we have to see, we are talking about severe head injury patients. If you see the severity of the injury, now here you can see this, this group where BC alone, 77.8% becomes better, but whereas here you can have only 72.5% of the patients are better. So overall the BC alone is giving a good result. Overall, this is my observations. So what are the observations and some of the take-home points which I thought was a lax brain that facilitates replacement of bone flop following cystonostomy indicates and predicts a better outcome. Number one. Number two, a moderately lax brain following cystonostomy which prevents the bone flop being replaced indicates a less favorable outcome. In malignant cerebral edema, the cisternal drain will be dry. If you go to the cistern, even if you manage, the best surgeon manage, it will be dry, it will be mixed with a thick blood. And those patients don't do well. They are the bad cases. Either I have taken the patient for a wrong, that may be for 1 or 2 cases which I had performed. I will finish it fast. So it is prudent to give a trial of medical management in severe cerebral edema patients. It is wise to offer surgical management at the earliest in the form of cystonostomy, since decompressive craniectomy alone has not provided great results so far for our community. So we have to think about it. For that, we have to, I would recommend please all of you read this. This is a paper with a large numbers, about some 35 pages. It's one of the best things that we have to learn, where it has even criticized the Dandy's work. And because we have evolved scientifically, we learned that whatever done was very small, because we were following with one single dog experiment, and then we say that ventricular EVD is better. No, EVD is not better. So I would like all of you to go through these articles. And finally, this is in 2024, just now has come. So very hot presentation by one group of Germans. What they have done is CSF after decompressive craniectomy. You do a decompressive craniectomy, and 2-3 days later you put a lumbar puncture. You reduce the complications of the so-called DC. Now, when you do the same thing, when you do a cystonostomy at the time of surgery itself, you can prevent it. That is what the Swiss group has argued. But if you look at that, whatever the minus points, what they have said is, as usual, that is where I come to the myth and the facts. Cystonostomy cannot be done by senior registrars and young neurosurgeons. But the fact is, it is our duty to train them in microsurgery and encourage them from the beginning. The other myth is cystonostomy is very complex and it is difficult to reach cisterns. The fact is, the procedure needs training and it is doable. With patience, basal approach, and soft handling, it is always possible to reach the cisterns. It is impossible to get all facilities like microscopes in emergency situation at uncomfortable hours. The fact is that efforts are not made to get them in time, and it is a lame excuse. The teamwork is very important. Cystonostomy does not work. It is not better than our standard decompressive surgery when done alone or in combination, like everyone says. The fact is, when we believe and accept the CSF drainage in the form of EVD is true, so why will be cystonostomy when we do and realize ourselves? So the thing is that we have to do first. For that only, I think we have started a small group now to study on this at the global level. Yesterday, we started this group. So this group is going to start working on. Now, when we say from the Indian subcontinent, sometimes it will be more difficult to, because we are more free to do techniques like in the Chinese counterparts, in the Asian counterparts, but it may be difficult in the Western part of the world because we may have some protocols, right? So for that only we have formed this very mature academic group, and this academic group will form over a period of time how we will work on this research and come to an analysis in the coming day. Thank you very much.
Thank you very much, sir. Wonderful observation. My only question is, when you're planning to do this research, are you going to go for double-blind control trial, which is very difficult to do in this part of the world?
It is tough. Yesterday we had a brainstorming short session in a small room without some even big lights. We are planning for that kind of work, but it is going to take long time because it is going to serve the global purpose, not the regional purpose. The idea is that, can we do this equally in every place? Because why DC is so popular? Because it can be done equally everywhere. You just throw out the bone and open the dura, that's all. Anybody can do it. General surgeons were doing it. But cystonostomy is a microsurgical procedure. It can be done only by the neurosurgeons, and it needs microscopes, it needs technical efforts. So we need to train. Now everybody cannot do it, we agree with that. But there was a big argument that, I cannot come in the night and do it. Okay, fine. Now you can't come in the night, but you have to produce a surgeon who can come and do it. If a boy who speaks at the age of 35, if he can't go and do a cystonostomy, I doubt that he'll become a better neurosurgeon, because he has to practice at the age of 25, 28, 29, 30. I mean that way. 50 years, 60 years, yes, I agree. Some surgeons find very difficult to come in the night, but you can have your team spread it out and nicely groom them well. So the basic thing is the training. The other day we had a very beautiful cadaver workshop, and we focus on that. In the cadaver workshop, the focus was only that how to train the young neurosurgeons in this subject. And fortunately in India, Indian young neurosurgeons are very, very fortunate because they are seeing plenty of these cadaver workshops, and they can see plenty of videos. We are doing enough, so they are seeing it.
And plenty of workload too.
Plenty of workload too.
So very nice talk. Definitely the cystonostomy helps, but as we can see in your study, there were two arms. One was pure cystonostomy, another was cystonostomy plus decompressive. The selection into the two arms was not equal. You kept the patient in DC because you could not put back the bone because of the bulging brain. So is it justified to say that basal cystonostomy alone group was better, the results were better in BC alone group versus BC plus DC?
No, that's why I'm telling you. See, whenever we are able to put back the bone, we do understand the brain is slightly better. It is not that badly damaged. That is the outcome we are seeing it in the final result. When I am not able to put back, that means there is edema which has gone beyond your limit, and so the results are going to be delayed. The outcome. This is my classical observation. I always tell, you're not, if the brain goes below the dura, oh my God, this guy is going to wake up very quickly. If the brain is just up to the dura, okay, but beyond, while this is so much, it's beyond, then after your cystonostomy you can see. Another beauty thing is observation is how much the CSF gush out. That is a very beautiful. So, personally, I feel that we should stay put patiently in head injury patients.
At the same time, when your midline shift is more than the size of the cloth, that they don't do well when the
Yes,
midline
yes,
goes more
all,
than the same
yes,
size.
yes, all aspects taken into account.
And you're planning to do double-blind trial just to answer these questions.
Yes, 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 in a wider
So,
way.
yeah, selection of the selection
Yes.
criteria for the patients, which arm they should go their shift.
Yep.
Any questions? So, thank you very much, sir.
Thank you, thank you.
From the optico-carotid space, and for how much days we have to keep this drain inside.
Okay, so these drains can be placed up to 5 days, approximately 5 days. But I have extended even up to 7 days, depending on the patient's improvement in the ICU. Basically, you know, if you keep the drain, you can see approximately 150 cc of CSF comes out every day. Sometimes more than 200. So it's very bad. So we have to keep it at the higher level, and we try to keep it at 150 cc to 120, 150 cc, something like that. For 5 days, it is fair enough. It is just like equal. There were a lot of questions about the infection rate. That also I studied that. You know, it is not much compared to the EVD and this procedure. Actually, this is you are in real time. You do the system. Real time, you do the CSF diversion, CSF drainage. Thank you very much.
Thank you. So, can we invite Dr. G.V. Ramdas for his talk on my journey with cystinostomy?
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the organizers and Providence also for getting this opportunity to talk to you. And it's an honor I would feel, because this is the burning topic of today. It so happened Professor Ibe had to give his talk about the journey of cystinostomy. Now he had to leave because of some urgent problem. So I step into his place. I'll keep the topic the same, cystinostomy today, but I'll change the perspective. So to understand this perspective, a little about me. I'm a retired Army neurosurgeon. I took my retirement in 2011. My training was at All India Institute of Medical Sciences, New Delhi. 15 years, I had the best of practice with the best of the institution, with the best of the equipment. Then when I came out, I had to choose, what do I do now? So there were two ways for me. One is, look out for another good institution, go and refine your skills more and more and do more exciting things. But by then, I was more attached to the neurosurgical morbidity. I mean, the difficulties the patients and the attendants were facing, they influenced me more. And in a country like ours, it's very heterogeneous. In Delhi, you have the best of the facilities. You go 100 kilometers away, there is nothing. So I used to interact with those doctors when they came for the conference. So that motivated me. I have the skill. And the industry was putting a different kind of pressure that without equipment, you cannot do good neurosurgery. So somehow I didn't agree to it, because in 99, 2002, equipment was just getting into our country. So this motivated me to go to the 2-tier and 3-tier cities and show them the way. I would pick up small hospitals, make a team with the local resources and do. Now this enthused me further. And then I had the opportunity to go to African countries. I went to Congo, Kinshasa, where I developed a center there. And then I went to Uzbekistan, where, you know, they're struggling with the basic medical education after the separation from Soviet Union. And many patients would come to India on medical tourism. So on their request, I went there. I worked there for 5 years. I could develop 3 small centers there. They're basically small units, single neurosurgeon-based units. Now, with this little bit of introduction, I hope you understand the perspective. So, I took the choice. And the perspective I gave you is of a small neurosurgical unit handling neurosurgical maladies. The humongous component of the neurosurgical morbidity is traumatic brain injury. So I would relate my journey to this aspect, although I did the full spectrum of neurosurgery, but today it's relevant to talk about this. Now, this is exactly the opposite of Professor Ayub Cherian. Like, he focused, he was also probably wanted to make a change, but he went into a technique, he evolved a technique, he understood the physiology and found out another venue of improving traumatic brain injury. I look at it this way: decompressive hemicraniectomy was born out of inability to put the flap back and close. It is not a procedure which was evolved to treat traumatic brain injury. So there was a need that we understand. And then we do something better than what we did over the last 1 century. So the thought process was the same, but the directions we took was different. I tried to go more deeper and then expand. He went more deep. Now, when we are confronted with a scan like this and a patient with a GCS less than 8, so what are the options left for us? To look at, overall there is edema, but not much of damage to the brain as such. But it is daunting what to do. Here we are seeing only the swollen brain, the physical part, but the physiology of the secondary insult, the change in the dynamics which are happening. All of us, I have seen many young neurosurgeons here, the second you take out the bone flap, you get the feeling somebody is blowing a balloon and then the brain is just coming out. You're helpless what to do. So in this situation, we try to go in aggressively, remove as much as possible, and try to, in a hurried manner, close the head. If you cannot put the bone, you take it out. So I always felt, as a resident, this was the first surgery I got to do. Imagine, see, look at the paradox. The least trained person is doing the most difficult. It's like sitting on a wild horse, which has not been broken. Whereas we find our professors sitting in the best of the equipment, opening their subarachnoid cisterns for an aneurysm. Whereas this we found as residents, we didn't know how to go about. But finally we learned the hard way. So here, I would present the practicing neurosurgeon's point of view. Now, handling the brain swelling was always a problem. Now, it was an uncomfortable option for a neurosurgeon, to create space and then close it somehow and remove the pathology. But did that translate into improvement of the neurological function? No. Now, then various procedures came. As residents, we were told, remove the frontal pole, remove the temporal pole. Then they wanted us to add sectioning of the tentorium. The initial thought process was, your brainstem is getting compressed, so you release it, probably the outcomes will be better. But probably what was happening is we were opening the cisterns, and then we would see, when you cut the tent, the whole brain would settle down. And it was much easier to do. So maybe serendipity there. Now, large craniotomy was advised. The larger the craniotomy, more were the problems. Closing was an issue. And if you ever have to do a cranioplasty, I'm sure the previous speaker has told us all the problems there. So here, we found cystonostomy has come as a boon. I'm sure all of us who are doing it, at one stage, when you are retracting either the temporal lobe or the frontal lobe, you will see that the cistern gets opened inadvertently. And so many times, it's so easy to handle those brains. Now, cystonostomy probably, these kind of inputs over a period of time was systematized. And today we are all talking about cystinostomy, the procedure, and we have seen the literature which has accumulated over the last decade and a half. And probably this is the way forward. Now, these are a few, I don't want to go into the details because my previous speaker has already, in an extensive manner shown this thing. And day before yesterday, we had the wonderful opportunity of, showing to the junior colleagues who came for the workshop how to do the procedure. So this is a typical example how, cystinostomy improves the cerebral dynamics of the intracranial cavity. But more astounding is the clinical improvement which we see. I mean, most of us who are doing it, it is very difficult. We cannot accept. Usually in a severe brain injury like this, you expect a post-operative morbidity lasting for about 15 to 20 days. Now we see these people getting up in 3 days, 4 days, and we are discharging them on 7 to 8 days. Now you may call it episodic, sporadic, yes, because for a man, at my perspective, in a small unit, I don't have the infrastructure or the capability to give you the evidence the way it can stand a scientific testing. So that is the reason I'm very glad I get this opportunity in a forum like ICRAN, where we are talking about recent advances in neurotraumatology, and we need the support of organizations like this to take this forward. So here is a couple of examples I gave. Now, there are 2 randomized controls we had in our country. One is Manish from Lucknow, KGMC, and then another from Ramesh Chandra. This is probably the one he didn't quote, so I thought I'll just show. This is the latest one which has come. And this is just the beginning to formalize. And today we have evidence, but we need to sieve it. We need to identify the procedure, identify the subset of people, because traumatic brain injury is a heterogeneous group. So how to standardize, how to identify? Now it is a process, and it's a lengthy process, and I feel here the role of the whole world coming together is very important. It is very easy to say how you cannot do, but what we need to do is we need to find a method of telling how to do it. So I make it simple. If I show a video showing how the forceps is going carefully into the opticocarotid cistern, it looks very daunting. What I want to do is, this is as simple as this, because this is my perception. All I have to do is, I don't retract the brain, don't open the dura first, reduce the bone, make space. So when you do that, you find the orbitomeningeal band holding the temporal and the frontal together. You just release it. What you see in the floor is the anteroclinoid process. To drill the anterior clinoid extradural is made out to be such a difficult thing. But I'm sure any surgeon who has been operating for 4 or 5 years and knows how to use a drill like a brush, it should not be such a difficult thing. And the reality is, do we need to take out the clinoid in all the times? No, not required. And then all it calls for is open the dura close to the cistern. Do not open in the middle of the sylvian fissure. Because the second the brain starts spouting out, it creates confusion. So I want to convey a simplistic view of how to do cystinostomy. If you go close, you put the retractor and you open, by which time probably you've already opened the intraoptic cistern and some decompression will occur. Just wait. It will give you enough time and space to put another retractor, go in and open the opticocarotid triangle. So, I mean, I found it easy. You might say because of your experience you find it easy. So we have fellows coming, we're doing cadaver workshops, we operate, and our residents are doing it. So where is the change? The change is in the attitude. Now to make something, if the Muhammad doesn't go to the mountain, we have no choice, we've got to pull the mountain first. So This is my perspective because I was the Muhammad waiting there. So now the perspective is we have to make the procedure safe. We have to overcome the problems in a limited resources scenario. It is very difficult to give you the scientific, kind of material for somebody to test it. We want help for people to come forward and guide us. And because most of the practice of trauma is done by, neurosurgeons at a small level. Because time is very important, time is brain. The first responders are the junior and peripheral neurosurgeons, not the trauma centers. Some of the countries are very lucky to have an organized trauma setup. But if you see the population, it's in China, India, and the African countries, not in the European countries, where they are well organized. So we got to go, the mountain has to go to the Muhammad now. So what to do in the absence of a definitive evidence? Evidence will only happen when you act. So we need guidelines, we need this, and we need such forums where, we have very powerful people here, and the connectivity is now very easy. So I would like to conclude by saying only one thing. There are foot soldiers and there are leaders. Foot soldiers can work, they can't lead. But the leaders have to make sure that the foot soldiers go in the right direction. And traumatic brain injury, mind you, if we can handle this, it is a social malady. We'll do a lot to the world and to humanity. So at an individual, what are we doing? I have joined Professor Wright. We have an institute at Karad. We have a cadaver lab. And because of the kind of awareness which is there today, over the last decade, we've been having fellows. More than 1,000 people have come to our center. Initially it was in Nepal, now we're here, we're developing it. So what we are doing is, we show them what we are doing. And then they see us, they learn some techniques, we clear their doubts. Now many of them are going back and doing it at their level. Now, when things start happening, when the need is there, the use will happen. One example is, Taliban use mobile phones when they don't know English. They are organizing because they have a need for communication and they've evolved a technique. They use 0-1 numerical technique. They don't have a language to communicate. Corona came. How quickly we produce vaccines. A medicine to go through the trial and become accepted takes 20 years.
Dr. Ramdas, may I interrupt? Wonderfully summarized, really, and eloquently, wonderfully summarized. Wonderful, thank you. Now we need to proceed to further. Next one, Dr. Xian. Sorry if I pronounce it wrong. Jian Huang. Individual treatment of hydrocephalus. Is he around? This is pre-recorded, yeah.
Dear professors and colleagues, good to see you again. It's my great honor and pleasure to share my topic here. I am Dr. Huang, come from the First Affiliated Hospital of Shenzhen University, China. Today, I want to discuss the treatment for hydrocephalus post-traumatic brain injury. As we all know, there are many kinds of complications happen in patients with TBI, including delayed reading, infection, hydrocephalus, school defect, etc. Hydrocephalus is the normal complication in patients with TBI, and it always happens in patients with decompressive craniotomy. Most patients with hydrocephalus are easy to cure, but we should pay attention to the abnormal ones, for example, subdural hydrocephalus. Otherwise, we will treat it in a wrong way. Hydrocephalus is generally divided into the following types: communicating hydrocephalus, obstructive, normal pressure. These three kinds of hydrocephalus are common types. And the mixed hydrocephalus means combined with multiple types of hydrocephalus. Complex hydrocephalus means combined with other complication, which resulting in imbalance of ICP, and this kind of hydrocephalus is very difficult to be treated. I will present a case of this kind of hydrocephalus later. When we face a patient with the suspected hydrocephalus, we can diagnose hydrocephalus through the following characters: clinical symptoms, including disturbance of consciousness, gait instability, urinary incontinence, and medical imaging with the clinical evaluation. Before we make a decision to the patient, lumbar puncture is needed for examination and pressure, and the CSF velocity is also important. MPH is a concern in an aging society. In the clinical evaluation of MPH, we need to perform lumbar puncture, test the gait disorder, MSE, and so on. However, when we treat the patient with hydrocephalus post-TBI, it's not as simple as it appears. These characteristics of hydrocephalus after TBI, including the uncertain duration between trauma and hydrocephalus, the relationship between subdural fluid accumulation and external hydrocephalus is intricate and complex. Some patients influenced by the decompressive craniotomy or with infection factors. The treatment of hydrocephalus includes the following methods. Thumb surgery is the most widely used method. Fistulization and choroid plexus caudalization may be done by neuroendoscopy. There are complex hydrocephalus. The first one is the ventricular septal defect by hydrocephalus. The second one is the asymmetric hydrocephalus, imbalance of the ventricles. The third one is isolated fourth ventricle. And the fourth one is the external hydrocephalus. All of these kinds of hydrocephalus are difficult to treat it. Y-Wolf is the special device to treat the complex hydrocephalus, so we need to treat it in individualization. Various factors lead to multiple obstruction or of the CSF circulation, or obstruction and impair absorption of CSF, or change in the character of CSF made the simple ventricle shunt cannot achieve good results. Eventually, multi-site obstruction result in local intracerebral hydrops in intracranial cyst, WRF, and compartmentalization. The most important key is the traditional ventricular peritoneal shunt is difficult to solve. Y-Wolf can help us to break the intracranial unbalanced pressure and reduce the local pressure difference. It can be used to solve the intraventricular and external hydrocephalus. Bilateral VPS can be avoided by use the Y-Wolf. Here is a case. This was a 33 years old female who suffered by a car accident 2 hours ago. Before she came to the emergency room, she had an unbearable headache. The first CT scan showed a fracture on the right side and a little extradural hematoma, but on the left side there was subdural hematoma. We could see the pelvic fractures. The patient's condition changed very quickly. GCS decreased from 13 to 5 with double pupils dilated. We had no time to check another CT scan, so she was transferred to the operation room immediately. Bilateral DC was performed with 30 milliliters subdural hematoma and 20 milliliter epidural hematoma was removed. After the surgery, the patient recovered quickly. Pupil dilated decreased to 3 millimeter. The ICP value maintained in a stable state. She was transferred to the orthopedic department. When she leaves the hospital, CT image indicates more amount of bilateral subdural effusion. Continuous follow-up CT image showed a little more of subdural effusion, but the patient had no neurological dysfunction. Cranioplasty was performed at 3 months after surgery. During the surgery, subdural effusion was removed before putting on the titanium mesh. But the patient felt headache with nausea and vomit 2 days later. CT image showed the increased ICP due to the bilateral subdural effusion. This was a great dilemma to the surgeons. We need to decrease the ICP but avoid the infection. Otherwise, the titanium mesh should be removed. Strict sterilization should be carried out. So we use the Y-type valve tube to connect the shunt catheter from bilateral subdural effusion. Since then, the patient recovered very quickly. She went back to work again 2 months later. Here was the 3D image of the shunt catheter. We can see the Y valve and the shunt device work very well. The patient get a very good outcome. When we treat the patient with hydrocephalus post-traumatic brain injury, we need to evaluate the condition carefully and choose an appropriate method to the patient. Also, we need to avoid all the potential risks. Here come to the summary. CSF is an important part of the school. The balance of CSF is an important factor to maintain intracranial stability. Complicated hydrocephalus and CSF infection cause changes in CSF dynamics. Simple VP shunt is difficult to treat, and it needs to be combined with multiple methods. For example, the Y valve, no infections of CSF is the basis, and the drainage sites are diversified. That's all. Thank you for your attention. Dear professors and colleagues, good to see you again. It's my great honor and
thank you. Any questions about discussions? No. Okay. Thank you.
A very insightful session. Thank you to all the speakers and the chairpersons. Thank you. We'll break for lunch now and resume at 2:30.
To see, but we're going to talk about neurorehabilitation, and we have some formal talks, but I think we should save plenty of time for discussion at the end to improve on our mutual understanding. I'm a neurosurgeon, but I've always been interested in early neurorehabilitation and also later in neurorehabilitation, because I always told my residents we are not treating a brain tumor, we are not treating a spinal cord injury, we are treating a patient with. So we have to be aware of what's happening with them afterwards. So we have to be in a good way of China. But I don't want to make further comments. Some of my co-chairpersons are not here, obviously, but I would like, so all the speakers are here, so I would like to call on Dr. Abhishek Srivastava from Mumbai, Recent Advances Acute Brain Injury Rehabilitation.
Good afternoon, friends. Most of my talk is in this chapter, which we wrote about a couple of years back in the cycle updates on advances in TBI. Also, under a chapter in unconscious state in this PMR book. As you know, TBI has two components: an axonal injury component and a contusion component. Axonal injury will cause loss of consciousness. Contusion will cause focal deficits. The mix of both will decide the long-term outcome of these patients. Also, we know people open eyes, it's vegetative state. When they have some purposeful responses, minimally conscious state. When they follow command as a conscious state. What we don't know many times is that people who are unconscious at 1 month, 50% can be conscious at 1 year. For 3 months is 36%. For 6 months is 1 in 5. So only at 1 year you can say a person with TBI is in persistent vegetative state, not likely to improve. Can we change the brain with brain injury? Yes. Two things can happen. The acute phase, we all know, swelling comes down. You can start some drugs now to improve connectivity in brain. In first few months, brain try to change. You can make that change by intensive training, called as neuroplasticity, or neurotreatments like pharmacological agents, neural stimulation, HBOT. Talk about all of them in short. How to assess these patients? We all know Glasgow Coma Scale. Always remember there are two more scales, very, very important. One is JFK Coma Scale Revised, which is the most important scale to determine patients are in vegetative state or in minimally conscious state. For long term, which is always something called Glasgow Outcome Scale. Now, if you open a textbook of medicine, there is no chapter on unconscious patients, how to improve them. So you can do these 8-9 things. We're talking about short. First and most important thing is to remove obstacles from recovery. There's a big team of people, multiple deficits. Whole rehab in TBI acute stage have 5 basic functions. First, people still have tubes, are semi-conscious, have tracheostomy, RT, Foley's, they have medical problems, but continue medical care. Second, you have to prevent and treat medical complications like pressure ulcer, DVT, pneumonia, LRTI, UTI. Third, give them training for sensory motor function. Fourth, give them training for cognitive cognitive function. And fifth, treat psychological and social issues. We all know there are complications, the big list, all can happen to TBI in the acute stage. You're able to treat these patients as early as possible. You can go for rehab. What you can do, person is GCS 8, lying in the bed, with tracheostomy and a portable ventilator. You start something called as multiple sensory stimulation, multiple times in a day. Mega dash still is shown. If you do this training 10 minutes, 5 times in a day, is better than 30 minutes twice in a day. So provide sensory stimulation. Second, music doesn't cost anything. Represent large brain area function. In one of our studies, we have shown that people in the high dependency unit with GCS 8, 9, 10, better with music therapy. So what we do is something called as pharmacotherapy. Always remember, we go to see a patient in the ICU. There are some bad drugs which hamper brain recovery. If you can possible, try to change to a better substitute. And then, you start any pharmacotherapy for brain injury. Yes, you can use a drug called as amantadine, published in NEJM trial 10 years back. Give to all your patients for 2 to 3 months of time. Z drugs can be tried, no side effects, can be given for at least a trial in patients with vegetative state and minimally conscious state. What's coming in now in a big way is called as hyperbaric oxygen therapy. It inhibits apoptosis, reduces inflammation, neurogenesis. And one of our studies, we have shown patients with TBI who got decompressive surgeries. GOS more than 3 and 56% of patients who got HBOT. It's very good. It's a drug which you can use in patients who have severe brain edema after brain injury. What the review says, Cochrane review says, you can improve GCS by 2.68 points only with HBOT, and recommendation says, my recommendation in favor to improve level of consciousness after brain injury. We should all have HBOT in our units treating acute brain injury to have these patients. Next is tracheostomy. You can decannulate most of the patients, even GCS 8, 9, for simple protocol, do a simple dye test. If they pass the eye test, you can put a speaking valve. It's a one-way valve. You can do a fluoroscopy to see where food is going, and you can decontaminate most of the patients successfully. Also, what helps is early verticality, early tilt-table standing. There are machines to make FES use while on tilt-table to prevent postural drop in blood pressure. Now robotics have come, we have patients who are GC 8, 9 who are on tracheostomy, standing on tilt-table, start step training in Lokomat on day 30, 40 also after massive TBI. We do it for all of our patients now. And one of our studies, we have shown that patients who started in early Lokomat training in TBI, change in FAC and PV musculoskeletal is significant. It's helpful now for even early mobility of these patients. What next is peripheral stimulation. We can do RTMS, we can do TDCS. What's very simple is repetitive median nerve stimulation. Doesn't cost anything, a small machine can be used, simple device can be used, all three devices can have. And research are showing people who are having VS and MCS stage can go one step ahead with this training. One of my students doing a thesis right now in DNB for same protocol. So if you use these acute training protocols, you can help patients like someone like this, massive left-sided injury. He went on walking at 3 months. Another guy with a massive axonal injury and left GC bleed also went on walking. Another guy with massive DI also went on walking without tube. So if you start training very early in these patients, it helps to improve the long-term outcome. Just to conclude, acute TBI rehab means to prevent, to recognize and treat medical complications, provide multimodality stimulation, so low-cost intervention, more effective if done multiple times in a day. Trial medication is given to all patients with VSNMCs at least for 2 months period. Proper tracheostomy care and decongestion protocols are necessary. HBOT is effective when combined with intensive training, and is still increasing step by step. Music therapy, low-cost tool, very effective for multimodal sensory stimulation. Early mobility, early verticality, depending on robotics also help, and peripheral median nerve stimulation is getting more evidence and good option patients with MCS in long term. This is our rehab team. Same opportunity to invite all of you to the next meeting of IFNR Con, which we had in Jipmer, Pondicherry. There are 12 pre-conference workshops, a 3-day meeting, very enriched. Thank you very much.
Thank you very much, Dr. Srivastava. I think we're going to have the discussion at the end, right?
Okay.
Okay, thank you. So the next speaker is going to be Dr. Gupta from Bangalore on recent advances in robotic gait training following neurological disorders.
Good afternoon, everybody. At the outset, let me thank Dr. Sinha for inviting me for this talk. So we'll be talking in the next 10 minutes about the recent advances robotic exoskeleton gait training following myelopathy. I have made the topic more specific. The topic was in following neurological disorders. So I thought I'll be talking about one of our studies, so following myelopathies. So what is a robot? Starting with the basics of the robot, it's a reprogrammable multifunctional manipulator designed to move material parts or specialized devices through variable programmed motions to accomplish a task. And it focuses on motor learning. How? By repetitive, intensive and task-oriented motor activities or training. And it requires subject's efforts, so it's not like a medication. Patient has to participate optimally in order to get optimum results out of rehabilitation, including robotic training. And it helps individual needs by adapting rehab to the patient's impairment and providing more objective measures of their performance. So if you look at the subcategories of robots, starting from the traditional part like leg orthosis and exoskeletons, which were used in the past, still very much used, where you are giving short orthosis, long orthosis, AFO, KFO, and then patients are made to walk with or without the help of assisted devices and using these splints. So, and then there is a foot plate based technology or hand effector device, as you can see in this, where the patient is not using any exoskeleton. So the patient probably is having some power in the lower limbs. Harness is required for unweighing, and patient is using the foot plates and some angular movements is produced, so patient is able to walk, but it's again a stationary walk. Then coming to the platform-based hand effector devices, just like this R-bot, you can see, again a device where you don't need exoskeleton, harnessing is required, unweighing, and the patient can be made to walk using this device. Then coming to the patients who are having lower limb paralysis, who are motor complete, or not able to walk, motor incomplete patient also who cannot stand and walk without the proper support in the lower limbs. So then you would be requiring robotic exoskeleton, as you can see in this Lokomat. So patient is walking on the treadmill, harness is there to support the trunk, treadmill walking, stationary walking is happening using these Lokomat based devices. So as I told you, for the mild and moderate gait disorders, we can use these anti-factor devices, but for the more severe, when the patient is having complete paralysis or near complete paralysis, probably it's better to go for exoskeleton to support better the lower limbs. I'll skip these slides because we have less time. Right, so this we believe are the first generation robots where patient is walking on the treadmill, robotic exoskeleton is used, harness is used, and patient is trained. Walkbot and Lokomat, some of our colleagues are already using it. Abhishek has rich experience of using this Lokomat. Then these are the second generation robotic exoskeleton devices where the patients are using the exoskeleton, but they are able to walk over ground. So that is the advantage of over first generation robots. The patient is able to walk over ground, but the weight of the battery, and if you have poor trunk control, those are probably, the patients would not be ideally suitable for this kind of robot. And of course the cost factor, like Exobionics, Rewalk, Indigo, all these devices are there. Then we come to our device, which was made by a Bangalore startup, Bionic Yantra, which we call it as Robotic Exoskeleton Assisted Rehab System, or RARES. We call it as third generation because it has the harness, it has exoskeleton, and it has the power, and the patient is able to walk over ground. Instead of doing stationary walking, patient is able to walk over ground. So that is the advantage. So that's why we call. And now, of course, we believe our device is cheaper as compared to the devices available in Indian market from Western product or in the Western market. So it has got two components, powered exoskeleton or wearable robot, which is the power exoskeleton. For the lower limb, you can see the motors are fixed in at the hip joint and the knee joint. Width can be adjusted. The length, as per the anthropometric measures of the patient, it can be adjusted. You have Velcro support the thigh, Velcro support the leg, so that you can keep the patient in place. Foot plate is there. So this is one part of this powered exoskeleton. And the second part is a mobile robot. As you can see, this frame is there, inverted U-shaped frame, which is 2 meters long. The source of power, it is embedded into this panel, so patient doesn't have to carry it. If we have got a winch, harness is there. Patient can be lifted. So once the patient is put in this harness, you can lift the patient. This can rotate 360 degrees. So the device mobile robot is moving in one direction, but patient can be made to walk one direction and then 180 degrees in the opposite direction. So once we got the device, we did the pilot feasibility study whether we can train the patients. The pilot study was done with 7 patients initially. 4 patients who were not able to walk to 10-meter walk test on day 0, and 3 patients who were able to walk for 10 meters. Of course, as the sample, we gave them 1 hour session, 24 sessions in total. And as you can see, by the end of the study, the patients who were not able to walk at the baseline were able to walk at midpoint, and they continued to walk even after the endpoint or after the session 24. And the patients who were able to walk showed improvement. Of course, statistical analysis not done because it was a small sample size study. So once we got the confidence that this robot is working fine, then we proposed a study with the myelopathy patients. Of course, we did study with stroke patients also, which we published already. So this study was done with the spinal cord injury patients, motor incomplete myelopathy patients, Asia C and Asia D, pre-post study, registered our trial. And then the patients which were included were myelopathy, adults, tetraplegic or paraplegic, traumatic, non-traumatic. All of them were motor incomplete, Asia C and Asia D. Injuries or lesion at least 3 weeks old. They have good breathing count, weight less than 90 kgs. This is as per our equipment's requirement. Height between 150 to 180 centimeters. That again, as per our equipment's requirement. And complete spinal cord injury patients were excluded. Patients having infection, pressure ulcers, HOs, DVTs, fixed contractures where you can't make patient wear those devices. We excluded those patients from the study. So 34 patients were recruited in this study, meeting the inclusion criteria. They were given 24 sessions in total. Each session was 1 hour, 5 to 6 sessions per week. And the study went on per patient for 4 to 6 weeks. And the target was to keep the total unweighing. The patient is able to walk independently without any unweighing. And the outcome measures were taken on day 0 and day 24. So our outcome measures were primary outcome measures of WISKI, walking index in spinal cord injury, 10-meter walk test, 6-minute walk test, and timed up and go. So this is for the speed, this is for the endurance, this is for the balance. And secondary outcome measures were 2-minute walk test, SKIM, to see their disability or functional improvement, and modified Ashworth for the spasticity measurement. So you can see some of the patients. I'll show you video of, yeah, this is one patient. It's walking on day 0 using the walker, no devices, and this patient was made to walk. I hope this video plays. I'll show in the next slide. And this is the patient walking after completion of 24 sessions. Let's hope next video plays well. Yeah, so this is another patient, as you can see, walking on day 0 using bilateral knee gaiters, right-sided AFO, and very slow speed. Patient is able to walk. Then the patient was put in for the gait training. You can see the device. Patients have to just tilt their pelvis. The direction where you are tilting your pelvis, the robot will initiate the movement. So patient doesn't have to do anything. Robot will initiate the movement. And then the patient would be made to walk one side and then the other side. The speed would be 1.6 to 2 kilometers per hour for this robot. Harness is used. Unweighing is done initially with the goal of maximum unweighing is desirable by the end of 3 or 4 sessions. And as you can see at the end of the study, the same patient walking. Of course, patient showed some spontaneous motor recovery also. Both the knee gaiters are gone, right-sided AFO, and patient showed better speed and better endurance after the training. So in our study, patient mean age was 36.7 years. There were more males, and etiology, non-traumatic etiology were more as compared to traumatic etiology, and mean duration was close to 1 year. 17 patients were cervical myelopathies, remaining were paraplegics. Upper extremity motor scores, as you can see, we divided them into 2 groups. The patients who were not able to walk 10-meter walk at the baseline, 20 patients, and the patients who were able to walk for 10 meters on day 0. And as you can see, most of the major upper limb motor scores, they showed significant improvement. The group where the patients were able to walk 10 meters, they showed improvement, but statistically not significant. Lower extremity motor score showed significant improvement in both the groups. This group, patients were not able to do 10-meter walk, 2 minutes, 6 minutes, were able to do by the end of the study. And in this group, I think both 10-meter walk tests, they showed significant improvement in speed, significant endurance in 2 minutes, 6 minutes did not show much improvement. Timed up and go, patient showed significant improvement. It was still not normal. You can see 42, 47.2. We expect it should be less than 20 seconds. So it was not that, but significant improvement was there. SKIM also, this key showed significant improvement. So conclusions, gait training with rears can lead to significant improvement in endurance, speed, balance, and functional outcomes in individuals with incomplete myelopathy. And effects are more pronounced with the patients who are baseline walkers. If they are not, probably improvement will be less significant. And it also shows significant improvement in functional status. Okay. So this project was funded by IIITB, Government of Karnataka. This is our team consisting of rehab physicians, urologists, physiotherapists, biomedical engineer, the entrepreneur himself, Mr. Vaidyanathan. Thank you.
Thank you for these impressive results. Thank you very much. Congratulations. We'll discuss later again. So I call now Dr. Anil Jain, orthotic management of lower limb paralytic disorders.
Good afternoon, everyone. And thanks to Dr. V.D. Sinha for giving me this opportunity. So I will speak on our experience, which is known as technology, which we use is known as Jaipur Rehabilitation Technology. That is low weight thermoplastic calipers for paralytic patients and Jaipur foot for amputations. I'll restrict myself to orthotics only. So this is orthotic management. Our department is situated here in Jaipur, a private, trust-based private hospital. So explosion of knowledge in the field of biomaterials, biomechanics, and changing patterns of disease and lifestyle has changed the practice of orthotics.
So orthotic intervention in neurotrauma patient is needed mostly in situation where when standing and walking is affected, the other causes locomotor disability. Other causes are head injuries, spinal cord injury, stroke, cerebral palsy, spina bifida, nervous system infections, neuropathies. So the changing pattern of orthotics because of the increased road traffic accidents, personal and mob violence, industrial accidents, terrorism, failed orthopedic surgery, infected implants, diabetic neuropathy. Is it not working? Okay. So increased number of road traffic accidents is the main man-made disaster as a new silent epidemic is emerging. This is causing around 450 deaths per day in entire country. And one can imagine the high number of morbidity and permanent disability. So major cause of locomotor accidents, you can see the overloaded vehicles, overloaded trains. You can see this scenario. Then this selfie-related injuries, highest in India. So musculoskeletal and neurological problems coexist, requiring orthotic intervention. Multiple fractures, peripheral nerve injuries, head injuries, spinal injuries. So this used to be the situation in poliomyelitis cases, and see, India is polio-free now, but the existing cases of poliomyelitis keep coming for orthosis. And these deformities are also seen in head injury, spinal injury, cerebral palsy, stroke, neuropathic knee, and meningomyelocele. So this orthosis were basically evolved for polio, which we have started using in all other disorders. The polio is relatively benign condition, which is not having any most of the time not having any upper limb involvement. There is no bladder and bowel involvement. Sexual functions are not affected. No sensory involvement. Speech and intellect is preserved. Surgery is needed when joint deformity develops. It is less expensive and there is no ICU care required. And orthotic intervention is often successful and less expensive. But here in road traffic accident, falls, and post-surgery after neurotrauma, the situation is very complex with sensory involvement, bladder bowel involvement, sexual function involvement. So ICU care is very costly and orthotic intervention is not very successful most of the time. So to restore ambulation, different devices are used, ranging from simple walking stick to long calipers. That there can be two types of presentations. One is lower motor neuron type of presentation without sensory loss, like polio, which is easy to manage. Success rate is very good. Functional life is almost like normal person. Then LMN with sensory loss, material which management requires material change in orthosis, where it has to be covered. The orthosis has to be covered with microcellular rubber, which is the same rubber which is used for footwear of leprosy patients to take care of the sensory involvement. And the design changes in orthosis. Here you have to cover minimum surface area and it has to be padded adequately with soft material. In such cases, success rate is good if it is used properly. Cannot be used for long period at a stretch because constant pressure and friction may lead to skin ulceration. Then upper motor neuron, where the patient is spastic, hypertonia. Orthotic intervention is successful up to grade 2 of modified Ashworth scale. Grade 3 and 4 orthotic intervention is difficult and painful. And when it is associated with sensory loss, orthotic intervention not possible as chances of skin ulceration are very high. This is modified Ashworth scale, you all know. Now there are different situations which we encounter in our OPD. Situation 1, when the total limb is involved, completely flared lower limb is there, unilateral or bilateral, it has good trunk balance and upper limbs are normal. So here the conventional calipers, you can see the diagram. The problem with conventional caliper was that it used to be very heavy, it was visible from outside, and you are bound to use that black shoe which was fixed to the caliper. So because of all these problems, the rejection rate was high, it was more than 90%. But we changed all these calipers to low-weight thermoplastic designs in our hospital with a research project funded by Government of India. And the acceptance rate was above 95% with this type of calipers. So although the plastic caliper also behaves like a conventional caliper, but has certain advantages over it. This is much lighter in weight. The ischial weight-bearing quadrilateral top makes the pelvic belt with hip joint unnecessary, and the choice of shoe is possible. Then the stance control knee and ankle foot orthosis. Stance control means knee is locked during stance phase when foot is on the ground and weight bearing, and it gets unlocked automatically during swing phase when foot is in the air. So orthosis resists knee flexion during stance phase and permits free knee bending in swing phase. At the same time, it provides mediolateral stability also. It reduces energy consumption and ground clearance is better. There are contraindications. If the patient is spastic beyond grade 2, impaired cognitive functions, and knee flexion contracture about 10 to 15 degree. Then polycentric knees, which has multiple axes of rotation and a simple mechanical swing control that provides a optimal single walking speed. It may be pneumatic or hydraulic. The polycentric free motion knee joint are made with stainless steel for increased durability and strength. So in case of paraplegics, same appliances can be used with the help of bilateral auxiliary or elbow crutches with 4-point alternate gait or swing through gait. And when sensory loss is there, a microcellular rubber insole is used for AFO, the same one which is used in leprosy. Then reciprocating gait orthosis. So it is an extension of KFO with pelvic bands and hip joints. Thoracic extension is added to prevent uncontrolled collapse of the hip. It combines flexion of the knee or flexion of the one hip with obligatory extension of the opposite hip. Essentially, the flexion power of the hip is utilized to extend the contralateral hip with a specially arranged cable. Then floor reaction orthosis, where the quadriceps paralysis is there and patient is not able to stabilize knee. It is basically a device which holds your ankle in artificially induced equinus and brings the weight-bearing line in front of the knee axis and helps in stabilization of the knee. The degree of equinus, usually the lowest level of the heel should be at least ½ inch above the ground, and with the shoes it is 1 inch above the ground, so that initial forefoot contact is ensured. Then rear entry FRO, it is a device used in patients with Creutzfeldt cerebral palsy. It prevents excessive dorsiflexion at ankle. This is rear entry FRO. Then modified Linhais KFO, this kind of hyperextension knee can be seen in traumatic hemiplegia, traumatic brain injury causing hemiplegia, polio, cerebral palsy, spinal injuries. So it provides a stance phase stability and allows knee flexion in while walking. It aggravates, and there should be no equinus at the ankle because it aggravates genu recurvatum. This is Linhais KFO, and on right side it is articulated Linhais KFO with drop lock knee joint attached to it. Ankle foot orthosis, everyone is familiar with the foot orthosis used for foot drop. Then articulated AFOs, where the ankle hinge is provided. Then it is used for prevention of equinus, virus, and valgus deformity. Tone inhibitory AFOs are also used, which are more useful for pediatric patients. This improves proprioception and balance. The supramalleolar orthosis and UCBL foot support may be of some use. Now, I will show you 2 videos of neurological involvement, just 1.5 minutes. So this was a patient from Lucknow with bilateral involvement. The muscle power was less than 2 when he started using these calipers. And you can see he is walking with knee flexion. The gait is quite stable. Without any stick or cross support, you can walk.
वापस आना.
Community walk. This is one more patient walking with floor reaction orthosis. You can see the level of the heel which is above the ground and the initial 4 foot contact with the ground. Heel is above. You can see on right side. He's very well stabilizing his knee. He's a chartered accountant from Calcutta. Thank you.
Thank you very much. This was a very interesting presentation. So the next speakers are going to be here, Dr. Lahai Kumar from Lucknow. So I will call. Well, it's my great pleasure to be here again. And can we start the video, the picture? Okay. I've been here many times in India, and second or third time to Jaipur. It's again and again, it's a great pleasure. And today I've selected this talk about neurorehabilitation on a more global issue. I was impressed by all the presentations you gave so far, and I'm looking forward to the next talks which are following afterwards, and we hopefully going to have a good, lively discussion. I don't have to go into this, but maybe the last line is important. Sustainable Development Goals, or SDG number 3, defined by the World Health Organization, states ensure healthy life and promote well-being for all at all ages. So that's what we have to look for. And that's a political issue, not only a neurosurgical, neurorehabilitation issue, but a global issue. You see here when I flew over to Pakistan and then to India, I took this picture from the screen, the flight screen, and you see all the lights shining in Europe and Western Turkey and Saudi Arabia and all these areas, and also over India, but there are many dark areas. So we have to bring light. And that's the goal of Rehabilitation 2030, which the World Health Organization put forward in 2017. So global estimates for the need of rehabilitation, that's all rehabilitation taken together, not only neurorehabilitation, shows that there is an increase of need for rehabilitation, as you see here. That's 1990, that is 2019, and here you see the many patients who require rehabilitation are in the young, productive age, 15 to 64 years. Neurological disorders and musculoskeletal disorders are just only part of it, but that's a major group of patients we are looking for. There are a couple of good studies which just came out at the end of last year, like the study from Guan on a global, regional, and national burden of traumatic brain injury and spinal cord injuries taken together from 1990 to 2019. And then the global, regional, and national burden specifically to spine injury, which was published also recently at the end of last year in the Lancet Neurology. So it's interesting to read those presentations. The incidence rate, as you can see here, from both traumatic brain injury and spinal cord injury is not distributed evenly in the population, and we have to see where the rehabilitation units have to be or should be localized. And so causes of traumatic brain injury, however, is except from the areas where there's heavy fighting going on. There's the pictures here of 2019. So I think it's going to change with the war in Ukraine and with the war in the Gaza Strip. So the picture is changing, but most reasons are fall and vehicle accidents. So we have to work on these issues, and in Germany it's really shifting from car accidents, from motorbike accidents to falls at home when you're working, when people are working, not so much the occupational falls, but the falls at home. So that's a very important issue. spinal cord injury has increased in prevalence, incidence, and also years living in disability. So what's more important, and again, here you see the young population is catching up. That's very bad news. Young population is very much catching up over the last 20 years. So we have to work on this, that they will not become devastated for long time. Ethical principles for treatment, any kind of treatment, obviously, as for neurorehabilitation, primordial nocere. So we have to evaluate very carefully that we do not do harm to the patients, like producing additional sores, whatever, doing with all these devices which apply to them. So I was very much impressed about the picture you showed with these good, well-fitted instrumentations to these patients. Beneficiency, do good, provide benefit, autonomy. The patient needs to take care of his own goal and should be able to continue his life the best way he wanted to have. We have this, I don't have to go into this because you're all from rehabilitation, so goals of neurorehabilitation are independence of the patient, self-esteem, and participation in the social life as much as possible. How can we estimate the benefit of the efficiency of neurorehabilitation? There have been a couple of publications. I just only want to show one, which came out in 2019 from the Netherlands. The conclusion was the available evidence indicates that early onset neurorehabilitation, the trauma center, and more intensive neurorehabilitation in the rehabilitation facility promote functional recovery of patients moderate to severe TBI compared with usual care. These findings support the integration of early onset and more intense neurorehabilitation in the chain of care for patients with TBI. And we all know that this is not possible in Western countries, in Germany and many other European countries. We have been able to improve this, but still we have some gaps in between. And I know from many discussions with you, I've seen your beautiful examples of your excellent neurorehabilitation, which you're doing in Mumbai and all the other sites. But that's unfortunate. That's not yet the case everywhere. So who decides for which kind of therapy? That's important. Is this the patient because he hasn't got enough money? Is this the family because they can scrap all the money they have for neurorehabilitation? Or is this the community, whatever? And this certainly depends on the guidelines which need to be given, country dependent. Variety of ethical problems is sure or occur also, like allocation of resources. And I've seen this in many countries which I've been visiting, like when I've been before coming to Jaipur, I've been in Pakistan, in Peshawar, and we discussed extensively also on global neurosurgery. And we have to be aware that how the long-term results of our treatment, they may be as good as possible in the acute or post-acute phase in the neurosurgical unit or in the neurorehabilitation unit, how they will be on the long-term run. So that is very important also. World Health Organization has put this up in 2021 in the rehabilitation competency framework. I am sure since you are specialists in neurorehabilitation, you're aware of this with these, like only the competences of the rehabilitation workers. He should demonstrate ethical conduct. He should have sufficient practice. He should have professionalism. He should be able to manage and learn further and lead and then do research. So there are many, many requests to many tasks he should be able to achieve. What is important, that's a paper which just came out only 4 weeks ago, integrating rehabilitation into health systems, a comparative study of 9 middle-income countries using World Health Organization systematic assessment of rehabilitation situation. And it is published on February 24. It is looking at countries like Myanmar, Sri Lanka, Nepal, Solomon Islands, and Tanzania at the lower middle-income countries. On the other hand, Zambia, Georgia, Jordan, Guyana, at the higher middle-income countries. Rehabilitation results checked for different issues with the global assessment of these scores. Financing available was only rarely or respectively not at all available in these countries, which is certainly an issue when the family has to pay for the rehabilitation itself. No or minimal fees exist for rehabilitation. I don't know how this is going to be held in China, in India here, and we discuss. What is also important, one bed ranges from 43,000 population in Sri Lanka, over 219,000 to 2.4 million population in Tanzania. So it's extreme opening. While we in Germany, for example, it's difficult to find the right figures always, but I looked through it. So 1 bed per 56,000 people in the population, 1.5 per 100,000, including psycho-rehabilitation, psychiatric problems, respectively 1 bed per 520 patients, including prevention and rehabilitation units. So we have this long history of the Kur clinics where patients go because they don't feel fine, so they pay for their own, or get even also paid by the companies or by the insurance companies. So, and there are private companies like Weidam. They suggested that patients from abroad should come to Germany because they provided the best rehabilitation units, and they cost from $370 to $1,000 per day, which is excessive, I think, and depending on what kind of, with intubation or not, ventilation and all these others, that's the early rehabilitation phase. And we have been requested, when I was still chairman at my department, we had also early rehabilitation beds, but we got many requests from Saudi Arabia. For example, normal history was a SUV against a camel. The camel was dead and the driver of the SUV, he was paraplegic. So they wanted to send these patients. That's not the way we should take care of these patients. Improved efficacy of neurorehabilitation. For example, how can we show, we discussed also this morning and yesterday, was discussion about how we could improve the selection for patients who would benefit from neurorehabilitation or any other treatment. Can we do this with whole brain magnetic resonance spectroscopy that could determine the functional outcome in patients? But that's a very expensive method. Can we base this on neuroradiology, or can we get a good information prediction set of biomarkers plus artificial intelligence? This may come out. Then we have the ethical question, shall we be allowed to exclude some of the patients from good neurorehabilitation? And the local situation certainly needs to be considered. You see, that's an example of a tetraplegic patient, young man. He underwent all kinds of rehabilitation, but obviously he was living in Germany, and so he was beneficial. But if such a same thing would happen in Africa, for example, and he would never be able to get such a system, but would not be useful for him either. So you always have to see what's important. Science and honesty needs to be considered. Evidence for post-stroke devices, for example, only 1/3 of all the overall devices which can be ordered are really have undergone randomized controlled studies to prove efficacy. So it's a waste of money for many of those patients. Acute medicine needs to be discussed versus rehabilitation medicine. The balance should not be for one or the other, but both should get the chance to work for the benefit of the patient. So they should work together. And the take-home message is the neurosurgeons should send patients to rehabilitation, respectively include this therapy in their planning the patient. That's very important, and we should, as neurosurgeon, as neurorehabilitation people, work together. Also working to convince the politicians to spend enough money on these issues, because every dollar which would spend in such a patient is beneficial for the future of his health. Thank you very much. With this, we come to the next talk, which is going to be Dr. Mrinal Joshi, Evaluation Management of Neurogenic Bladder Dysfunction.
So, afternoon, everybody, and I thank the organizers for inviting me for this lecture. It's an exhaustive topic, and so I will talk of some basics and things that we do. And thank you for pointing out the need of rehab, because there was one of the ads of one of the motorcycles that they sell in India: fill it, shut it, and forget it. So similarly, that's what happens most of the times. You fix the injury and then you forget them. And we need rehab because we need survival, because what's happened after injury. And the bladder becomes one of the more major issue as far as the mortality and the morbidity is concerned. So I'll talk about the overview of the problem and focus on spinal cord injury because that's our major chunk, and what are the problems that we're looking at and the evaluation of that, and a bit of classification, and what are the goals of management. So we can have neurogenic bladder in a lot of kinds of injury. It can be cerebrovascular accident, brain tumor, CP, Parkinson's, multiple sclerosis, spinal cord injury, TABs, and disc disease, and diabetes. So this is the basic diagram, just to things clear and short about the storage and micturition. And most of the times what we do is we divide all these spinal injuries into supraspinal, suprasacral, and infrasacral injuries. This is a very broad classification which most of the times doesn't work. So when we talk of suprasacral spinal cord lesions, we have an initial period of shock and detrusor areflexia. And then after some time, you have uninhibited bladder contractions, which are associated with the episodes of urinary incontinence. You have visceral sensations, you have increased lower extremity spasms, and autonomic dysreflexia, which is emergency and the dreadful complication that you can have. You have uninhibited bladder contraction, which becomes slowly stronger. The PVR decreases. There's high voiding pressure. Prolonged duration of bladder contraction increases hydronephrosis, renal deterioration, and DESD, or what you call detrusor external sphincter dyssynergia, also commonly occurs. And it is basically what happens when your detrusor is contracting and the neck doesn't open. So what happens, the pressure increases intravesically and it goes to the kidney, and slowly you have hydronephrosis and a chronic renal failure. In sacral regions, you have damage to the cord, the sacral cord and roots, which results in a compliant but an acontractile bladder. In partial injuries, you can have areflexia, which may be accompanied by decreased bladder compliance. So when I talk of compliance, it means that when you have more and more water coming into your bladder, the pressure doesn't increase. The pressure remains the same. So normally we have good compliance. Our bladder has good capacity to get the water in our bladder. Now, when we talk of evaluation, we have to have good history and examination, which includes neurological examination and pelvic floor functions. A dipstick urine analysis, because most of the times it can be a UTI, which increases the problems of your neurogenic bladder. And a bladder diary, which is very important tool for us who are in developing countries, because most of the times you do not have access to urodynamics. And post-void residual, again, we have found this beautiful machine. Now, fortunately, we got one, so which is good for us, because otherwise what's happening, we used to actually put a catheter to actually measure the post-void. So that was pain, and then renal tract imaging and the urodynamic study. When we come to examination in SCI, we usually use a standard neurological classification spinal cord injury proforma by Asia. This is the standard proforma which we fill for each and every patient, and then we also fill this autonomic standard assessment form. So it's a standard assessment form that we fill that basically tells us who are those patients who are at risk of autonomic dysreflexia. Most of the patients that we actually cater to are uneducated people. It's fall from height, which is the most common cause. Most of them are laborers and agriculture workers. And their monthly income roams around $100 a month with a family of 4.2. They're uneducated. And you have to sensitize them with the symptoms, because most of the time they do not have access to a specialist where they are living. And this is the standard bladder diary by the International Continence Society. But what we have done is we have a Hindi version of that. So we usually use it and for 3 days, and then it gives us a picture that what is the frequency of micturition, what is the volume of micturition, how many times he has drank. So it gives us an idea what is happening in the bladder. And then the post-void residual, which is very important. So now we have this a bladder scanner, and then we can always measure the post-void once the patient is on clean intermittent cath. Urodynamics is very important. Let me tell you, most of the times what used to happen was that we would have a simple 1 + 1 = 2 kind of a philosophy, where you have a suprasacral lesion and you have a spinal lesion, and then you have a pontine lesion. And then you have a set mind that if it is above the sacrum, then it's upper motor neuron client of bladder, and then you have a lower motor. Nothing like that exists. It's a very mixed picture. And we have actually published the data, and this is one of the bigger studies that I'm sharing. So here, if you see that if you have a cervical spine injury, the total number of patients is 259, and 1% have normal, detrusor areflexia 9%, detrusor sphincter dyssynergia 63%, and detrusor overactivin 65, which is totally defies your neurological prediction based on your neurological examination. Same goes with lumbar. Even in sacral, you have even detrusor overactivity in 22% of the patients. So at some point of time, we need to do a neurodynamic study. And there is a mismatch. And this mismatch is maybe because of degeneration or reorganization of neural pathways, or incomplete lesions, or combined lesions, or extension of injuries, or aberrant healing process, vascular extensions. So UDS is an important tool for management, particularly when we are doing interventions. When we are doing for overactive bladder, we are doing botulinum toxin injection, so we don't inject unless we get a urodynamic study done. So we have this ICS classification, which actually divides all the problems into two phases, the storage phase and voiding phase. But as a rehab person, we talk about functions. So we use a functional classification. This is a Mader-Becker classification. So it's a 4x2 table, and all of our management goals and planning is based on that. And our treatment goal is to protect the upper urinary tracts, the improvement of urinary tracts, improved quality of life, restoration of normal or at least near normal lower urinary tract functions. It should be cost effective, very important for us. The technical intricacies are also important. You can have possible complications. It's very common, uneducated people doing self-intermittent CATs, urethral injuries. They just happen, and we just have to treat them and teach them, and that's how we go. I think I'll be able to talk a bit about intermittent catheterization, which is very important. And if you see previously the old data, the most common cause of death was renal failure. And then in 1972, Lapidus introduced intermittent catheterization. And since then, the morbidity because of urinary complication reduced, but it has remained stable since then. So it's an important cause of morbidity and mortality. And we have to consider intermittent cath wherever we have sufficient health skills. Now imagine we have a person who is, say, an incomplete tetraplegia, and we want to put him on a intermittent catheterization. So he's supposed to do 4 times a day, a family of 4. He was the only earning person, so now the responsibility of earning has changed. So wife is going out and get the living. Who will do this intermittent cath? And then it becomes a big problem, and that's a challenge. And after more than 25 years, I've yet to find a good solution how I can solve their problems. I don't know. But we have to keep going, as I said, and we have to promote. And most of the times what I do is I put them on SPC, because this is the safest bet that I can do. Even though I would like them to do an assisted or self-CIC, but I have to shift them to, because once they start leaking, they will have pressure ulcers, they'll have UTIs and whatnot. So until and unless we have an unwilling caregiver, abnormal urethral anatomy, poor cognition, high fluid intake, and AD, autonomic dysphoria, despite treatment, I will put everybody on intermittent cath. Now, if we look at this table of intermittent cath and chronic indwelling catheter, the complication of people who are on intermittent catheterization is lower than IDC. Okay? So it has been proven without doubt, because what actually happens is once you do a CIC, you have a biological layer in the inside of your bladder which actually prevents all kinds of infection happening. So I will stop here. The time is up. So because I just can't cover management of bladder. Thank you.
Plenty of time to discuss after the lectures topics. Now I would like to call Dr. Jeremiah Mahavedan from Bangalore, TBI, in patients with alcohol and drug use. That's certainly not only an Indian perspective, but it's an overall world problem.
Very good afternoon. Thank you to the chair and thank you to the organizers for giving me an opportunity to talk to all of you a little bit about traumatic brain injury in patients with alcohol and drug use. I know it's, so I'm a psychiatrist by training, and so it's probably I may be a little out of place and I've never been to a conference like this before. So the objective of my talk would primarily be to sensitize people about the importance of recognizing alcohol and drug use, of course, as being very important etiologies, and also the importance of screening as well as interventions to be instituted early for the same, and I hope I can make a case for that. Right, so this is going to be the outline of my talk, very briefly, talking a bit about epidemiology, presentation, evaluation, treatment, outcomes, and a little bit about prevention, including some of the work that we have done. Right, so now I know this is something most people would know, but I'm just going to run through that. So these are the various drugs, the commonly used substances: alcohol, opioids, cannabis, stimulants, sedatives, as well as some of the others. As we know, of course, the maximum amount of literature that we have is with regards to alcohol, although there's a lot of emerging literature in the context of cannabis and opioids as well, in terms of its relationship with traumatic brain injuries. Now, just to define our terms, when we talk about substance use, we have the whole population, and most people, of course, don't use substances. Then there would be a subset of individuals who use substances, a subset of individuals amongst them who would incur harm from use of substances, and a very small percentage who would actually have dependent or problematic substance use. I think it's important to recognize that. But at the same time, I think it's very important, at least in the context of TBI and substance use, to understand that you don't necessarily have to have dependent substance use or problematic substance use to have an increased risk of problems related to TBI in the context of alcohol and drug use, right? So when we talk about epidemiology, essentially we know that TBI and substance use share a bidirectional relationship. So we know that substance use is an important etiological factor for TBI, and we've also studied, and this is I mean, the first part is obvious, but then it's been also seen that TBI itself is a significant risk factor for future development of substance use and problematic substance use. The mechanisms for that are varied. So people talk about dopaminergic dysfunction secondary to TBI. People talk about OFC dysfunction secondary to TBI, and that leads to increased impulsivity and a risk for developing substance use. So it's very important in either case to be able to look at the intersection of these two problems, right? So when we look at epidemiology, there are two ways in which it can be studied. And this brings us to this kind of schism that is there, right? So one set of epidemiology is actually where substance use is studied in individuals who have TBI. And the other is where TBI is studied in individuals with substance use disorders. So the first is usually done by neurosurgeons and people working in that domain. And the second is usually done by people like me. And so that's the problem. It's essentially, although I've just quoted some of the studies from some of the rates from global studies, they're fairly high. But the major challenges that we see is a lack of uniformity in the way that assessment is done. So we are really bad at assessing TBI, and neurosurgeons are perhaps not so good at assessing substance use. And so I think that's one of the reasons why I'm very happy that we are together here and talking at the same time, right? So when we talk about epidemiology from India, again, this is a large TBI cohort from Chandigarh, almost 15,000 individuals, and alcohol use was there in almost 18% of these of this overall sample, and slightly higher in the RTA sample as well. And again, people who had moderate or severe head injury had significantly more frequent alcohol use. This is a study that we have done. It's not yet published. This is actually a survey which was commissioned by the Ministry of Social Justice and Empowerment, and it has been done by myself and some of my colleagues, wherein we've looked at trying to identify causes for mortality among substance users. And as you can see, it's quite concerning. I mean, when this was done in Karnataka and Rajasthan, two studies. I mean, It's again, it's ironic that I'm in Rajasthan right now. So alcohol use, of course, has been associated with highest rates, but even opioids and cannabis users report fairly high rates of RTAs as well as head injuries, which is definitely a matter of concern. Right, this is a very old study done from NIMHANS, where alcohol users and non-users from hospitals across Bangalore were studied, and it was seen that drivers and occupants of motorized two-wheelers, evening and nighttime consumption of alcohol, and higher severity of brain injuries, duration of hospital stay, death, and post-traumatic disabilities was seen in alcohol users. So I think there's no doubt that there are significantly poorer outcomes in substance users, and so that requires intervention. So when we talk about common clinical presentations, and we get called in for a number of consults, given that we are a multi-specialty hospital. So one would be substance intoxication. So a person comes in with a TBI under the influence of substances. Not very much that we can do in that context. The other very common clinical presentation would be person comes in with TBI, has probably been using substances for some period of time, undergoes surgery and then goes into delirium or has a seizure post that. And so that can be in many cases attributable to substance withdrawal, leads to a lot of problems, long prolongation of hospital stay, and requires acute intervention. And of course, the other would be individuals who present with TBI and have had long-standing substance use problems or substance dependence. I think all of these offer opportunities for interventions. Right? So when it comes to evaluation, I think it's very, very important that we need to incorporate substance use evaluation, a routine screening for substance use amongst individuals with TBI. The same study, which the survey that we had done, I've not put those results up because they're a bit worrying. So when one looks at the rate of screening amongst emergency departments, and we looked at hospitals in Bangalore, the rate and documentation of substance use amongst people with TBIs is extremely low. I mean, it's abysmally low. I'm not even going to quote the numbers. But I think it's very, very important that we need to look at being able to screen. There are tools available for screening for substance use, the audit and the assist for alcohol and other substances. There are tools available for withdrawal assessment. And of course, I think there is a very important role for toxicology, which includes blood and breath alcohol as well as urine screening for drugs in the context of people with TBI. This is the WHO Assist. These are all freely available tools. Brief. It takes about 5 minutes to apply these tools, and they would be very useful both in the context of collection of data as well as obviously in terms of planning management, because interventions can be linked to the same, right? So when we talk about treatment, obviously there's medical treatment and psychological treatment. So treatment of substance withdrawal. So when we're talking about alcohol, I think a timely and judicious use of benzodiazepines for treatment of alcohol withdrawal in individuals with TBI. People feel very hesitant about it because, as has been mentioned by one of the speakers previously, use of benzodiazepines in individuals with TBI is something of an unsure topic. But in the background of substance withdrawal, it becomes something which can, and we've seen this, it can really help with being able to reduce morbidity and long-term hospital stays. And the other thing is about treatment of substance dependence. So what has been found in studies across the world is that the TBI for an individual who has substance use problems is a very good opportunity to actually intervene for substance dependence. And in fact, if people don't intervene, people go back to their preceding rates of substance use in 6 to 12 months. So it's an opportune time for intervention per se. And so intervention can of course be medical, and there are trials that have been done, very small ones, which have looked at agents such as naltrexone and topiramate for treatment of substance dependence in this background. Psychological treatment is something which definitely can be offered. So there's something called screening, brief intervention, and referral to treatment, as well as of course cognitive rehabilitation approaches. So essentially, as I said, the importance is motivation to quit substances are higher after TBI, and if we don't provide interventions, people tend to go back to the previous patterns of substance use, and that can lead to recurrent TBI. So it's a fertile ground for intervention, right? This is a study that has been done at NIMHANS. Professor Dhaval is one of the co-investigators on this study. It was a nurse-led brief focused intervention compared with minimal intervention in people with mild TBI who screened positive for alcohol alcohol use. Essentially, the brief intervention was just a video portraying the effects of alcohol and brief advice on how to reduce or avoid alcohol use. And it was found that over a period of 6 months, the BFI group had significantly lesser quantity of alcohol consumption and fewer alcohol use related problems. So again, some evidence suggesting that this could be something worthwhile, right? When we're talking about outcomes, again, I think in general, although there is some debate about whether alcohol use at the time of TBI leads to worse outcomes, I think the floor is still out as far as that is concerned. But overall, clinical cognitive outcomes are definitely worse in individuals who are either under the influence of alcohol when they have undergone the TBI or have had a previous history of substance use disorder. And that leads to worse outcomes as well. My last slide, I'm sorry, I've exceeded my time. So this is actually something which gives us an idea about prevention. So again, this is a study that was done in the context of COVID, which was the largest natural experiment that we have had in recent times. And we've looked at what are some of the factors which have contributed to a reduction in TBI cases post-COVID. And so using some fancy statistical analysis, we've been able to look that community mobility and alcohol sales were something which significantly affected the number of TBI cases. This has implications for prevention because around the world, people have seen tighter alcohol regulation, alcohol taxation can significantly impact rates of TBI as well. Right? I'm going to skip. This is another controversial topic which I'd come about, protective effects of substances in the context of TBI. So this is something for people to think about. So in conclusion, alcohol and drug use increase the risk for TBI. Recognition of alcohol and drug use in patients with TBI is important. Interventions for alcohol and drug use delivered after a TBI can be extremely beneficial. And I think this is my closing point. There is a need for more multidisciplinary collaborative research, particularly in our context. So thank you so much.
Thank you so much. I learned so much again from your talk. Now we have 20 minutes for discussion. Are there any? Okay, I didn't see it. So. Oh, sorry. Yeah, Dr. Sharan Srinivasan. Sorry. My fault. I was so eager for discuss all these interesting lectures.
10 minutes.
Sorry.
10 minutes.
10 minutes, even more. Sorry.
I'll get out of the way in 10 minutes.
Don't rush. Just do it.
Audio check. Audio check. Yeah. At the outset, I want to thank Dr. V.D. Sinha for giving this opportunity to speak here. Sir, Chairman, sir, incidentally, we are the only 2 neurosurgeons in this group. I think we need more neurosurgeons looking beyond acute care and more into rehabilitation. Also, it's our response as much as it is their responsibility, and working together is critical. So, I'm basically a functional neurosurgeon coming from Bengaluru, India, the Silicon Valley of India. So, the theme of this conference was stimulating innovations in neurotrauma. But the key issue is we need affordable yet effective rehab that can be mass rolled. That's a very important thing. Even the Western population cannot afford expensive treatment, and we have seen enough of that. So, functional neuroscience is the future, which is a unique world of neuromodulation with advanced neurorehabilitation. Should have both are happening separately. I've tried to blend it all together under one umbrella to make it happen. I run my own rehab company. So I do neurorehabilitation from coma to community. I also run my own technology company. I make low-cost gadgets. So I built my own software, and we hold a couple of patent pending processes. So the importance of comprehensive neurorehabilitation in spinal cord outcomes, it's a cord-to-community approach. So what's the patient and family's expectation? Will my patient improve? Will she become normal again? How long will it take? What all do we need to do for that? Is there hope? Whether he's the CEO of the company or beggar on the street, rich or poor country, the questions are the same. There's no difference. To answer these questions, we need to know what was the reason of the situation of the patient. Was it a stroke, head injury, brain infection, spinal cord, degenerative, whatever the cause was. Next, what's the current level of functioning of the patient? We don't even know the starting point. What are the different disabilities the patient is having currently that's stopping them from functioning well, which is very individualistic. Next, what are the expectations of patient and family? Is it realistic? Can all that be achieved? And next, do we know all the abilities the patient needs to have to reach that outcome that they want? How do we know the patient is improving, progressing? It's such a long journey. It's not a 5-10 day affair. Nobody even knows where I started, where I ended. Can we measure progress? And then how can we communicate all this without medical jargon in simple English to a family, at the end of the day? And then can we issue reports to the family that they can understand and read? So the steps of SEER rehab, we follow at our association called PRS Neurosciences. It's a neurosciences company. Is step 1, assess the functional starting point. It doesn't matter what has caused the problem to the patient. What's the functional starting point? What is his ability? What is his disability? Step 2, assess the rehab potential. We call it the PPP, progress and prognosis prediction. Number 3, a dynamic and real-time assessments of the progress using proprietary evidence-based protocols and processes with appropriate course corrections. Step number 4, constantly keeping both the restorative and compensative strategies in place. And then finally, special interventions, neuromodulation strategies wherever indicated, earlier than later, proactive than reactive. All this is based on a cooperative clinical framework we use called the CARE framework, where C is clinical, A is anatomical, R is radiological, E is EP is etiological, and R is rehab. So step 1 is assessing the functional starting point. What is this? We have a concept called C2C. C2C BIR is coma to community in brain injury rehab, and C2C SCIR is called COT to community in spinal cord injury rehab. Now, step 1, this assessing starting point. We have something called spinal cord function test based on the C2C SCR concept. We have an online screening tool called the SAFA, Self-Evaluation of Functional Abilities in Neuro Patients. It's a version 1.0, has been used for 5 years. We have got a version 2.0 just getting launched. It's an online self-evaluation tool, can be used anywhere in the world. It immediately declares the C2C score. It comes in the Microsoft Teams channel of ours. Can be done 24/7 by 365. Currently in English, can be converted to any other language. Then we have the CAFA, clinical evaluation, which is an online calculator that our clinicians do to assess the C2C SCR score, which is based on the ASIA and the SCIM-3. And then we match the two for cross-verification, so that one comes from the patient side, one from the clinician side, we know what's going on. And then we use the CARE concept to look at the current clinical versus radiological NLI. Then what do we do? Step 2, assess the rehab potential, PPP. There's a rehab potential calculator, but we have created a unique concept called the Rehabability Index, which is part of the first patent, which we applied for the American patent last year. It's called RI calculator. Calculator gives the following data: the possible endpoint C2C score, possible duration to reach it, amount of effort times of therapy sessions per day needed to reach it, kind of facility required, inpatient, outpatient, whatever it is, acute care, percentage of success possible to reach that endpoint, and then we call it the rehab RI or the rehab astrologer. PPP is progress and prognosis prediction. Then we go to step 2 of this. The radiological is the clinical NLI. This is checked retrospectively, current and prospectively, because the levels keep changing. And then what do we do? Based on the day that we are assessing, we make distinct plans for above the level of injury, what therapy to give. At the level of injury, what do we have to do? Below the level of injury, what do we have to do? Because each of it has a different story, and each story has to be tackled differently. It can't be a carpet bombing at the end of the day. This is our life inside the house, life outside the house. We call it FIL, functional independence levels. This outside the house is called, we call it as FIL 5. We have FIL -1 till FIL 5 mapped out. And then the step is progress, assessing the progress using proprietary evidence-based protocols and practices. And that is done, we are using our own software called Neurologics that we have built ourselves with a lot of process. What do we do? It helps us set a field-based step-by-step goals. KFA is done online. We match the two for cross-verification, and after that, what do? We keep looking at both the restorative and the compensative strategies so that the patient gets active faster to reduce caregiver burden. Because that's one of the biggest things that we have here, to reduce caregiver burden. Special interventions, I spoke about that. Let's see one such patient C2C journey. SCR journey. This lady is a 54-year-old businesswoman, had a slip and fall at home. She had a dorsal SCR with paraplegia, which progressed rapidly over days after the trauma. She took some initial treatment for 2 weeks, some Ayurvedic treatment. Once she was bedridden, she sought neurosurgical help. She was Asia-B thoracic D6 motor incomplete at time of evaluation. She was found to have severe underlying dorsal canal stenosis from D5 to D9 on MRI. She underwent a decompressive laminectomy at D6 to 9. Another hospital, and she was sent to us for institutional rehab after a week. What did she do? She had no significant changes in HIB status about 1 week after surgery, developed progressive worsening spasticity in both lower limbs, and suboptimal results with oral baclofen. Then she developed severe painful flexor spasms, especially at nights. She was crying in pain, and she had no sleep. We did a comprehensive care plan evaluation, framework-based evaluation. MRI repeated was suggestive of a persistent focal canal stenosis at D5 level, just superior at the upper end of the decompression. Then we also, because of the spasticity, I also gave her an ITB trial, and she got very good results. So I did a two-step strategy on the same day. I decided to go ahead, re-explore the wound and do a D5 decompressive laminectomy because I thought that was still creating some problems. At the same time, on the same surgery, I implanted an intrathecal baclofen pump. So this was her post-through surgeries, post-op programming of the ITB pump over the next few weeks to a couple of months. Her painful flexor spasm disappeared completely. Her night sleep was good. Spasticity was much better. And then we continued 3 to 4 hours of institutional rehab per day, 6 days a week, and she showed definite but asymmetrical improvement power of both lower limbs. This is how she was initially when she came. This is about 2-3 weeks of therapy. She's struggling. She was very obese. She's struggling to even turn. They have turned her to the side. She's just struggling to do what it is. Then as she started getting slowly better, this is post-ITB pump, but still struggling a lot with her obesity, knee buckling. This is 9 months post-ITB, 12 months after starting rehabilitation. This is her back in her community. She's still about C2C, SCR 3C. She's not yet 4, which is normal, but she's gone back to her business. So that's what it is. Thank you very much. I invite all of you for International Noble Art of Lesioning program for brain lesioning that we are having. Oops, where did that go?
Can we show the last slide again, please?
Yeah, last slide.
There was an announcement for another meeting. Maybe you can just...
I'll just show
there
that,
it
yeah.
is. Perfect.
So this is a brain lesioning. We are trying to restore the noble art of lesioning, which is 5 times cheaper than putting DBS in the brain. Pallidotomies, thalamotomies, it's all required in low economy countries like us, even in places where patients cannot afford or too far away logistically. So this is an Asia level program headed by Professor Takuo Metaira from Tokyo Women's Japan. So I'm a student, so we are doing it here. So I invite all of you who are interested in stereotactic lesioning to be in May, book your tickets and book your seats there. Thank you very much.
So now we are at the end of all the lectures. I learned a lot. It would be best idea to join together, have a sitting together in a great round and discuss mutually. But there are certainly questions from the audience. Any questions? Whoever wants to speak, address to which talk. Maybe I take the freedom of asking the last speaker, what would you have done differently as a excellent neurosurgeon or simple neurosurgeon if you would not have all your computer programs with you? Because if there's still some stenosis remaining, a simple-minded neurosurgeon would always say, well, I do additional decompression because they didn't do a good job. Can we have a microphone for him, please? Sure.
So the stenosis was very focal. It was a very short segment, so I was not really sure whether that was the only problem. But I've seen people with chronic, degenerative canal stenosis related. The spasticity doesn't change even if you decompress because there's the myelopathy. It's a myelopathy feature.
Sure.
So because of that, I didn't want to waste time because she's already doing that. So that's why I thought I should give it the benefit of both.
Perfect. Thank you. Any question from the rehabilitation people to the neurosurgeon or the other way around? From the audience, who would have a question? I can ask. I noted some questions. Yeah, please go. Can you turn on the microphone, please?
Can you hear me now?
Now it's better, yeah.
Yeah. Question for Dr. Jayan and for other surgeons also. Is doing blood alcohol concentration mandatory in all trauma patients in the country? Irrespective of history, is it mandatory to do blood alcohol concentration?
I think given the rates of TBI amongst people with substance use and vice versa, I think it would be indicated.
Is consent required? Like, can we check anyone's blood alcohol concentration without his or her consent? Because in traffic also, without consent, even traffic police cannot check your breath alcohol.
So I don't have a definitive answer for that, but I can tell you there is a definite clinical utility. So I don't know, we would draw bloods for other reasons, right, typically, and I don't think we take consent for say doing an LFT or an RFT or a hemogram. I don't know, but I think that there would be a clinical indication. There are, of course, medico-legal implications which are there of finding a positive blood alcohol. And so I think that's the reason why there's a bit of hesitation, but I would definitely look at, from a clinical standpoint, looking at doing a blood alcohol would be good. I would like other people's opinions about it.
Any further questions from the audience? You certainly, you're always very active.
Listen, as always.
Listen and ask.
Listening skills, I'm a neurologist, that's what I do for a day job, you see. Anyway, thank you for the session, Professor Max Miller, because I think it covered the gap of the morning where the rehabilitation needed to be highlighted. My first question is, can you hear me?
Yes.
The first question is for Abhishek, my friend, who invited me to come to this. You were stimulating the median nerve, and that was improving the outcome. So just can you explain to me what the underlying mechanism or the pathway you were trying to activate to ensure?
Yeah, so the right median nerve has a big representation of the hand area of the brain, of the left-sided cortex. That's the whole concept. So if you can do it for, all the studies are being done for 30 minutes per day. We are doing 8 hours per day for patients with GCS less than 9, and we'll publish it mostly next year, couple of years or so. So right median nerve, if you stimulate that area, that stimulates the hand area of the left dominant brain.
The maximum somatotropy you can get. Is that the principle?
Yes.
We confirm that with fMRI, BOLD studies or DTI studies.
So there are published literature of doing fMRI. What we are doing is EEG. We are doing coma recovery scale revised. We are doing GCS. We are doing GOS. To explain, do an fMRI in a hospital, but there are studies with fMRI to show it improves outcome.
So that's something we could take forward. The second,
and doesn't cost anything. Simple, which with each therapy department has a small device which costs 2,000 rupees, can be used for stimulation.
And then going into details, what's the frequency, amplitude, and from an EMG, from a nerve conduction perspective, what's the
50 hertz.
50 hertz stimulation.
50 hertz.
Not frequency and all. We'll find the paper and we'll get that one. Yeah. So the next question was to my second colleague, Professor Anupam Gupta. You showed us the excellent study with the paraplegics, spinal cord pathology, and the gait training. Two things, would you get the same results in cortical pathology, brain injury? Because aren't you stimulating a local spinal reflex in your mechanism? Because you said the hip was turned forward, and then the robot was doing the entire gait cycle on its own, and then at each, it was half the gait cycle it was showing, wasn't it? Because the patient had to voluntarily move the other hip forward.
And the movement, robot generates the movement.
Can you go into some details as to how much the machine was doing and how much it needs to be from the patient, and whether you get the same results from the brain?
Totally robotic. The spinal cord injury, the concept remains same. The central pattern generators are working. Even in the complete spinal patient, there is no connection with the brain. Central pattern generators in the lumbosacral cord are doing the tricks. Automatic walking is generated. That is the concept. But here the robot was inducing. You have to just simply tilt, so start the robot, and then robot will initiate steps for the patient.
Maybe I can just ask another question in this issue. You showed good examples when there was really improvement in walking. It's fascinating always to see those patients. when the patient gets home, how long is this effect so beneficial? How rapidly does it decline again?
We did not do the follow-up, and it's a very valid and pertinent question because most of the rehab modalities, the sustainability is the key million-dollar question. So we don't know the sustainability of it. But yes, the patient who was not able to do something, and of course, we did study with both the stroke and spinal cord injury patients. Stroke patients, we got follow-up. They were doing fine. That you would expect. Spinal cord injury patients, if they are not showing improvement in terms of their Asia C remaining Asia C, Asia D of course would be walking much better. So that long term we do not have, but this is with the caveat, like most of the other rehab modalities, we don't know the sustainability of it.
But would the patients come back for another treatment series to you or similar for median nerve stimulation or transcranial stimulation business? It always fades away the effect, but would they come back again? Would you have the financial or the possibilities to do so?
Most of the patients, especially with brain injuries, those who improve, they're able to sustain the improvement. Versus spinal cord injury, when they lose the mobility after going back, it's a valid, pertinent question. But cortical pathologies, if they improve, gain functional independence, they're able to maintain that level of function within community. Versus spinal cord, who are not improving neurologically, might need more booster doses with due course of time.
And how about the bladder improvement when you treat those patients? How would you rate the permanent benefit, or is also declining after a while when they do not get in again and again?
So we are very proactive when we are managing the bladder, and as you know that usually most of the recovery would come by the end of 6 months. But theoretically speaking and legally, we usually wait before certifying them at least a year or 1.5 years for brain injury. But we know that most of the recovery will come by the end of 6 months, more than 90%. And he will continue to have the same kind of status, neurological status or whatever bladder status he has. The only thing that worsens most of the time is when people have incomplete injuries, where the detrusor overactivity actually increases. And these are the big problem patients, where we will have most of them who have detrusor sphincter dyssynergy. And they are the people who are at risk of damaging at the upper tracts. And as I said, the problem is the hand dexterity. And the whole process of intermittent cath is very simple. It is not very costly also. I've seen people who use coconut oil. And initially, it's around, I think, 20-25 years back. And because they were not able to buy xylocaine jelly, it was too costly for them. So they started using coconut oil. And initially we thought that, okay, that's fine. But at some point of time when we started doing diagnostic cystoscopy for them, we found out that the urethral wall was getting more and more fibrotic because it was actually acting as an irritant for the urethral wall. So now we are trying, unfortunately now, our state is where we have free medicines and free treatments to all the citizens of Rajasthan. So now things have changed a bit, fortunately. So everybody has a xylocaine jelly to put in. And as far as the people who are with overactive bladder and DSD are concerned, we try to, and if they do not have dexterity of hand, I try to put a IDC. But the problem is, to convince is very difficult because then you have to explain that we have to put a catheter through your lower tummy into the bladder. And the moment you say that, most of them don't give consent on the first time. But over a period of time, I've seen that probably in their second or third follow-up, they'd get very convinced because it's very labor intensive for the caregivers. And then you have some sexual issues for the young people and hygiene issues. So once you convince them, because that's the thing, you have to communicate with them with all the symptoms and the benefits of the interventions that you're doing, and then they get convinced. So most of the patients are on CIC or IDC, and as the problem happens, we do have interventions for them, and most of the times we do botulinum intradetrusor for them.
One more question from our young psychiatry, Dr. Jayant. So kind of you to come and join the TBI. So are you doing any trials or studies on the effects of cognitive stimulation in TBI patients in our NIMHANS? Because Abhishek was talking about quite a few possibilities of having psychological and psychiatric inputs. What's your team doing?
Sorry, sir, nothing formally. I mean, we do have, I mean, obviously on a case-by-case basis, but we're not running any trials that I'm aware of. Sir, can maybe add?
Yeah, double sir, yeah.
Yeah. Yeah.
It's psychology.
Yeah.
So we have two modalities of neuropsychological rehabilitation. One is cognitive retraining and another is EEG neurofeedback training. So both are being offered to the patient and they have been formally studied and published as well. Yeah, results are good. So one question for Abhishek, what is your end point of terminating coma arousal therapy for vegetative state patients?
666. We call it 666. These patients should get 6 hours of therapy, 6 days a week for 6 weeks. And then you tell them they are changing or not changing. But if you see research, especially TBI, those who are unconscious at 6 months, 1 in 5 can be conscious at 1 year. We can stop at 6 weeks, but patients can still improve up to 1 year.
That is spontaneous recovery.
So we can't label them. So we can't label them PVS at 1 year in TBI, but we do for 6 weeks. Patients still want to stay beyond that. That is their wish. But we say we think now onward, if he is not change, he's not going to improve. So we call it 666.
Okay, gentlemen, we still have official. We are pushed already to leave the room, but we have still 5 minutes to go. So, you have given so excellent lectures. I would just ask you, how could, on a single, everyone should answer, how should we, or what would be the next steps to improve access of patients with spinal cord injury or traumatic brain injury to excellent neurorehabilitation as you presented? Because you see there's such a, one by one. So there's such a need in this business here in India. I've seen it in Pakistan similarly, and so it's always in many, many places. So what are your suggestions?
I think clinically assessing them, making sure your data is correctly captured in an organized way so that then you can run your algorithms on that and understand patterns of recovery and see the good patterns you follow, the long patterns you change. Unless we do that, it doesn't matter what gadget you come. If you don't have the fundamentals right, the brain is still an old-fashioned wired model. Even in Sundar Pichai of Google, if your son is weak in mathematics, he needs mathematics tuition. He cannot do anything else.
We should provide low-cost, accessible, multidisciplinary team rehab programs at every district level.
And how much would you include the family in the early rehabilitation phase?
In India, family is an integral part of it. We call it family-based rehab. Like in US or Western world, we have community-based rehab. In India, post-discharge is family-based rehab.
Awareness among general public, and more importantly among our colleagues, the glorified surgeons and other guys who believe they operate the patient, treat their stroke, diabetes, hypertension, stabilize, kasrat kar lena ghar jakar, just do the exercise. So that is probably the whole crux of rehabilitation. So that kind of mindset needs to change from public, but more importantly from our viewpoint, from fraternity, medical fraternity.
I fully agree with what Dr. Anupam has said, because most of the, I'm sorry to say this, but most of the neurosurgeons and neurologists in this country or in this state are practicing neurophysiotherapy. They are not practicing neuro rehab. They get the patient and they directly refer it to the physiotherapist. And you know the level of the physiotherapy, level of knowledge, level of skills they have. And by the time, sometimes there are only few patients who will reach to a rehab expert, and by the time they reach, nothing can be done. So
maybe I can just add to this one, because I discussed with some of these very famous neurosurgeons in India, but also similar abroad, when they say we are doing such a good surgery that our patients don't, I quote, I don't want to say we are doing such an excellent surgery, the patient never would require any kind of additional. Oh, it's so important to remind. Also, the best surgeons I had operated on huge meningiomas. MRIs can look perfectly well, and it took 1 year, 2 years maybe before the lady really recovered to her pre-tumorous level. So we have to work to understand this. We do not treat the tumor. We know spinal cord injury. We treat the patient with and the family with. So sorry, I didn't want to stop you from talking.
Thank you so much. So I would say instituting screening, brief intervention, and referral for treatment. It's an established model for intervening for alcohol, drug use problems, and I think it would have a long and a big public health impact in being able to reduce morbidity related to TBI.
So how much alcohol would you allow for an average person?
I'm going to be politically correct, notwithstanding what's going to happen today evening. There's no safe level of alcohol.
Okay, so what I'll do is I'll just share my experience. I started in rehab in 1994, and I think it's networking, understanding all the consultants, if they understand each other, and then if we work together, I think we can do that. What our model is, we are in level 3 trauma center, and we have our colleagues here from the neurosurgery also. So I'll tell you how we work. So as soon as the patient comes in trauma, he is overlooked. He is looked by 3 people. He is seen by orthopedic surgeon, a neurosurgeon, and a rehab specialist. And we decide there in the trauma what is going to happen to that patient. So if it's a surgery, it is to be done for the spine or brain, he gets shifted to the neurosurgery. If it's a conservative management, it comes to us. If it's a peripheral injury, a long bone injury, he has to go to orthopedic if it's a priority, or long bone fracture. And usually, most of the times, the neurosurgeons are very happy to transfer patients to our side as soon as they operate it. And we are very happy with that, because once they fix it, we can make them sit and get into rehab very fast. And this has taken a lot of time. We started our department in 1974, and next month we are going to finish 50 years of our center. So it has taken a lot of efforts, and I think it's stopped. So it has taken a lot of efforts, a lot of networking, a lot of working together. And I think at this point of time, we can say it has to be an understanding and networking between different specialties where we can work together. Most of the time what happens is that there is a fear that maybe neurologist is taking my patient, and the rehab person thinks that neurologist is taking my patient. So we have to actually grow beyond that. We have to work. It happens in private practice, and that's the truth of it. And at the end of the day, we have to understand, we have to work for the patient. And once we are able to have that ethical and moral clearance in our mind, I don't think anything is unachievable.
Excellent comment, because I have also seen the other way around, that the neurorehabilitationist think the neurosurgeon will send the patient to rehabilitation when he has taken out all the money. But
that's what I'm telling you, it never stops.
Okay, so, but the lady has a final question or comment.
No, it's not a question, it's a comment.
Perfect.
The thing is, most of our cases after surgery, if they require neurorehabilitation, we refer. But the number of beds which are available for neurorehab are not commensurate with the numbers we operate. The number of surgeries are much more. Okay, and we need to discharge the patient also in order to admit the next batch of this thing. It is like a rolling band, you know. One batch comes in, you operate, and then if they don't find the bed in the rehab, they have to go. That's all. It's not as though the surgeons are arrogant or they're not aware of rehabilitation. I think many of us are much more aware of rehabilitation rather than anything else. This is number one. Number two, about the alcohol. I don't think it is going to be decided in any of these conferences like this. This number 2 paper which came in BMJ, and it has got the highest number of viewers, reads, etc. Is that as long as alcohol exists, the accidents will happen. Okay, there is no way you can prevent it. The most important thing about neurotrauma is whether it is traumatic brain injury or spinal cord injury is prevention. Prevention is the best form. After all that, only all these surgeries and rehabilitations and remodulations and blah, blah, blah will come.
That's totally
By the way,
correct.
I'm a neurosurgeon, sir, and a practicing one till recently.
I remember I was invited once about 10 years ago to a neurotrauma meeting in Himalaya, and there was one of the secretaries of state saying, well, you neurosurgeons are doing such an excellent job saving so many patients. And so the neurosurgeon would tell the secretary, you could do a much better job if you would really give good rules which should be obeyed by the public.
Yeah.
You would be much better.
And then, by the way, this WHO in January 2021 had declared that alcohol in any amount is toxic to the system, including causing carcinogenesis of various kinds. Forget about substance abuse and dependence and traumatic brain injury. They're all actually minor issues. People don't understand that.
Can I just end that with the first question that you asked was, we are a public hospital and we have around, I think we are one of the biggest rehab hospitals in India. And the thing is what you're talking about, the rolling beds, we had the same kind of problem, and I don't remember that paper now. It was published in Germany. So there were a lot of patients were there, and then how to manage these fast rolling patients. And then I learned from that German study where you basically divide these patients into short goals and long goals. So once you admit patient, you make them sensitive, you do a rehab for 15 days and see what happens. You have to decide. You have to triage them as you have in trauma. And then you send them back home. Maybe they will recover, and we call them after a couple of weeks. So that's the rolling model that we follow. It's a German model. It's an old German model, 70s model. So we can do it if you want it.
So you're welcome to come back to Germany. Huh? Okay. Thanks for the interest. Thank you.
Again, now we are moving towards our last session of the day, and I welcome Dr. Fitra for chairing the session. He is from Indonesia, and he has done fellowship in vascular and vascular neurosurgery, and currently working as assistant professor in Indonesia. Welcome, Dr. Fitra.
Thank you. Thank you very much. Good morning, college. Good afternoon, college. I am Fitra from Indonesia, and it's my privilege to welcome you to the pre-paper session of this conference, ICRAN 2024. As the chairperson of this session, I'm thrilled to see so many experts, so many colleagues gather here today. So we have 5 presenter speaker who will present about 10 minutes, right? 10 minutes, and we will have discussion after the talks. Oh, 7 minutes. Okay, sorry, 7 minutes. So I will call the first speaker, Dr. Zia Maula Fadullah. The time is yours.
Good afternoon, ladies and gentlemen. Hello, namaste. My name is Zia Maula Fadullah. I'm from Indonesia. I'm the resident of the Faculty of Medicine Universitas Airlangga, and also in Department of Neurosurgery, Dr. Sutomo General Teaching Hospital. First of all, I would like to give a gratitude and thanks for my teachers, Dr. Teddy Apriawan, Dr. Rohadi, also my colleague, Dr. Hilman. So in this afternoon, I would like to present my experience in Indonesia and about the updates in decompressive craniectomy for severe traumatic brain injury and outcome analysis of early versus late decompression in Indonesia. So, as we know, the decompressive craniectomy for traumatic brain injury remains an area of considerably controversy despite a large number of studies having been done. DC in TBI could significantly lower ICP and reduce mortality rate, but was associated with more complications. In one study, early decompressive surgery within less than 3-6 hours result in improved outcomes in Glasgow outcome scales in evaluation in 6 months. So this is Indonesia. This is my hospital with the population about the 40 millions in inhabitants. But in a total, patient with a traumatic brain injury calculated about 30 until 40% in a year. So what's the problem? There is no consensus what's the best time to conduct the decompressive craniectomy. And what's the challenge? In Indonesia, early decompression is still preferred due to a lot of variables, and then the intraoperative surgical technique is critical in attaining appropriate decompression during craniectomy. These are the population methods and my samples. So I studied the retrospective study from the medical records from my hospital from January to June 2023. In a total, I get 40 patients with a severe traumatic brain injury, and I analyze with and extract the data such as age, diagnosis, and time of surgery, and also we evaluate the Glasgow outcome scales. These are the results. I got 40 patients with the severe traumatic brain injury. 7 or about 17% patients received a late decompressions, while 33 and about 83% underwent the early decompressions. These are the charts. You can see in the pie chart in the right side. It's Glasgow outcome scales in late decompressions. There is about 28% with GOS score 1 with disease patients, and also with the early decompressions. There is 43%. There is also a big difference between the late and the early decompressions. But the main thing, as we know, you can see in the right chart. In early decompression, with the GOS score 4 until 5, there is a 45%. Compared with the late decompressions, there is only 29% in the total with the good rehabilitation after decompressive craniectomy. That's why it is the main discussion about the early and versus late decompressions. So diffuse mind damage the cerebral tissue as a result trauma and subsequent increase in intracranial pressure cause significant neurological deteriorations. And post-operative results are more satisfactory in patients who underwent decompressive craniectomy and earlier stage of treatment. DC can improve the mortality rate, but also didn't prevent the severe handicap, including the vegetative state. And the available adequate neurosurgical care doesn't match the burden of neurological disease. So this will result in the less and then optimal neurosurgical services. These are the complications that I meet. In early DC, most of all, from the DC early decompressive craniectomy, we can see the complication about the central nervous system, even such as ICP elevation and seizure is predominated, and followed by the electrolytes and respiratory distress. These are the charts about the acute complication and late complication with decompressive craniectomy. We can see the ultra early, and then early, delayed until the late complication with the bone resorption, osteomyelitis, and also hypovascular bone necrosis, the complications. So the conclusion and the suggestions: early decompressive surgery offers a favorable outcome in patients with the severe traumatic brain injury. This based on our data, because I think the many variables that can make the patients also go to the severe complications. And there is needs more research, more specific variables and bigger data, and also the bigger population about early and late decompressions. And we can strive towards optimizing patient outcome and fostering a pathway towards recovery in this vulnerable patient population. So these are my hospital. This is our ICU. This is our hospital operating theater, and then there is an emergency room. These are our services in Dr. Stumo Hospital, neuroscopy, endovascular, stereotactic surgery, OX surgery, and also microsurgery. And this is my beautiful city and Surabaya. And thank you so much for your attention.
Thank you very much, Dr. Zia. I would like to invite Dr. Hilman Suhaili from Indonesia for the next speech.
I'm sorry. Is that the KB function, right? Sorry. I'm sorry to this mistake. Good afternoon, ladies and gentlemen. My name is Hilman Suhaili. I'm a resident of Neurosurgery Department, Airlangga University Faculty of Medicine, Dr. Sutomo General Academic Hospital, Surabaya, Indonesia. I would like to express my sincere gratitude to our teacher, Dr. Teddy Apriawan, and Dr. Rohadi Muhammad Roshidi, and our colleagues, Dr. Fitra and Dr. Zia, for their support for this presentation. And today I'm going to present about my case series. Title is Intraoperative Acrylic Cranioplasty. Is it good enough for cosmetic purpose? Cranioplasty is a surgical procedure to correct skull defect both cosmetically and functionally. This procedure is thought to provide relief for physiological vulnerability and improve social performance. Cranioplasty is performed mostly after traumatic injury. However, cranioplasty is also needed in traumatic case series, such as a tumor that causes bone inversion and hyperostosis. Along with the development of biomedical technology, there are many types of material and techniques available that can be used in cranioplasty. Acrylic is one of the allograft material which has been around for a long time and is commonly used in cranioplasty. The problem is acrylic has advantages and disadvantages as a cranioplasty material. Acrylic is an affordable material, easy to obtain, and can be performed pre or intraoperatively with uncomplicated technique by molding directly into the defect area. Acrylic has several disadvantages as a cranioplasty material. Although rare, acrylic can be an allergen in certain fashion and can cause an exothermic reaction. The question is it good enough for cosmetic purpose? We are report 3 clinical cases in our hospital were replaced with intraoperatively molded acrylic cranioplasty. We attempted to analyze the use of this material in cranioplasty, mainly from a cosmetic and aesthetic point of view. Case 1, 55 years old woman with a lump on the left head for the last 5 years, and on CT scan of the head, we find hyperostosis in the left side of skull, and we perform craniectomy tumor excision followed acrylic cranioplasty. And the second one, 31 years old woman had a lump on the left side of the head for the last 6 months. The patient was diagnosed with an flak meningioma and underwent craniectomy tumor excision. And the last, 45 years old woman with headache accompanied by blurred vision in the right eye. The patient was diagnosed with a right side of spino-orbital meningioma. The patient underwent tumor excision, craniotomy, and decompression. Cranioplasty was not done immediately because during the procedure, brain edema was found. And the outcome and follow-up in this study, all the patients saw improvement in their condition and were discharged without additional complaint, and to provide relief for physiological vulnerability and improve social performance. And this result, in case 1, the patient came to for follow-up examination without any complaints with a remarkable head curvature improvement. No defect or no sign of infection were found on physical examination. From 3D CT evaluation showed discontinuity on calvaria bone, suggesting previous cranioplasty procedure. In case 2, on follow-up examination, the patient had no complaints with the surgical wound looking dry without any adhesions, like asymmetry in the temporal area was seen. In the case 3, on the next outpatient appointment, the patient came without complaints. However, at the surgical site, the skin was hyperpigmented with sunken area. From the 3D CT evaluation, saw the skull defect at the bedside of temporal base. And a study by El Mohandes et al. In 2015 state that acrylic provides good cosmetic result as a cranioplasty material. This is in line with the case 1, where clinically remarkable improvements in head contour were seen. Radiological examination saw a gapless implant with the adequately fixed mini plate. And the curing process, the use of acrylic can cause an exothermic reaction. This reaction occurs when there is thermal damage from the contact between the acrylic and the underlying tissues below. However, this can be avoided by providing an insulating base and adequate irrigation of the acrylic. In our center, we use gauze as a base and soak the hardened implant in normal saline. Prefabricated implants can be an alternative to improve patient cosmetic result. The freehand molding process on the skull defect tends to be tricky. The intact inner table will be the support of implant from the bottom and at the same time reduce the possibility of gap forming between the cranial edge and the implant. This can also be a solution avoiding the dents in patient. However, custom implants are expensive. It's not easy to obtain in low income countries. It is necessary to maximize on the result of what is available. One of the pitfalls using acrylic and ensuring good contouring of the implant itself. In intraoperatively molded cranioplasty, acrylic is malleable material. However, the final result obtained will depend on the dexterity of each operator. In case 2, a slight asymmetry in the temporal area was seen. This may occur because the molding process was carried out in area that has undergone total resection underneath. Adequate head wrapping installation can maximize the patient wound healing process. This is important to ensure that the patient has good blood flow and does not procedure additional blood collection within the scalp. Education for patient to maintain nutrition and hygiene while at home is very important in accelerating the wound healing process. And the learning point is one, acrylic is a reasonable choice to produce good cosmetic and aesthetic outcome, a cranioplasty material. And two, the threat of pitfall must be anticipated in every phase of cranioplasty. And the third, further techniques should be explored as an attempt to increase patient cosmetic satisfaction. Thank you.
Very interesting speech from the Dr. Hilman. So I would like to call Dr. Ashish Moore from Kota.
Good afternoon, good evening, everybody. Myself, Dr. Ashish Moore. I'm presently a senior resident at Government Medical College and Hospital, Kota. The topic for my talk today is incidence and prognosis of pre-existing aneurysms presented as traumatic subarachnoid hemorrhages. No disclosures. So subarachnoid hemorrhage is a very common entity. We all deal with it on day-to-day basis in trauma ward. Incidence is very high. It ranges from 15 to 40% in different studies in cases of head injuries. Well, the relationship and important aspect is differentiating the origin, whether the trauma, whether the origin of the SAH is traumatic or it's spontaneous in nature. Incidence, there are many studies which focuses on the incidence between formation of traumatic aneurysms. But there is a very less literature on this aneurysm and for pre-existing aneurysm. This creates the need for the study. The relationship, we searched the net on PubMed and Google Scholar using the keywords pre-existing aneurysms and subarachnoid hemorrhage. We didn't find much of a literature. So most of the time diagnosis is challenging, whether the rupture is because of the trauma or it's the trauma which follows the SAH. History is most important because most of the time the history is very dubious and we didn't find any witness on the spot. So most of the time patients are found unconscious. Though there are certain findings on the CT which can differentiate between spontaneous and aneurysmal rupture, such as SAH with IVH and ICHs are most often associated with SAHs, spontaneous rupture of aneurysms, but they are not definitive. Other findings are that major bony or cisternal injuries, cisternal SAHs are associated with aneurysmal spontaneous rupture of the aneurysm. So detailed history is very important. So aim of our study is to find the incidence and prognosis of aneurysms, pre-existing aneurysms presented as traumatic brain injuries. We examined 40 patients from September of 2023 to February of 2024. Patient age ranges from 15 to 70%. Mean age is 45.88 years. We also divided the patient on the basis of the following parameters: age, sex, and also on the basis of the risk factors which are involved in the formation of aneurysms. We included the patient on presented within the 48 hours of the injury and excluded the delayed presentation. Like in the morning sessions, they also discussed by Dr. Reisner that most of the delayed presentations are traumatic formation of the aneurysms. So we excluded those delayed presentation cases. We find that 8% of our study, 4 patients out of 40 have harbored aneurysms, which is also the case by Cummings and all. They find 8% in their study. Interestingly, most of the aneurysm patients fall into the group of mild category of GCS, that is 13 to 15, and other cases with no aneurysms are scattered all around the And major risk factors, we find that most of the patients are with major non-risk factors of aneurysmal formations. 3 out of 4 are smokers, 2 out of 4 are non-hypertensives, and 2 are chronic alcoholics. And also, aneurysmal patients are on CT. We find that patients with aneurysms are at basal and Sylvian Fisher SHs, versus surface SAHs are found in other patients with no aneurysms. So results of our study concluded that there are patients which can present as SAH harboring an aneurysm. So we must take a detailed history, whether the other risk factors and hypertension and other known risk factors for the aneurysmal formations are there or not. And on CT, we must find the cisternal versus surface SAHs. CT angiography must be thought of in every cases with SAH, whether it's early presentation or delayed presentation. This is the picture of our institutions. Thank you.
Thank you, Dr. Ashish Moore. I would like to invite Dr. Mihika Sinha from Jaipur.
Good evening, one and all. I'll be giving an endoscopic CSF leak repair topic, and it's more of an extracranial and endoscopic viewpoint, and not a study per se. So CSF rhinorrhea is a direct communication between the subarachnoid space, which is CSF rich, and the mucosalized paranasal sinuses like shown here. So most of them are traumatic, so either due to head injuries or iatrogenic post-surgical, or in non-traumatic cases, we can have benign intracranial hypertension cases, congenital anomalies, skull-base neoplasms, and even skull-base osteomyelitis. You can see here a small meningocele here with an active CSF leak repair, a CSF leak there with that suction place there. So a unilateral clear nasal discharge with a very characteristic salty and metallic taste in the back of the throat, maybe with a prior history of surgery or trauma, should raise a very high suspicion of CSF rhinorrhea. So I would put the diagnostic testing into two processes. One is an actual documentation of what is leaking is CSF or not. That's the first step. And step two is tracing the position of the skull-base defect through which the CSF is draining. So for point number one, we can have beta-2 transferrin with excellent sensitivity. Also can go ahead with glucose testing and diagnostic nasal endoscopy to actually see the defect and the active CSF leak. For radiological investigations, we have HRCT and CT cisternography, which gives a very excellent anatomy of the bones, the skull-base defects, and the post-operative bony anatomy. We can also go for MRI cisternography for soft tissue attenuation, and also when you're suspecting a meningoencephalocele. Intrathecal fluorescence can also be given intrathecally, and then do an endoscopy and see for the fluorescent dye after 30 minutes. You can see this rarefaction of the sphenoid in the MRI of the cisternography over here. So the management first is, for the first 2 to 4 weeks, go for a conservative management. Around 70 to 80% will heal spontaneously. Patient information in form of bed rest, a 45-degree elevation, start on Diamox, laxatives, and tell the patient to avoid sneezing, heavy lifting, and straining. Now, the principles for management of CSF leak are essentially identifying the site of the leak, which we just spoke about, determining the optical surgical corridor, whether it has to be a transethmoidal, transsphenoid, or paraseptal olfactory, a wide exposure including and addressing the adjacent sinuses, open them up, and a meticulous preparation of the graft bed. Also take out 5 mm of the mucosa around the defect size to prevent future mucoseals, and multi-layer closure whenever possible. So for graft materials, you can go from varied things from mucosa, cartilage, bone, a single incision from the anterolateral part of the thigh. You can take out fascia lata and fat both. And also the very famous Hadad flaps, which is based on sphenopalatine artery and inferior turbinate and the middle turbinate flaps. So the grafting technique in traumatic cases can be single layer. In spontaneous cases, because they are notorious to come back, you should probably go for a multi-layer repair. And for large multiple defects, go for vascularized flaps. So endoscopic techniques are multiple. So there's a bath plug technique, which is basically putting a suture in the entire plug of fat, placing it inside the defect, and then making a tight seal. This is reserved for huge defects. Whereas an overlay technique, you just close the defect on the skull base. You don't exactly enter the cranial cavity like shown. In underlay techniques, you put the graft inside the cranial cavity in the subdural or the epidural space. There are a lot of studies done which show that there is no superiority of any technique per se. So you can see here there's a placement of fat inside the defect, and this is how an ideal multi-layer closure would look like. Fat around 50% inside, 50 outside, with fascia lata, Sergi-cell, followed by Hadad flap, and a fibrin sealant like you can see in the last picture to close it all off. Now, just a comprehensive management strategy of all causes, a traumatic etiology, go for conservative management, wait for spontaneous closure, doesn't resolve, you go for an operative repair. In intraoperative injury, if you have caused any during head injuries or during your intraoperative repairs, FES, identify, tell your anesthesiologist to give positive pressure ventilation and make a watertight seal on table. And for non-traumatic leaks, go for conservative, take care of the neoplasms and hydrocephalus if they're associated, and go for an operative repair. I think post-operative care is as important as the operative technique. Strict bed rest for 2 weeks, prophylactic antibiotics, would recommend ceftriaxone with very good CSF penetration, cough suppressants, Diamox, antihistamines, and the nasal pack could be removed after 5 to 7 days, probably endoscopically guided. You can see for the graft side, you can see if it's been well taken up. You can also suction and you can clean up the space before sending the patient off. So to conclude, there's an accurate identification of defect required with a radiological correlation to identify the defect size and the site. The basic principle is identification of the leak site, preparation of the recipient bed, and accurate placement of graft with very nice post-operative care. Thank you.
Thank you, Dr. Mihika Sinha. I would like to invite the last speaker, Dr. Abhishek Shukla.
Good afternoon, everyone. Dr. Abhishek Shukla from SGPGI Lucknow, presenting today a topic on thoracolumbar junction fractures commonly encountered and study on inclusion of index level fixation versus long segment pedicle fixation. So the thoracolumbar region is one of the most important biomechanical transition zone in which rigid thoracic kyphosis and flexible lumbar lordosis meet. Almost 60 to 70% of traumatic spinal fractures are related to the thoracolumbar region, which ranges from T11 to L2. The surgical management of TL burst fractures is commonly done by posterior pedicle screw fixation. And the basic mechanism and the aim is to restore the vertebral body height, correct the kyphotic deformity, and restore the spinal stability and indirectly decompress the spinal canal. In spite of all this, the controversy still exists regarding the short versus the long segment pedicle screw fixation. The posterior long segment fixation, that is the traditional 8-screw construct 2 level above and 2 level below, is the conventional surgical technique followed for TL fractures. And the effect of including 2 intermediate pedicle screws at the fractured level, that is the 6-screw construct, is still a matter of debate. So the aim of this study was to compare the outcome of the short segment fixation with inclusion of the index or the fracture level versus the traditional long segment fixation for the treatment of the unstable TL junction fractures. From November 2018 to April 2020, we included 60 patients with unstable TL junction fractures, which were operated at Apex Trauma Center, SGPGI Lucknow, and they were studied retrospectively by dividing into two groups according to the level of the instrumentation. So the group 1 included 30 patients with index level screw fixation, and group 2 included junctional fractures without involving the index level. We looked for local kyphosis angle, anterior body height, loss of vertebral body height, ACI impairment scale, and VAS score and ODI scores. Operative time, intraoperative blood loss, operative cost, and surgical complications with implant failures were also recorded. The inclusion criteria was the thoracolumbar spine instability, including wedge fractures or the burst fractures with TL injury classification, and 4 or more than 4 were included, and the single level fractures were only the single level fracture was included. The exclusion criteria was the corpectomy and the anterior cage fixation, previous instrumentation at the same level, patient with documented osteoporosis were all excluded. The technique was the posterior approach to the spine, and the wound incision and exposure of the lamina and the facet technique was same in both short and long segment approaches, but they differ in the length and the number of the lamina exposed. In this short segment approach, after the exposure of the lamina and the facet of the index level with one level above and one level below, the transpedicular screws were inserted under the CM guidance, and laminectomy was done further to decompress the canal, and posterolateral fusion was done with bone graft. In long segment approach, the exposure was in the similar manner with 2 level above and 2 level below exposure with transpedicular screw fixation under CM guidance, and further laminectomy and the lateral fusion had been done. All the data was analyzed on SPSS, and the comparative tests were performed between the first year values and baseline measurements. So results were as expected. Male proportion was more than the female, and the highest incidence of TL vertebral fracture was at the level of the L1, followed by L2 and then D12, and least incidence was at D11 and D10. The type of fractures were variable. 30 patients presented with burst fracture, 20 with wedge fractures, 7 were hyperextension fracture, and 3 were of the shear fracture. Most of the burst and the wedge fractures were due to falling from a height, while most of the hyperextension and shear fractures were due to RTAs. This is the Asia grading scale, which we all are well aware of. Won't go into the details. This is the neurological status in the pre-operative and the post-operative period with the comparison of the index level fixation and the long segment fixation. There's not much of a difference between both the groups. The angle of correction, there was no superiority of the long segment over the short segment stabilization, with index level stabilization as regards the correction of kyphotic angle and maintaining the sagittal plane till fusion. Interestingly, the post-operative anterior vertebral height was significantly better in short segment group versus the long segment group. This is post-operative 1 year follow-up of the same patient with the correction of the kyphotic angle. The pain, the short segment group had less pain as expected in immediate post-operative evaluation than long segment group, in whom more anesthesia was needed. And both the groups had almost similar VAS scores. The ODI score were almost similar in both the groups. There was no statistical difference between both the groups after 1 year follow-up. And the duration of the operation was almost similar in both the groups. And short segment group seemed to be needing less time on surgery, and there was no statistical difference between both the groups. Intraoperative blood loss was similar in both the groups, and outflow of the hematocele within the fracture vertebral body was less in the index short segment fixation. Operative cost was obviously more in the long segment fixation group, and hospital stay and medications were similar in both the groups. The complication, 3 patients in the short segment groups had complications of CSF leak. 2 patients had superficial wound infection, and all of them were treated conservatively. 4 patients in a long segment group had superficial wound infection, one of them who needed debridement and resuturing. These are the various literature which had already compared the short segment versus the long segment fixation, taking the posterior transperpendicular approach. We'll just conclude my discussion. The study limitations of my study was 1 year follow-up period, which is comparatively a short period, and many patients with multi-level fractures were not included in this study. And to conclude, the inclusion of the fracture level in the short segment fixation for a TL junction fracture results in kyphosis correction and maintenance of sagittal alignment, similar to long segment instrumentation. However, this technique allows us to save two segments of vertebral motion with lesser financial burden to the patient. Thank you.
Thank you very much, Dr. Abhishek Shukla. That is the last speaker, so we will have a discussion session, 10 minutes. Is there any question or comments? Yeah, please, Dr. Rohadi. Before the question, I would like to invite all the speakers to come to the front of Yes, please, Dr. Rohadi.
Yeah, thank you. Well, Dr. Zia, I want to ask you about the take-home message for your study, because we know about the severe brain injury in Indonesia, or same with India, is complex, and stabilization is not so easy for we treat the patient. About your study, about the take-home message for your study.
Okay, thank you, Professor Rohadi, for the questions. The take-home message for the study is that early and versus late decompressions, Indonesia still there's a challenges, because there is a lot of limitations in our country, like neurocritical care facilities, and also the infections, the emerging infections in our country. It's also the limitations. So the take-home message is to expand more the study data, not only in Surabaya but also in a lot of center in Indonesia, and combine and get a result with which is the better between the early or late decompressions. Professor.
Thank you. Any opinion from our colleagues from India about the topic? Yeah, many cases in Indonesia is led to decompression, led to operation. Why? Because complex referral system, and I think maybe same with India. What your opinion?
Sir, do you all have considered doing cystonostomy along with decompressive cranectomy, or only decompressive cranectomy? Have you all encountered any experience with it?
Oh, okay.
We rarely do the cystonostomy.
Along with decompressive cranectomy?
Yeah, we instead do the decompressive cranectomy in Indonesia.
Yeah, but ideally in cystonostomy we have a complete facility, for example microscope in emergency, but some places in Indonesia cannot have microscopic in the emergency room. Usually in elective we cannot open the elective room to operate the cystonostomy, as usually in Indonesia is only large decompressive cranectomy as soon as possible, but some cases cannot rapid to referral to the hospital, but the late time. Okay. Second question for Dr. Hilman. In Indonesia, acrylic is mandatory, maybe is first choice for the skull defect. Some problem if we cannot, maybe for example system is not sterile, it's not good. some problem risk of high infection. I have any experience about that. Maybe what's your opinion about defend on your study?
Yes, thank you for Dr. Rohadi. I think we have to prepare more before we perform the cranioplasty first, because so many complications such as like infection maybe. But I think before the perform, we start prepare like material like acrylic cranioplasty, and during operation, we have to be ensure that all of equipment is sterile. Maybe I think it's the first one that we can do before doing perform cranioplasty. Maybe.
Okay, thank you very much. For Dr. Sinha, any criteria for your recruitment when you open with the endoscopy, when you conservative, when you only maybe sub lumbar drainage? Any criteria for your?
So, sir, I'm an ENT surgeon. So for us, I think less than 5 centimeter defects can be endoscopically treated. If they're multiple, I would probably refer to neurosurgical, because then it would need an intracranial intervention and not an extracranial one.
Not your joint with the neurosurgery?
Yeah.
Only
And,
ENT?
I'm a pure ENT surgeon. So I would probably go for a single less than 5 centimeter defect to be treated endoscopically, and then go for maybe a multi-layer closure for most cases.
Sometimes some cases cannot healing with endoscopy, but with open in the scars.
I think for multiple defects, there are some studies which shows that, especially for leaf-foot fractures, skull-based fractures, they can go for a combined approach with lesser morbidity and mortality. So yeah.
Okay. How about antibiotic? Broad spectrum or depend on swab after your?
I think just prophylactic broad-spectrum antibiotics can be started, especially pre-operatively. And it's a controversial question, because some people think that there is no role when especially comes to conservative treatments. But if you're operating, definitely, like I said, ceftriaxone 1.5 gram has to be started, has good CSF penetration, and then continue on oral antibiotics once the patient is discharged.
Okay, thank you, Dr. Sinha. The last question for Dr. Abhishek. I agree about your study, because I think same with Indonesia. If we choose a long segment, it's more expensive than the less segment. But some spine surgeon especially a neurosurgeon with specialist spine is think about because thoracolumbar is a bridge. It's not enough for the short segment. But in the study, in the meta-analysis, it's okay, it's similar. What are your opinion?
I didn't get your question, sir. What exactly you're asking? There was no statistical difference between the two groups, the long segment fixation and short segment fixation, apart from the cost and the operative time, for that matter.
Operative time and cost. I agree with you, because for our experience, our center, I maybe choice the short segment because of the not the expensive and not the more time for the operation. But depend on some spine surgeon have opinion, because we must long segment in the thoraco.
That is because of the junction you're talking, thoracolumbar junction. You need for the spine stability, you need 2 level above and 2 level below the fixation.
I agree with you.
But the results of both the groups are almost similar, sir. Maybe the shortcomings of my study was the short time of the follow-up, 1 year 1 year follow-up. Maybe like we are like the studies at present undergoing. Maybe 3 or 5 year follow-up will reveal more results.
Okay, depend on your study. How about the different age of the patient? Maybe young age is okay, but some old age is any complication.
Complications what we encountered in both the groups were of the surgical site infections. Only one patient in the long segment fixation needed surgical wound debridement. Apart from that, nothing else.
Okay. Okay, thank you. Very good.
There are two questions, but before I ask the question, I request chairperson to pass one message to the organizer that the youngster, they are coming far away from the Indonesia, from the Lucknow, and there are hardly 4 or 5 people sitting over here. Why? The same session can be merged with the other hall, or the simultaneous EC meeting is going on. EC meeting is secondary to this meeting. See, these people have made a very good papers. They have lots of enthusiasm. So you being a chairperson, I request you to pass my message to the organizer. Now, yeah. And see, the registration fee for the youngster also is not less than 16,000. I have paid 18,000, but the youngsters are paying 16,000.
I agree with you, sir. I agree with
lot of amount they are paying. Not only that, lot of the time they have spent for the preparation of this papers.
Yeah.
Now the question, coming to the question to the madam, do you use lumbar drain?
So in high leak cases, when it's a big defect, then we would prefer to put a lumbar drain, clamp it after 24 hours, and then remove it based on the drainage. So
Otherwise, in all of your cases, you never use.
if it's a very small meningocele or a very small defect, which is we are very sure it's a tight seal, then we do not put lumbar drain in all cases.
Once you put, then you keep it for how many days? Suppose if you put.
Lumbar drain around, I've seen the maximum being put for around 4 days. So, and then we remove it.
Normally you don't put it.
No, if a very small defect, no.
Fine, thank you. Now coming to the use of acrylic. Have you come across the use of acrylic in spinal fusion?
Spinal fusion.
Interbody fusion of the cervical spine, for example.
Yes. Kyphoplasty.
Even after discectomy also. Yeah.
Yes.
So it can be used. That's what I'm saying.
Cranioplasty.
Yeah.
Ini
Not cranioplasty. I'm asking about the spine.
For the spine, cranioplasty
Use
for the
of
spine,
acrylic
kyphosis.
or interbody fusion.
Pertanyaan?
We have used with very good result. Yeah. Yes. Like cranial. Like cranial. Like cranial. Yeah. Particularly here. Thank you.
Okay. Thank you, sir. Before we finish this session, I would like to ask my question too for the Miss Dr. Sinha. You use the ceftriaxone, right? For
Yes.
Yeah. And you use antibiotic prophylaxis in the for conservative management. So for how long you use the antibiotics?
2 weeks.
2 weeks.
Yes.
Oh, so you use ceftriaxone for 2 weeks.
No, that is only for the stay, so around 7 days. And then after that, when the patient is going home on the 8th day, then for 2 weeks, oral antibiotics conversion.
Oh, okay. Thank you very much. And for the Dr. Sukla, in my country, we usually use the 0-degree rod for the thoracolumbar junction. So only 0 rod. It's a straight rod, no degree.
Okay.
Fixation. And I see in your first presentation, you use the strike rod, and another is with the angle. So how you determine this angle?
Okay, this is we decide intraoperatively. Like if you are asking for the kyphotic deformity correction, how we bend the rods, or
yeah, because you use the rod, right? The fixation.
yes,
So,
yes, sir.
So
No,
how
you're
do
saying that you already get it like before pre-operatively you get it done, or we do it intraoperatively according to the CM guidance. As per the level of deformity, we bend the rod intraoperatively only.
Oh.
We don't get it pre-operative.
Okay, thank you, Dr. Sukla. So please give applause to our. Okay, we'll take a photo.